Safdarjung Hospital, another from CMC Vellore, another from BHU Varanasi. These are reputed colleges. And as you can see in this table on the right, you have NDMs, oxas, and combination of NDM oxas causing carbapenem's resistance. This last study came recently in July of 2020. It was the Atlas study. It looked at multi-centers. So I showed you single center studies. These are multi-center, 9 Indian sites, close to around 400 organisms. The commonest organism was Klebsiella. They could identify 40% bugs which were resistant to carbapenems. Now they looked at what was the distribution of the carbapenemases in these CREs, and you can see that most of them were NDMs and oxas. But what was very important was bugs can secrete more than one carbapenemases. So combination of beta-lactamases was the norm. Very importantly, if you look at the susceptibilities for CREs in our country, only colistin showed 90% susceptibility. Resistance was seen across the board, not only to the older drugs like amikacin, but to tigecycline and the newer drugs like ceftazidime, avibactam, clearly showing that the resistance is increasing. So from the last few slides, what have we summarized? Carbapenem resistance in Enterobacterialis is primarily mediated by beta-lactamase enzymes. NDM and oxas are the commonest. It is common across the country. Co-production is common, and polymyxins probably are the best bet to treat CREs in our country. Which brings us to how do you manage these bugs in our hospital. So before we go on, these are some of the principles which we follow to treat XDR infections in our ICU. And the most important is one on the top. We need to differentiate between colonization and infection. And the second bit is we usually resort to combination therapies. Monotherapies are not commonly used to treat XDR bugs. So this is possibly the largest list of drugs which are available to us to treat CREs. And I'm going to highlight just a few of them, show you some studies, and come to some conclusions as what is the best option for CRE in today's world. So this is polymyxins. It is our workhorse antibiotic. We are using it right, left, and center. It has several benefits. It is inherently resistant to gram-positive, most anaerobes. It doesn't work against Burke, Serratia, and Morganella. It is a good drug against gram-negatives, whether it is Enterobacterialis, Acinetobacter, or Pseudomonas. It is effective against all carbapenemases in most case scenarios. That is why it has become a drug of choice for us. However, polymyxins are associated with several problems. First and foremost, they have to be used in combinations, and there are several reasons for that. Firstly, for the respiratory tract, penetration into the lung for polymyxins is not great. If you have augmented renal clearance, your therapeutic levels might not be achieved. Presence of heteroresistance is common with polymyxins, and if the MIC is high, monotherapy will not work. And hence, whenever we use polymyxins, it is recommended we always use it in combination. So this was, say, 5 years back, and this was the guideline in 2019. It was an expert consensus where for carbapenem-resistant Enterobacterialis, polymyxin was the primary drug, and you could add other drugs. It could be tigecyclines, carbapenems, phosphomycins to polymyxins and form a regimen. Not only that, for CNS and for lung, you had to use intrathecal and inhaled polymyxins because the level of polymyxins in these two organs doesn't reach therapeutic levels. And hence, it was a difficult drug to work with. There are other challenges with polymyxins, and these are microbiological challenges and clinical challenges. First and foremost, what about the breakpoints of polymyxins? And you are microbiologist, I don't need to tell you this, but there are several limitations in susceptibility testing with polymyxin. First and foremost, the agar diffusion doesn't work. You need to use broth dilution. And there is absence of clinical efficacy data equating dose, MICs, and clinical outcome. The epidemiological cutoffs which had been given to us were these in 2019. However, CLSI came out with new data in 2019, clearly showing that there was no susceptible cutoff for polymyxins as far as Enterobacterialis go. What it means was now you can only give polymyxin as intermediate or resistance on the antibiogram. What it means in simple terms is that any patient given polymyxin, even if the MIC is less than 2, there is no assurance it will work in the patient. So we have to use polymyxins with a lot of caution in the ICU, even if you give us intermediate susceptibility. Particularly for the lung, the problem is even difficult. And I showed you VAP is the commonest nosocomial infection in our country. And when you can't have polymyxin penetration in the lung, it increases our problems manifold. And why is that? Basically, the surfactant in the lung can inactivate polymyxin. Polymyxin penetration in the lung is very low. When we resort to inhaled polymyxins for lung, we cannot achieve reliable therapeutic levels. And hence, using polymyxins for VAP is extremely challenging. So it is not recommended as the first choice of drug for VAPs or nosocomial pneumonia, which means that this nosocomial pneumonia is the commonest infection in my ICU. And for me, polymyxin is not a drug of choice. Makes my job extremely difficult. What about clinical cure rates with polymyxin? And this study came from South America, looked at around 200 patients with multi-drug resistant bugs, Klebsiella, Acinetobacter, and Pseudomonas. The failure rate was to the tune of 80% when you used polymyxin-based therapy. So survival is very poor for these groups of patients, even when you combine polymyxins with other drugs. Last but not the least, why is the problem with polymyxin? And this is a meta-analysis which just came out in 2022. And they looked at the incidence of polymyxin colistin resistance, which has come up in the world today. And as you can see, post 2020, the incidence of polymyxin resistance is on the rise, which clearly means that polymyxins should be avoided as far as possible. So what are the key points from the last few slides? Polymyxins are not ideal drugs for CREs. There is increasing resistance to polymyxin because of excessive use, and hence we need some novel therapies. And newer BLBLIs could be a possible solutions. So which are these new BLBLIs? The one which we have in our country, we don't have all of them. We just have one which is available from the newer BLBLIs. This is ceftazidime avibactam. And as you can see, as far as beta-lactamases go, it is effective against ESBLs, AMPCs, KPCs, and OXAs, but it is not effective against MBLs. So this is the combination. Avibactam is a novel beta-lactam which is attached to ceftazidime, and it increases the spectrum of ceftazidime. When you compare avibactam to clavulanic acid and tazobactam, the pre-existing beta-lactamases which we had, you can see it is a far more stronger anti-beta-lactamase as compared to clavulanic acid and tazobactam. However, there are still gaps. We'll not go there. But the conundrum is that in India, the dominant enzyme prevalent in our hospitals is MBL. Amongst them, NDM and OXA is the commonest enzyme. And ceftazidime avibactam basically does not work against NDM. Now, aztreonam is the only drug which is effective against MBL, but aztreonam gets resistance to CTX, ESBLs, and the common enzymes. So the issue was, if we combine ceftazidime avibactam, which is resistant to MBLs, with aztreonam, which is sensitive to MBLs, would it be a good combination? And that is the way we have solved this difficult problem of treating with CREs today. So this was one of the first studies which clearly shows that synergy between aztreonam and Cas-Avi on the microbiological diffusion, where you can clearly see the zone of inhibition for the combination is much better. And today, Cas-Avi plus aztreonam has become the drug of choice for treating CREs. Are there other beta-lactams available? There are a couple of options, and again, they are used as colistin sparers. One of them is ceftriaxone sulbactam EDTA. The EDTA here basically has multiple benefits. It sort of prevents zinc ion, it causes zinc ion chelation and hence is effective against MBLs. It reduces other mechanisms of resistance like efflux pump and disrupts biofilm and prevents transfer of plasmids. All this helps in improving resistance. Now, this was a study from India using ceftriaxone sulbactam EDTA microbiological data from almost 3,500 samples of gram-negative bugs. Now, I'm going to focus just on the phenotype of MBL. So they could look at phenotypes, they looked at ESBLs, MBLs, and a combination of ESBLs and MBLs. And as you can see, I'm not sure whether you can see it clearly, but ceftriaxone sulbactam EDTA was as good as colistin when you were looking at the phenotype of metallo-beta-lactamase producing organisms, clearly showing it could be a reasonable substitute. And this was a clinical study, again from India, showing the efficacy of ceftriaxone sulbactam EDTA in these resistant group of drugs. And it was at least as effective as colistin, and it could also be combined with colistin to get good results. What are the other drugs which are available? Tigecycline is one. It is effective against almost all beta lactamases apart from AMP-C. The problem with tigecycline is you cannot reach high therapeutic levels in the organs because it dissipates, it goes down in the blood levels very fast. So there is a black box warning that you should never use tigecycline as monotherapy, but tigecycline is a good drug to use as a part of a combination. And when using tigecycline, we as clinicians need to use higher dosages. There is another drug which will come into the market in the next few months, that is plasmomycin. This is a semi-synthetic new aminoglycoside. Apparently, it is effective against all beta lactamases, as you can see here, against ESBL, AMP-Cs, KPCs, OXAs, and also against some of the MBLs. It is better than the previous aminoglycosides like amikacin, and the chances of resistance to this aminoglycoside is apparently going to be low. So we have multiple combinations coming up which we can add to polymyxin or substitute. And CAF-AVI-aztreonam has become a drug of choice. And I'm not going to quote the IDSA guideline for management of CRE today. I'm going to quote the ICMR guideline. So it is Indian guideline, which is proven. And the first choice drug is a combination of ceftazidime avibactam with aztreonam. There are other options of combining polymyxins with other drugs like carbapenem, tigecycline, fosfomycin, and aminoglycoside. If that is when you are dealing with NDM, if you are dealing with OXA, simple ceftazidime avibactam is effective. If you are dealing with KPC, which is not prevalent in our country, again, a single drug is effective. So coming back to my case, this patient who was given meropenem was also added polymyxin when he worsened. 24 hours later, the blood cultures grew Klebsiella. Susceptibility testing showed sensitivity only to polymyxins and tigecycline. Now, to speed this process, we also asked for an expert carbar. Expert carbar showed OXA48, which means this bug was sensitive to ceftazidime avibactam. We switched down from polymyxins, de-escalated to ceftazidime avibactam, protecting his kidneys, giving him a better drug, ensuring better results. However, that was the problem. But we would not reach this problem if we could prevent it. And CDC has given us clear guidelines as to how to prevent this very difficult bug. And it includes basically combining skills from clinicians to you as microbiologists. And we hope that all of us together can ideally implement these strategies in our incidence of CREs. So this is my final slide. And to summarize, as I've already told you, CRE rates are progressively increasing. It carries high morbidity and mortality. Treatment options are very limited. Polymyxins till date have been the backbone of treatment. However, there is increasing data on the safety and efficacy of polymyxin use in the ICUs. Overuse has also led to increasing resistance, and hence we should start substituting new BLBLIs in the appropriate setting as a very good alternative. But last but not the least, prevention is always better than control, and I would urge all of you to go back to your hospitals and at least implement whatever is possible from the CDC prevention guidelines for CRE. I thank you for a patient listening, and I'm open to questions.
Thank you, sir. Now it's my humble request to Dr. Sanket, sir, to deliver closing remarks.
So thank you very much for this enlightening talk on CRE. One of the few questions that I had in mind was, is plasmomycin a very effective molecule in management of CRE, particularly when we are dealing with PAPs or bloodstream infections? Any data on that?
So Sanket, just the question on the dot, a great question. So plasmomycin is not a great drug for bloodstream and VAR, but it's a good drug for urinary tract infections. But now what we've started doing is with CREs, we are also looking at organ involvement to decide which is the best antibiotic for that organ. Say, for example, let's talk about tigecycline. Tigecycline is not a good drug monotherapy for CRE, and it does not get into the lung very good for nosocomial pneumonias. But if you have intra-abdominal infections, then tigecycline in combination with polymyxin becomes a good drug. Similarly for the lung, because polymyxin and tigecycline don't penetrate into the lung, ceftazidime avibactam with aztreonam becomes a better option. So similarly for the kidneys and UTI, plasmomycin with some other drug would be a good combination, particularly when you are dealing with CRE, but it will not be a good drug for the lung.
Okay, and one more thing, any clinical experience with ceftriaxone, sulbactam, and EDTA, how good it is clinically?
So I have not used it as monotherapy in the ICU for hemodynamically unstable patients. In that segment where you get just one chance at getting the drug right, you would usually use it in combination. But hemodynamically stable patients, moderate severity, where you basically can demonstrate sensitivity to CSE, I have de-escalated to CSE after 48 hours. In the wards, it is better because you do encounter UTIs and sometimes intra-abdominal infections, which are CREs, but these are stable patients, so it is an ideal drug for that kind of situation.
So in short, plazomicin for complicated UTIs, you would like to reserve it,
Exactly.
use it as a reserve drug.
And CSE
Okay.
primarily for stable patients as a de-escalation therapy and ward patients.
Okay. Any questions from the audience?
Yes, ma'am. We'll get a mic to you.
So as you showed that different carbapenemases have different, the different antibiotics have working on different carbapenemases.
Yes.
In antibiogram, we generally do not reflect what kind of carbapenemase is this. So will it really help if we start mentioning it is NDM or KPC or Oxia? Will it help you in choosing antibiotic better, or you have decided that for this particular syndrome, I'm going to use this antibiotic as per ICMR guideline? Or
So I'll answer that question in a roundabout way just to get you in the context. First and foremost, how does it make a difference to us as far as identification of the enzyme is concerned? For Klebsiella, it makes a difference. Why? Because beta-lactamase production is the dominant mechanism of resistance. For Acinetobacter and Pseudomonas, even if you give me the enzyme, there are other mechanisms of resistance. So when you look at the phenotypic susceptibility, you might still have resistance to a drug, which basically might be sensitive if you just had the enzyme as the reason for the resistance. So if you have a beta-lactamase plus sporin loss, the phenotype will be resistance. So in Pseudomonas and Acinetobacter, it might not. My dominant bug is Klebsiella. So 70% of my patients will be harboring Klebsiella when they get sick inside the hospital, nosocomial. Fine. Now, what you are asking about the enzyme, if you tell me, we already go one step forward. So once my microbiologist comes back to me and he says, I'm growing a gram-negative bug, it looks like possibly a fermenter, because that is the only information I will get. I know it is E. coli Klebsiella. Then I get that bug if my patient is sick to the tune that I don't have more than 4 to 5 hours because I've started an empirical therapy. This patient is not doing well. I get the culture at around 12 to 24 hours. I need to know which is the bug. Then I resort to an expert carbar and I get the enzyme and I change my empiric therapy to appropriate therapy if it was inappropriate in 18 to 24 hours, which saves me 24 hours, which possibly has a bearing on mortality. So yes, you telling me the enzyme makes a hell of a difference to my decision in a hemodynamically unstable patient in the ICU.
Sir,
Yes.
talking about this two antibiotic, what you sir also asked, ceftriaxone, sulbactam, EDTA. We know the laboratory data. You also shown the laboratory
Yes.
data. That's good. But what is because we are in doubt, the comparison of the laboratory data and in vivo and in vitro are the same. What the clinical data says about that. And second question, the simultaneously just I am asking that the second newer aminoglycoside you talk about, what is a comparison that newer aminoglycoside with the amikacin? So perhaps that can evaluate the better utility of that drug.
So the first question about in vitro versus in vivo susceptibility to CSE, that is the question. So there was a lot of debate about the amount of EDTA in the CSE disc which these people are getting you, because it is not in the Vitek 2. You have to do something like a modified disc diffusion to tell us whether it is susceptible or not. So there was a lot of debate. Why? Because most of the samples which were being sent for CSE susceptibility turned out to be susceptible. And when we were implementing this in the ICU, our survivals or our cure rates were not coming up as good. So there was a lot of debate whether the disc which we are using is ideally the optimum concentration or it is an excess concentration which is giving you in vitro susceptibility, but it is not reflecting in vivo survival. So for the time being, that conundrum has not been sorted out. So for us as clinicians, when we use CSE in the hospital, on the bedside, we would obviously choose our patients where I get a second chance to change my antibiotic if I'm wrong on the first instance. And that is what Sanket asked. So I would go with stable patients. Maybe I would go with de-escalation rather than use it as my upfront. Now this possible conundrum can be sorted out between the pharma companies providing the discs and the microbiologists and come to a conclusion whether it is reliable disc or not. But that is not in my domain. The second question about plasmomycin is that we still have not launched it in India. So for me to give you clinical feedback as to whether it is better than aminoglycosides like amikacin, no, I don't have that data. As far as theoretical data goes, it is less toxic than amikacin. So for me, a drug which is less toxic obviously becomes a drug of choice. Secondly, what I've shown is that with amikacin, the aminoglycoside modifying enzymes which are responsible for gram-negative resistance to amikacin, are more as compared to what we see with plasmomycin. So apparently on paper, plasmomycin is less resistance to these AMRs as compared to amikacin. So it becomes a better option, but only time will tell whether there is cross resistance and we can use it or not. So I can't give you that feedback this year. Maybe Kamlesh calls me next year, I'll tell you.
This is the last question. Have to respect the time limit also. So we'll have ample time during the. So
Okay.
this is going to be the last question for the session, I guess.
Thank you, Dr. Hardik. We are using Zevicepta for CRE. So what is your experience of using Zevicepta for Pseudomonas in your ICU?
Okay. So first and foremost, unless and until you have Oxa, we don't use Zevicepta monotherapy for CRE. Let's make it clear. For Oxa, Zevicepta. For NDM, Zevicepta, Astronam. That is the take-home message. For Pseudomonas, like I said, the mechanism of resistance for Pseudomonas is not just beta-lactamase production. It is efflux pumps, porin loss, stuff like that. And hence, phenotypic susceptibility needs to be documented. Now, for Pseudomonas, if the beta-lactamase mechanism of resistance is the dominant mechanism, then ceftazidime is an anti-pseudomonal. When you add avibactam to it, it increases the susceptibility. But I would still wait for my phenotypic susceptibility before I can be sure and de-escalate to Zevicepta monotherapy. So I might start with Poly B Zevicepta or Poly B Zevicepta Astronam. And once you give me the phenotypic susceptibility for that Pseudomonas, and if you give me Zevicepta susceptible, I might de-escalate. But then I will ask you whether it is Zevicepta susceptible or ceftazidime alone also susceptible. Because if you give me ceftazidime susceptibility, I don't need Zevicepta. I can go with just ceftazidime.
I'm sorry to restrict you for the questions. I can understand that among young and enthusiastic clinicians, we have such a knowledgeable clinical speaker and we want this discussion to go on. But I'll finally ask Dr. Sanket to deliver the.
To summarize it, the prevalence and incidence of CRE is increasing day by day, and clinicians are finding it difficult to manage this particular part. The most imperative thing in this case is to call your microbiologist and ask what is the mechanism of resistance.
So the most imperative thing is to call up your microbiologist. You increase as a clinician your communication with your microbiologist. Ask him what is the type of carbapenemase production, right? And as Sir said, that you have specific carbapenemase production and you have different treatment strategies. So you are beyond culture also. Genotyping testing, CARBA-R testing is becoming one of the major cornerstones for the management of CRE infections. And one more thing is that now newer molecules are coming up. Sir mentioned in one of the slides, Zidibactam, that is newer BLI. So there's a news that cefepime is being combined with Zidibactam. Nacobactam is also coming up, right? So these are the various BLIs, newer BLIs that are coming up and which will prove to be promising. Till then we have Astronam, Ceftazidime, Avibactam also, and one of the newer aminoglycosides that has come up. Right, and so thank you very much for the invite, and thank you, sir, for the presentation and other dignitaries. Thank you very much.
Thank you.
I request Dr. Neeta Madam to felicitate Dr. Harjit Dumra sir. I request chairpersons kindly remain on stage, please. I invite Dr. Sumita Soni to felicitate our chairpersons. Dr. Sumita Soni, thank you. Thank you, sirs. Thank you, ma'am. Now I invite my two beautiful co-hosts, Rachna and Palak. Well, I've been observing for some time that these two girls have lost their mind and they are up to something very silly and crazy. So, girls, the stage is all yours.
Thank you.
Is it working? Sir, is it working? Mic is working? We proceed. Good morning. Hi, I'm Sifra,
Sifra.
super intelligent female robotic automation.
Okay, so our next lecture topic is
Clinical utility of syndromic approach.
how do you know?
You have shared a program schedule with me, admin.
Okay,
The clinical utility of syndromic approach. What do you mean by syndromic approach? It is a qualitative detection and identification of multiple pathogens like bacteria, virus, parasite, and fungal with the use of a real-time multiplex PCR.
stop. We have a renowned speaker for this who will enlighten us for this.
Which speaker? Boss? Atmos?
Is this a joke?
Yes, it was a joke.
Stop, Sifra. Okay, I'd like to invite our chairpersons for the next session. Dr. Nidhi Sood ma'am, Professor and Head GMERS Sola. Dr. Neeraj Biswas sir, Dean GMERS College Morbi. Dr. Sarita Gaonkar, Consultant Microbiologist Zydus Hospital. Dr. Deepa Kinanewala, Faculty BJ Medical College. I request Dr. Syed Huda madam to proceed for our session. Okay, I request Dr. Sarita ma'am to introduce our esteemed speaker.
Hello. Dr. Huda Ali, Manager Medical Affairs, South Asia, has her hat decorated with many feathers. She is qualified to specialization in multiple fraternities like ENT, head and neck, as well as microbiology. Having experience of more than 13 years in teaching in renowned institutes like D.Y. Patil Medical College, Navi Mumbai, KM Mumbai, Metro Hospital Jaipur, Sri Devraj Academy Karnataka, and Nepalganj Medical College, Nepal. She likes to actively participate in numerous medical events and also winning awards. Welcome, Dr. Udali.
A warm welcome. Thank you for the warm welcome. All right. Good morning, everyone. And thank you so much, everyone. So today I'd like to talk about the syndromic approach. So what is it? What is the definition of syndromic approach? So it is the ability to test for a variety of pathogens simultaneously when a patient presents with a set of clinical symptoms not specific to a pathogen. So thank you, Sifra, that was close enough. Syndromic testing is a symptom-driven broad grouping of probable pathogens into one rapid test that maximizes the probability of getting the right answer in a clinically relevant time frame. So how does this help us? So with this approach, the probability of identifying the pathogen the right time at the first time is the best. So there's no more guesswork. So it is the right test at the right time. Another thing is it improves with the antimicrobial stewardship, decreases the length of hospital stay. I'll speak further with real-world evidences in further slides. This also helps us in cohorting, in the treatment plan, in admission, as well as the isolation of the patient based on the causative pathogens. So this could be sooner initiated than later. Now, if you just give few moments into this slide, so I would like to explain something. Say a patient in the IPT starts exhibiting symptoms of sepsis and the Q-SOFA score is deteriorating. Now in this case, in conventional method, once when the signs and symptoms start establishing, the patient is immediately started on empirical treatment. And during examination, the blood testing, the specimen will be collected and sent to microbiology. So this will take by the end of day 3, even if we use automated ID AST, this would take by the end of day 3, and it will only be by day 4 that the causative organism as well as the targeted therapy can be started. Meanwhile, with syndromic testing, if a patient is critical, on the day 1 itself, during the onset of the symptoms, the specimen can be collected, and by the end of day 1, the identification and the antimicrobial resistant gene can be identified. So by the first day itself, targeted therapy can be initiated. So what does this mean? So this will result when we speak of diagnostic stewardship. So it is the right patient, the right test at the right time. So what we are doing here with syndromic testing is we're improving diagnostic stewardship as well. Diagnostic stewardship states that empiric treatment should be started as soon as possible, which is happening in both the cases. But it should be for a very short period, and the initiation of targeted therapy should start as soon as possible, which will result in shorter length of stay, no use of unnecessary antimicrobials, even battery of tests wouldn't be required. Now, how is it useful to us? So relevant pathogens can be diagnosed. What is the causative organism? So sometimes some rare pathogen can be identified. For example, parvovirus has been seen on the rise in many pulmonary cases. So that is not, first of all, expected with the diagnostic as well as the antimicrobial stewardship. And this generates saving at the hospital level as well as for the patient. So I'm going to discuss more real-world evidence regarding how cost beneficial it is to the patients. Now, what is a BioFire film array system? So this is an all-in-one integration. So there is a small pouch, a plastic pouch, where the sample, ready sample is placed. You hydrate the pouch and put it in the system. The result is ready in 1 to 2 hours. And we know it is a nested multiplex PCR. But how is it different than other multiplex PCRs? So in the BioFire multiplex PCR, there are two-step PCR taking place. The first step is the amplification of the DNA. Now what happens is the amplicon that is produced, that is the double-stranded DNA. So there is a patented LC green dye. This goes and binds with the double-stranded DNA or the amplicon. When it binds to it, it will emit fluorescence. It keeps emitting fluorescence. So as you can see in this chart, it will keep emitting fluorescence. Now what happens in the final stages of the PCR is there will be a very gradual rise in temperature, starting from 60 degrees centigrade to 94 degrees centigrade. And what happens is when that gradual rise in temperature occurs, there comes a melting temperature. Now this melting temperature is independent, it is dependent and it is specific for each amplicon sequence and length. And once it reaches that melting temperature, denaturation starts taking place, the strands start breaking apart, the LC green dye gets released and the fluorescence start reducing. So you can see there will be a dip of the fluorescence and this is captured by the film array. So this is the inverted graph of the melting curve, and as you can see this gives a melting peak which will be specific for each target. So this is how it is determined and it is different than the CT value that is used in the PCR, simplex PCRs. So CT value, as you know, earlier in COVID times, there were a lot of literature and it became a household thing, kitna hai CT value, acha, bura hai, acha hai. But that's no longer as significant. If you go through the literature, since past 2022, it is losing its credibility to decide based on CT value. Now, this is the study that I wanted to discuss about. So, this is a study conducted in a Greek pediatric hospital. Now, we all know the economy in Greece is not doing great. So they wanted to find out whether it is cost beneficial to the patients to go for BioFire. And this study proved that the overall positivity was 52.1%. There were no false negative results with BioFire ME panel. Overall economic outcome was 31.5% reduction in per case hospital cost. And the total cost reduction over the study period was almost 22,000 euros. So and for neonates, this was extremely beneficial, shorter length of stay, meaning less hospital-acquired infections or complications, and the hospital cost also was reduced because the length of stay was reduced. Now, we have to keep in mind when the patient is in the ICU charges, the antimicrobials that are going to the patient, those multiple antimicrobials, each syringe for those, the IV antibiotics, antifungals, antivirals, all this should be considered. And the longer the patient stays, the more the chances to acquire hospital infection. Now let's talk about the specific panels. Something interesting about it, because most of you are familiar with the panels, but how is it different and unique? Now in the respiratory panel, so co-infections can be detected, and this was keenly seen in cases of SARS-CoV-2 with co-infection with other viruses like human metapneumovirus or adenovirus or even influenza virus. So I'll show you some patients' examples as well, how this changes the course of treatment. But first, So this is the panel where 23 targets are there. The sample is nasopharyngeal swab that is taken in saline or transport media and is processed, and the result is obtained in 45 minutes. Now, in this panel, you'll see the viruses are there which are clinically relevant, which makes sense. These are coronaviruses affecting humans. It doesn't make sense putting coronaviruses affecting other species, as well as the bacteria, that is Mycoplasma, Chlamydia, Bordetella. So these are difficult to diagnose. So that's why the targets should be as much it is relevant and important. Now the IDSA guidelines also gives various situations where it needs to be used. Like in cases of OPD and IPD patients where influenza is suspected, multiplex PCR should be considered. In cases of immunocompromised patients that are hospitalized, so there would be a high chance of any severe infection, hospital acquired in those cases as well. Excuse me. Or in patients that are not immunocompromised, but they're critical patients and we need to cohort accordingly, isolate them, decide the line of treatment as well. Now, this is an example. You can see this is a patient's report where SARS-CoV-2 and influenza A virus present in the respiratory pathogen is detected. So this would entirely change the course of treatment. We have to add oseltamivir to this patient as well. And some other systems may just give SARS-CoV-2. So that is symptomatic treatment. So the patient won't be improving. Another example is a patient comes to going in respiratory distress and empirically started in amoxiclav and oseltamivir. However, when BioFire panel is run, it shows that it has adenovirus and parainfluenza 3 virus. So none of these are useful. Immediately stopping these oseltamivir as well as amoxiclav is necessary and symptomatic treatment is required. So this is how it affects the line of treatment in patients. Another interesting is the pneumonia panel. So earlier we used to use blood culture that gives low yield, sputum, the quality of the sputum sample may not be good enough, and urine antigens doesn't give good sensitivity or specificity to diagnose pneumonia. And international guidelines state that in cases where in patients wherever there is non-standard community-acquired pneumonia antibiotics being prescribed, in those cases multiplex PCR should be done so that we can give appropriate therapy. So this is the IDSA clinical pathway. In non-severe CAP cases, to eliminate viral suspicion, it should be considered to go for multiplex PCR. And in severe community-acquired pneumonia, definitely one should go ahead wherever it's available for a multiplex PCR. Now, this is the pneumonia panel with the bacteria, atypical bacteria, viruses, and the antimicrobial genes. Now, I would like to emphasize this. What is with the semi-quantitative thing? As you can see, these are the bacteria that are found as commensals or colonizers in the lower respiratory tract. So they are to be found out whether they are causative pathogens or not, hence they are semi-quantitative. Those bacteria, viruses that are definitely considered as pathogenic are qualitative in this case, and antimicrobial resistance gene is also there so that it can be decided. The sample that is used is lower respiratory tract sample like BAL, mini BAL, sputum, or endotracheal aspiration. This has a very high sensitivity and specificity level, and indications are CAP, hospital acquired, ventilator acquired. Although this test is not indicated for non-symptomatic patients, as for screening, it's not indicated. As well as if you want to find out that the condition is resolved, no, it's not indicated. A simple chest X-ray PA view can help you know from the initial stage to the last stage whether it's resolved or not. Now, what is semi-quantitative reporting in this situation? So what happens is during the PCR, there are DNA copies per ml. So these DNA copies per ml are counted and assessed by the system, and anything above the level of 10 raised to the power 3.5 starts getting allocated to respective bins. 10 raised to the power 4, 5, 6, and 7. Now, if it is in less than 10 raised to the power 5, even if it is detected, it may not be significant. So now comes this question. If you get this kind of a report where there is, so this is a pneumonia bowel specimen, Klebsiella pneumoniae present, Staphylococcus aureus present. You can see Staphylococcus is allocated to the 10 raised to the power 4 bin, and Kleb is reaching to 10 raised to the power 6 bin. And we can see there are resistant genes present here, but only for the GNB, not for the Staph aureus. So what do you think would be your interpretation of this report regarding the patient? Yes, sir, absolutely. So we have to consider Klebsiella because it is more than 10 raised to the power 5. Now my question to you is, what if there was also a MRSA, the MECA gene detected here? So in that case, whenever there is a resistant gene, even if it is less than 10 raised to the power 5, we'll have to treat for that. So if this was a MRSA and Klebsiella, we'll have to treat even though it was falling in the range of 10 raised to the power 4. However, since it was not resistant, so we'll only treat the Klebsiella. Now the BCID2 panel. So this is for, this is used after the blood culture. And what is the importance? Polymicrobial detection is very helpful in these cases. How many times have we seen that there are polymicrobial infection in a bloodstream infection? It's very rare, but BioFire can pick that up. And these studies have indicated the significance of it, because when there is just a gram negative that is affecting, it is not as much with the mortality. However, with gram positive as well, but when there is multiple organisms involved, say bacteremia and fungemia involved, the prognosis becomes very bad, mortality and morbidity increases, and the time is also of the essence in such situations. So that is why it is very important to diagnose co-infections in bloodstream infection. Now the BCID2 panel, the sample is from a positive blood culture. Immediately as a blood culture flags positive, put that sample into the BCID2 panel. Within 1 hour, you'll get your organism and the resistant gene. So this has GNB, GPB, yeast that are found in bloodstream infections, and the antimicrobial resistant genes. Now you can see these two examples. So these patients had bloodstream infection. Now speciation is so important in such cases. Now here we found out that it's Candida auris. So we'll have to start with echinocandins. Whereas in this case we saw it's Candida albicans, but there is also Gibraltar present. So we'll have to go for higher antifungals in such situations. If we compare with the conventional method of blood culture and ID-AST method, so considering it takes 12 to 72 hours to flag positive, let's say, after that, for the standard testing to identify the organism and the antimicrobial susceptibility, it will again take you 1 to 3 days. But with the BCID2 panel, it will take you 1 hour. So this will reduce 70% reduction in time to identification. So if we consider 12 hours as time to positivity of the blood culture, in 17 hours almost, we are getting the targeted treatment, whereas in conventional method, it's taking 57 hours. And we all know surviving sepsis guidelines, empiric treatment definitely, we start in 3 hours, but targeted treatment is very important because time is of the essence in cases of sepsis. Otherwise, we are damaging more organs and further morbidity. Now, when we consider the BCID panel with antimicrobial stewardship, so this is something important because as microbiologists, many of us, even if it flags positive or if, say, the BCID panel has also identified, when we do the gram staining, if we wait for the next day, we are waiting so many hours. But if the bottle flags positive, immediately a gram staining and or putting it immediately into the BCID and generating a report can save lives, especially in cases of neonatal sepsis. So it is very important to have that collaborative approach for critical patients. With the clinicians, the microbiologists should have this immediate approach with them. This helps with the BCID panel, and it should be made a point that if you're using it, immediately report it to the clinician. And softwares are available to immediately let the clinician know. They can see it in their phones itself. Now with the ME panel, so the infection in the joint that was operated, even those are identified. So these are more examples where MRSA was detected. And like I told you, rare pathogens can be detected as well. So with this, finally, I will mention the latest, that is Global Fever Panel, that is coming shortly. And it's time that we have to stop guessing and start knowing. Thank you so much, everyone. Any queries, please go ahead.
I request Dr. Nidhi Sood ma'am to give closing remarks.
Before I give closing remarks, ma'am, I have some questions
Definitely.
on behalf of audience.
Yes, absolutely.
One thing is, as a simple principle of PCR, the more we increase primer pairs, we lose on sensitivity and specificity. So how is BioFire taking care of that? Second question is your blood culture panel. Since it will give result only after we get a blood culture positive bottle, so how does it compete with MALDI-TOF?
Absolutely. Ma'am, the first question, sorry, what was it? What increases?
The more targets we increase,
Yes.
we lose on sensitivity
Yes.
and specificity as well.
Yes, absolutely. Excellent question, ma'am. So I couldn't bring it up in my talk. Thank you for asking that question. So that is why if you compare BioFire multiplex PCR, the targets are only limited to those that are clinically relevant. Those are found in human species. So those are the targets, because the more we'll add, there are many, whatever out there, they say we have this many, but the fact that limited targets that are significant is more important, because if we keep too many, the sensitivity specificity will come down, because the denaturation will be similar of different species as well. And the other question about some whole blood are being used, and in the BCID we use from blood culture. So this was primarily decided because the gold standard method is to do a blood culture, and from the blood culture to find out if there is any organism. So that is why we can use other methods also, but those are not approved from US FDA. As well as the entire panels, the organisms, each and every one is approved from US FDA to be used. So based on the ASM guidelines, IDSA guidelines, for sepsis, it has to be blood culture, and it should be from the blood culture that we're identifying organisms. So this is important to do that. MALDI, yes, it can be used, but BCID is also a very beneficial. Plus, there are some off-label use that require studies, So some studies can prove other parameters can be used in the BCID panels also, but we still need to do more studies about that to validate them.
Thank you.
Thank you so much, ma'am. Thank you, everyone.
Hello, ma'am. Congratulations for a wonderful presentation. Thank you. My question is regarding the GI panel. Basically, about GI infections, I would like to bring to the fore two aspects. The first one is that majority of the GI infections, when the patient is managed, the identification of organism in majority of the infections generally does not alter the pharmacological management. And the second aspect is that when we identify the organism, the pathogen, as well as the genotype, if there is any resistance pattern, how much does it differentiate between an actual pathogen and a non-pathogenic bystander? In view of these two aspects, I would love to have your take on the clinical utility of GI panel. Thank you.
Thank you for the question. It's excellent question. So, as you know, if there's a neonate or an infant, the normal microbiome is not formed till 2 years of age. So, it is critically important in such patients. And we know that that causes, I think it's the second most highly cause of mortality for neonates and infants. Another thing is, so many times exposure of antibiotics starts causing Clostridium difficile infection. So that can be detected and immediately stopping all antimicrobials and considering only the pathogen to be treated. Now, many times, if you see the panel also, yes, there are presence of E. coli, I say, but when you get a EPEC, say, so, and there are symptoms present, so it's definitely the causative organism in that case. And if there are multiple organisms, that is more than 4 detected, in that case, the test needs to be repeated again because that is one of the limitations. And why repeat? Not just doing the same repetition from the sample, no. There are 2 causes for that. The sample type and the transport of the sample. These are the errors that are found out. So the sample type need to be the proper sample that is collected, and the transportation needs to be done immediately so that we are not letting the normal flora also become, yes. So in that case, those 2 considerations need to be done with a fresh sample and repeat the test. Then it will narrow down the organisms as well. And also, one point, if I may put, negative results are not a bad result. It's very important. It helps you know whether it's an infectious or a non-infectious disease that you're treating. So, किसी का HIV negative आया तो अच्छी बात है. We don't have to start ART. So, this is exactly in that point of view. So, whether you need to do antiviral stewardship, antimicrobial stewardship, antifungal stewardship, that all matters also. Thank you.
Just to add to her, I would like to say that the indications that they said for GI panel was dysentery and diarrhea not responding to 7 days. So dysentery, we have multiple reasons, and each reason has its own treatment option. So getting it done would be, I think, beneficial only.
Yes,
But
ma'am.
indication is not for simple diarrhea. It is for
Yes.
dysentery and diarrhea not responding to more than 7 days.
So I showed this slide again so that you see these are the specific, not every patient who comes with the diarrhea in 1 day, and we have, it's in our hands. These machines are there for us to decide and make us more powerful. So they're not here to replace us. They are here to enable us to become more powerful.
Thank you, Dr. Huda.
Thank you so much.
It was a very wonderful presentation.
Thank you.
It was very beautiful. In fact, we have read BioFire in our infection control book only. So reading and learning and putting into brain is always very difficult. But when we hear it from someone and hear from expert from the industry, it really adds. It was put up very meticulously. And we have come to know that there are many panels for many syndromes available.
Absolutely.
And the only thing, because we are a resource poor country and cost is major concern. So if the company could focus on the locally prevalent organisms while formulating panels region wise, it would be far more beneficial to us. I would like to congratulate you for giving us insight. Also, I would like to congratulate our organizing team. Since I am from an academic background, and many of us who are sitting in the audience are also from the medical colleges, the what do you say, the viewpoint of colleague from industry, listening to that is was a really delightful experience. I congratulate the organizing team, and I congratulate them for bringing us together after many years, and I hope that it continues this continues year after year. And thank you very much.
Thank you so much, ma'am. And
Thank you so much, ma'am. I would like to request Dr. Neeraj sir and Dr. Deepa ma'am to felicitate Dr. Syed Huda ma'am. Uh, I would like to request Dr. Rupal Patel to felicitate our chairpersons.
Okay, before proceeding to our next session, let's have a look at the AV and audiovisual.
दो हफ्तों से ज्यादा खांसी, तुरंत डॉक्टर से मिलिए और बलगम की जांच कराइए। टीबी हारेगा, देश जीतेगा।
I'm sure the audience got some idea about the topic, but now that we have gained insight from our speakers, it's time to deepen the conversation with our upcoming panel discussion on unlocking TB diagnostics and our panelists are Dr. Neerav Pandya. He's a clinical microbiologist, Dr. Udayan's Laboratory, Vadodara. Dr. Neerav, welcome. Dr. Anand Shah, consultant microbiologist, Nobel Micropath Laboratory, Surat. May I have Dr. Anand? Good morning, welcome. Dr. Bhargav Patel, consultant microbiologist, Sarthak Microbiology Laboratory, Wadaj, and Sterling Accuracy Diagnostic. Dr. Bhargav. Welcome, good morning. Dr. Foram Patel, Associate Professor, Ananya Medical College. Welcome, good morning, Dr. Foram. It's a privilege to invite moderator for this panel discussion, Dr. Bhavini Shah, madam. Dr. Bhavini Shah, ma'am, is a clinical microbiologist and an infection control consultant at one of the most reputed laboratories in Ahmedabad, having probably the biggest chain across India, Newburgh Supratech Laboratory. He's having experience of more than 34 years And she is also actively contributing to ensure the best laboratory practices across India as an inspector and assessor of renowned accreditation bodies like NABL and CAP. Good morning and welcome, ma'am.
क्या है इंटर इंटर થેન્ક યુ હાર્દિક થોડું વધારે બોલ્યો છે એના કરતાં so just so that you don't get your hopes high, so I am going to breeze you through TB, all the diagnostics that are available, the approved ones. There are tons of things available, but we talk about what is relevant for this talk. I have the brilliant set of panelists with me, so if I have queries I go back to them. So let's begin with the first slide, because since we were studying, TB was a slow process. When I say a slow process, what do I mean? કે સેમ્પલ આપ્યું પછી ક્યારે રિપોર્ટ આવશે ખબર નથી, and whether it will be the correct report or what are we going to get. So this is a very symbolic thing that the crow is thirsty. The water is just this much. We read about all these stories when we were in school. So they kept putting stones inside so that the water level comes up and the crow could quench the thirst. So this is a very important slide with reference to TB. So we know that India has the highest TB burden across the world, contributing to about 27%. So every 100 people having TB in the world, 27 hail from India. The rest is history. Everybody knows the data that is around. We have the best of modalities, but then where are we missing out? We have all the diagnostics that the world has. So where are we missing out? Let's just quickly go through this. This is what is available today. 25 years back, we had only the smear and we used to put our RJ mediums. What do we have today? We definitely have our smears along with the fluorescence. We have all kind of NAT testings. It could be CB-NAT, it could be chip testing, the mall bio ones. It could be LAMP testing. There are different kinds of tests available. We have the very popular line probe assays, which is the DR for the first line and the second line. Even ID, NTM ID also comes on the LPA. You have manual and automated cultures, the LJ media and the automated cultures. The world is moving towards automated, so we'll have more emphasis on the automated cultures. Sequencing is what we do very regularly. So if you go to Pyro, Sanger and whole genome sequences, NGS technologies, the MALDI-TOF, of course, as someone mentioned right now. The benefit is the TAT. I think the numbers would have been 3 times if we did not have these modalities. So one by one, I'm just giving a slide each. We are not going to learn the technology because that's a huge thing. We're just breezing through it. So we know what is available and where we could use which technology. It could be the best of technology, but might not be helpful to the patient. Other technology, like we say tropicalis, or a candida albicans could respond to fluconazole. So for a parapsilosis, you don't need to give an echinocandin. So that's how this is, that you may have tons of available modalities. Choose the right one that your clinician needs. So AFB stain, of course, we know economical, time saving, skilled person to see, because we've all seen reports of nocardia also reported as AFB detected. Experience can, of course, assist all these young children that I see around. Looking at the smear, they're able to tell, ma'am, NTM જેવું લાગે છે, MTB લાગે છે. So experience gives you a lot of push. The only difference between fluorescence and the regular ZN that we see, what I see is that we use fluorescent only when we have a big load. It helps in screening because you see it under the high power, so you see more area and you quickly go through the slide. But otherwise, ZN is a brilliant technology. The nucleic acid amplification test that we know, many tests are available, as I said. It detects MTBC and the load. Both the things you get in the NAT testing, that will be MTB detected and rifampicin sensitive, resistant or indeterminate. Now these are the 2 things that are detected. The only difference between CB-NAT and LPA, which is in the next slide, is that gives you INH also, high level, low level. So molecular test does not ensure the viability of the bacilli. This is one standard thing we need to remember at all times, that we are looking at DNA. It is not going to ensure the viability. They could be dead, they could be live. That is what you need to keep in mind when you're talking to your clinician. When I take this talk, I'm targeting at our fraternity when we guide the clinician as to which test should be done. Blood is not a recommended sample. Two things again you need to remember. When CBNAT came in, it did not have the ultra. Today it has the ultra. So ultra has the capability of detecting low load of bacilli, like 13 to 15 bacilli per ml. The previous one had 133. Remember this, that the new XDR that has come in is not ultra. When you're talking to a clinician, you must remember that XDR is not ultra. So if you have a very low in MTB, there is all possibility that your XDR will come negative after the patient invests such a lot of money. So talk to your clinician and open up with this so that he or she decides whether he wants to do it or not. Just some quick pictures of the CBNAT, the MolBio and the open RT-PCR systems. The line probe assays, reverse hybridization of DNA, they are a strip-based technology. Can I quickly have a hands up how many of you have used line probe assay? Just so that I know how much time I should spend on that. Uchu karon thodo. Okay, so very few. So it's a very thin strip, like a filter paper. It's a very thin strip. I'll show you in the next slide. And the strip is coated with the probes. They are all hybridized. They are all there. And then the amplicons that you're going to make in the kit are going to bind with them and give you the bands. I will show you in the next slide very clearly. So it gives you two things. It gives you MTB and it gives you drug resistance. So drug resistance, when I say RIF INH in the first line, both it will give you, and in the second line, respectively, it will give you. There are some revisions for all those who are using LPA. There are some revisions by the manufacturer. We don't use the term susceptible. We use resistance not detected. Because when we talk about these molecular tests, the major difference between molecular and whole genome sequencing is that they target specific locus. They are not going to cover the whole genome. So only the most frequently found mutations are addressed. Therefore, you miss out on some. So once you call it sensitive, you don't know whether the other ones that are rare mutations are covered or not. Therefore, the terminology has been changed to resistance not detected. You have resistance inferred. I will show it to you. If the wild type is missing and there is no mutant, so all the bands of wild type you will have, which should be there technically, but if one of them is missing and there is no mutant to it, that means that wild probe has not been captured in the test. So resistance is there, but you don't know what is the mutant. So you call it resistance inferred. Low level increase in MIC and high level increase in MIC, that both of them we see in INH and in the S second line panel. 2 minutes you concentrate on this so you understand what LPA is all about. You see the two strips, the A and the B. The first three, I put a red line for your understanding. The red line means they are all controls. We don't want to go into what the controls are. They are controls and you need to have those controls like any other test. Then you see a blue line coming in on the side at number 12. They are all wild type. All of them are wild type probes. And corresponding mutants are there at the bottom. You can see the RPO, the mutants, 1, 2. Then you go to CAT-G, that is high level resistance. And then those locus and their mutants. Then you go to the low level, INHA and their mutants. The second is for the second line. We'll stick to the first line, the only reason being we have to understand, we don't have to report. You see the results of the strips on the other side. Let's see the first one. If you quickly start counting, I thought I'll show you with a pointer, but you can very easily see two beautiful screens on the side. The first three controls and then you count them, you have 9 bands with the locus and the wild type. Then the 2 for CAT-G and 3 for INHA. This is a resistance not detected pattern. All the wild types are there, properly sitting, a standard book picture. When you see the second one, the third one. The third has one missing. Can you see the wild type missing? Now, when you have a wild type missing and no mutant bands, then what would it be? What did I tell you? Inferred ray. You're inferring it. If you have a mutant band, you know what it is. If you have all the wild types and the mutant band, what you would call it? All the wild types, and still you have a mutant. You must not forget there is always something called heteroresistance and mixed population. So you are never wrong. Remember this. These are beautiful technologies. If you get some result which is like not giving you confidence, don't go on to that. Try to see, talk to the clinician. What is it that is with the patient? I'll show it to you in the next slide. So these are the same things. Second line. See this? I think all those who are with the TB government program would know this very well. How does this help you? There are tons of things like this. I'm talking only about one thing to give you a symbolic thing, make you think why you need to read the whole document once. That when you look at guide A, that is for fluoroquinolones, if you have a mutation that is linked with 3B, 3C and 3D, 3B, 3C and 3D, if this is the mutant you are getting, remember both levoflox and moxiflox are not going to work there. If it's the previous one, it is likely that you could use moxifloxacin on a higher dose. But if you have these three mutants, you are sure that it's not going to work. Even in the previous, there is a recommendation that you need to compare it with the phenotypic DST. So that's about LPA. Please remember, line probe assay is used for first line, second line, and also to identify NTMs, right? NTM, it has an identification strip. We will see it later on, but I have not just killed time there. AFP culture, as I said, LJs, loyal, faithful, olden days, but we know all the problems that we have with LJ. I still use them, but I use them as a parallel. You know, literature does recommend at times to use this, so we do it, but automation is today the primary mode of AFP cultures. It is the need of the hour. It remains the gold standard. Blood and bone marrow have a special collection method. So when we say NAT testing does not recommend blood, please remember, for AFP culture, you can always use blood or bone marrow, but you can't take blood and straight away put it for culture. Before you collect it, you have to talk to your clinician, take a sterile container, could be a urine container, have 10 ml of distilled water inside, which is water for injection you can take, and add the blood to that and mix it. It lyses. That specimen you can use for AFP culture, and same for bone marrow also, so that it doesn't clot inside. So market leaders, as we know, Midget and Bactec are leaders. These are just the pictures. They come in smaller sizes and bigger sizes also. So once the culture beeps positive, you know, it has a sensor based. So once there is growth, whenever a midget culture is positive, it could be MTB, it could be NTM, it could be a contaminant. Even a contaminant will give positive because it is going to release and the sensor is going to detect, so it will be positive. You differentiate it. Once it's positive, you differentiate it whether it is MTB or NTM by immunochromatography. Microscopy. My kids have become so brilliant, you know, they look at the slide and they say, oh, this is MTB, you don't need to do the card. But we need to do the card. That I'll tell you why. Identification of NTM and MOTT is recommended for clinical management. When I'm saying this, I would quickly want to add that NTM, like Candida, 10 years back when I was talking about Candida, non-albicans 10, 15 years back was like, oh, non-albicans, okay, germ tube curry, albicans and non-albicans. But now the world knows that when we do non-albicans, we need the correct speciation because clinical management is affected by different species. The same thing stands true for NTMs also. Identification and MIC. Recommended because clinical management, I'll give you one or two examples because it's a huge talk on its own. So NTM or MOTT, speciation and sensitivity is recommended. So speciation and MIC of course defines, as I told you, biochemical we no longer travel by ST buses if we have an option, right? We no longer use the Nokia 1 kg phone that we used to use 15 years back. So if you are not using those things for your comfort, this is a patient, this is life. Please do not use technologies that have gone to the dogs for the patient. Use whatever you would use for your own family. Then you are on the right path of diagnostics. When you do LPA-CM, as I told you, you are doing line probe assays for identification of NTMs, right? The next slide will show you that. LPA-CM, that is common mycobacteria. That is one strip and it gives you 16 species it identifies. MTB also included in this. If you get no bands there, it's none of those. Then again you have to shift to LPA-AS, that is additional species, which has again another 17 species. So total kitli thai? 16 ne 70? Just was checking whether you all were awake. So this is what it is. And then also there is a possibility that Beuma, it is negative. So Malditoff is definitely a better option. Around 200 species are identified for NTM, which are relevant. And Maldi has a database of 178 species and a time of 1.5 to 2 hours for identification and brilliant results it can give you. So Malditoff for NTM definitely becomes the one for choice. This is the LPA-CM just for you to have a glimpse of it. Ke je band ave, e pramane nu naam hoy. Whatever are the bands, similarly they have given. So it is no rocket science. This is one magic box that I love, Malditoff. It is matrix because you always use a matrix before identification. So it is matrix assisted. There is a huge laser. The heart of the instrument is the laser. So matrix assisted laser, deabsorption, ionization. Time of flight it is called because it is measuring the time of flight it takes. In the next slide I will show it to you. It is a mass spec right from 1912 when Thomson did phone and a ghadiyal. So it was him who had introduced it. This is the Malditoff. Simple, no hang-ups about it. It's a simple dabba, magic box. If you see this, at the top is the detection device. At the bottom is the ion source. And in between you can see a box which is the mass analyzer. If you go on the other side, you will see the electrodes and the detector. Detector is at the top. Here I said detection device. So what happens is, when you put your bug here at the bottom, where between the ion source and the mass analyzer, you have the matrix on top of it. It drifts forward as per the mass and then it is accelerated towards the detector up there. When I go to the next slide, you will understand this better. This is, let's say, a blood agar with growth. For mycobacteria, we could do it directly from the midget tube also or from the LJ. We have a 1 hour pre-processing for that. So you take it, you do whatever is to be done, and this is a steel plate that you see. You see a steel plate. You put a drop of whatever you have done ready, and then you put formic acid, allow it to dry, use matrix because it is matrix assisted. It has a specific matrix which is the magic over it. You put that, and there is a small device like this, where you put the plate inside and push it inside. And magic, in a moment of 2 minutes, less than 2 minutes, it will give you the first 10 probabilities as per the mass. So this can identify bacteria, this can identify fungus, mycelial also, and of course mycobacteria. So it is a mass spectrometer. It produces a mass spectrum, very simple. The time it takes to travel from the ion source to the detector is measured. And then it is converted to mass with high accuracy. Today, even when you see your ATCC strains, which had Vitek inside at the second page, says identified by Malditoff. So now this is the gold standard for identification. Tons, it came in first research. Malditoff has been with us forever, but it was with research. Now we have got it into clinical diagnostics. So quickly, as I told you, bacteria, fungal, directly from positive blood culture, as ma'am was talking in the previous. The advantage over Malditoff becomes it has a huge database. When we do a panel, which is expensive, Malditoff is more expensive, so only if you have a Malditoff, it makes more sense. Otherwise, buying and having a Malditoff, it's too much, very expensive. Quickly going to sequencing. Three most popular methods, the Pyro, the Sanger, and the NGS whole genome sequencing. Pyro and Sanger have been with us for some time. I'll take you to the next. I've just tried to make a précis for you to understand. We do PCRs and we know probes and amplicons. All of us post-COVID are very, very familiar with what PCRs are all about. So this is the same sequencing, you know. What is the difference between the three? It's the chemistry that is different. The first is amplification of specific loci. Pyro, when you see, is generation of light. Pyro sequencing, I will show you in the next slide. It's measuring light with enzymes, light that is produced because of enzymes. And NGS based approach. This is a brilliant invention for us as microbiologists, because in one run, maybe a year from now, in one run, it is going to give you MTB or NTM. It is going to give you all the mutations that are present. When mutations are present, it doesn't mean it's resistant. Some of them are silent, they don't make sense. Some of them are important. So it's going to give you all the mutations, NTM and all the drug susceptibility of NTM. So in a span of 48 to 72 hours, you will have a report which says which bug it is and what is the sensitivity of the bug. Lots of AI and softwares are involved. Validation is going on as of now. Advantages you can read. I mean, these are naturally point. If this does 1000 base pairs and 1000 base pairs, Sanger would look at 1000, Pyro would look at 1000, and how much would this look at? 4.4 million base pairs. This value I'm giving you just so that you can relate to the difference between the technologies, that it will go through deep slicing of 4.4 million base pairs. What are the limitations as of now? I mean, I don't even count it expensive for whole genome sequencing, because we are already spending so much on all these syndromic panels and all. And if this is the total that we see of our culture, of our smears, of our LPAs and our Sangers or whatever, this is definitely not very expensive. The only thing is that we need very specialized people, because the data that comes out is in terabytes, right? So you need a special set of bioinformaticians. We can't read that. I'll show you in the next slide. It's Greek and Latin for us when the report comes out. So you need bioinformaticians who are trained for this to point out the mutations, and then we do the interpretation. So this is the Sanger workflow, as I said. You can, I hope everybody can see the diagram, how the reagents are put in and how the primer, like any other sequencing, puts inside, how it gets tagged. And Sanger was supposed to be the gold standard for limited amount of mutations. And this is how the result comes and it is interpreted. This is Pyro sequencing. As I told you, the enzymes are there. Pyro, it detects light of the DNTP incorporated in the ongoing PCRs. There is this enzyme, the ATP sulfurase, which converts the pyrophosphatase to ATP. Ultimately, the ATP is converted into light, as the diagram shows you, by the luciferase enzyme, and it is that light comes out and it measures the intensity of the light. Pyro sequencing was one of the first methods that was used directly from the sample also to find this, and still it's doing very well in places where whole genome sequencing is not done. This is whole genome sequencing. This is my favorite slide and my favorite topic, so I'll just take 1.5 minutes on this. That once you collect the sample, see what is so beautiful about the test, that once you collect the sample, you extract the DNA, you prepare a library. When we talk about all these whole genome sequencing, we prepare a library and see how technology moves so fast that when you create a library, it's not only about the amplicons, when we talk about not only about the primers, it's also about barcoding. Now, when I say barcoding, I mean it is an individual barcoded labeled stuff. That means if I have 10 samples, 1, 2, 3, 4 till 10, and if I'm going to put the extracted stuff, whatever my amplicons are, and I put the barcode in all of them, I mix them all together. If I have 10 samples, if I have 100 samples, whatever I have, I barcode all of them individually and then I mix them all together because that barcode has been tagged with the whole sample. So it's all together. And then from that mixture, I will pick up whatever volume according to the assay and push it into the flow cell. Flow cell is the one that goes inside the machine of the sequencer. Tons of sequencers are available. The latest that I'm working with is the MGI. NovaSeq had just come in a year back, but that also is now going into, there are new things coming back. And the advantage of using new technology is that it becomes more reasonable, the pricing becomes more economical for everybody to use it. So I work right now on MGI and minimum 5 GB of sequencing is required for TB genome. At least 5 GB of sequencing, then only I will get the whole genome. So if you can see, I don't know if the slide is big enough, I can't see. Can you read this? Generation of raw data. So this is what comes out. So it's very difficult for us to, sit down and practically do it. You need brilliant software and bioinformaticians who can convert it to the language that we understand. So let's first begin. I hope I've quickly gone through all the technologies and you have a rough idea of what things are about. So Dr. Forum is one of our mature microbiologists, and being with the government sector, she has a good experience over the NTEP and the private sector that we talk about. So Dr. Forum, could you just give us a quick brief overview of how these two systems work?
Yes, thank you, madam. Good afternoon to all. As a working in the government medical college, we all know about the NTEP. Previously, we used to call it as a RNTCP. It's a control program. Now it's changed to the elimination program. As TB is a 5th leading cause of death in the India, and 65% patients are from the rural category. So government has to intervene for the control and elimination of TB. In 2017, there is a major change in the TB elimination program. There are 4 major changes were done by the government. First is the mandatory notification of the AFB positive patient to the government center. Second is availability of the molecular testing at the district level. Third is the active case finding, and fourth is a merge of NTEB program with the NACO to find out the TB associated with HIV infection. NTEP program was launched in January 2020 with the 2 main goal. First is the 90% reduction in the death associated with TB as compared to the 2015 data. And second is the 80% reduction in the TB incidence rate as compared to the 2015, and government will achieve this target by the 2030 as they mentioned in 2022 data. Then which are the different facilities which provide through the NTEP. NTEP is functioning for mainly for 4 areas. First is to develop a plan. Second is to detect the TB at PHC level. Third is to give the treatment to each and individual TB positive patient. And fourth is to prevent the TB to the contact person in the family and etc. Being a microbiologist, second word, that is detection of the TB is our main concern. There are main 4 criteria of NTEP for the detection of the TB. First is the TB screening at the PHC level. That is microscopy facilities available at the all PHC level. Second is the facility of CBNet and TrueNet at the district TB center, that is Jilla Kshay Kendra, what we called. Third one is the early detection of drug resistance TB. This facility is available at state TB center, mainly in the civil hospitals of each district. And fourth and most important is private sector management. Now NTEP is coordinating with the all private pulmonologists and infectious disease specialists for the further testing and management of the TB patient across the India. And after 2022, government has launched a Nikshay portal. All government colleges may know about the Nikshay portal. It's an online portal system which we can use on the desktop and mobile also. It has the 4 major modules. First is the registration of the suspected as well as the confirmed TB patient. Second is the detection and reports of the TB patient. When you registered your patient on the Nikshay, you have a one Nikshay ID particularly for that patient, and you can check all the reports and treatment sheet of that patient. Third is a treatment and follow-up of that patient. And last and fourth is a contact tracing of that patient of family members also. And lastly, all the facilities we can having by nearby district TB center. Just you have to assign a MOU with nearby district center, and you will get your Nikshay ID and password. Through that, you can utilize all the facilities of the NTEP program. And as Hardik saw our video, ke TB free Jeetega India. This is the goal of the NTEP program to achieve by the 2030.
Yes, thank you so much, Dr. Forum. And you can see how passionate she is for that program. Going into some clinical situations, that our responsibility is more towards our clinicians, you know, and it is a failure on the part of our fraternity if we are unable to convince the clinician that this is really going to help our patients. So knowing and understanding the technology is so important to know what to use where. So let's quickly take a peek into our brief discussions with our panelists. That I have a clinician who is suspecting pulmonary TB. He sent a sputum AFP smear which is 1+ positive. Dr. Neerav, what would you suggest as the primary test? You are talking with the clinician.
So for clinician, the patient should not or never be treated solely based on the smear. The first test should be either CBNet or the TrueNet. As the WHO is also suggesting to go for the CBNet or TrueNet as a primary test, replacing the microscopy nowadays. So this could be atypical mycobacteria or even tuberculosis. So you may never know. So first advice I will give to go for send the sputum for the CBNet or TrueNet. And accordingly, they can decide later on as per the result.
Correct. Thank you, Dr. Neerav. So history of the patient most important, because if the patient is on treatment 6, 7, 8 months and then coming to you, the probability responding, the clinician is going to tell you he is responding. So the probability of that being a dead bacilli is much higher. So you would also keep in mind that you might want to go in for an AFP culture because you are more interested in the viability. And this you will know only if you talk to your clinician. A positive smear does not always mean MTBC. You should know that. Would we want to move to CBNAT chip based? Yes, as he rightly said, but please talk, interact with your clinician. That is what they want. They want you to talk and ask because they are never going to learn to write the TRF with a detailed history. So we have to call them up. AFP culture remains the gold standard. Discrepancy between the results of 2 labs. If we have the time, we will discuss that. You could directly do all molecular tests from the positive smear sample. So CBNAT is positive and RIF is resistant. Dr. Neerav, I'll request you to please continue. How would you guide the clinician as a microbiologist?
So again, we need to discuss with the clinician whether it is a new case or it is a recurrent case or relapse is there. If patient is having history of any MDR TB in family or contact history. So if normally this is a clear-cut scenario. CBNet is positive or TrueNet is positive. RIF is detected and this RIF is resistant. So go for this either LP or the X-ray panel to detect the more resistant bugs, resistant pattern, and also the AB culture. The AB culture is the must to go for the phenotypic sensitivity testing.
Yes. Yeah, thank you, Dr. Neerav. Perfect on the dot. History of the patient, as I said, most important. Let's remember that this is a molecular test. Definitely could be dead bacilli also. Communicate. Previous report is sensitive and yours is resistant. This question is for you to think. પહેલા પોઝિટિવ ક્યાંક આપેલું છે, નેગેટિવ આપેલું છે, or sensitive rifampicin and you are getting resistant. Mixed population, heteroresistance. Request for CBNAT, XDR, LPA. Remember, what you've done is ultra. What you're going to do is not ultra. So you have to be transparent with your clinician. What is CBNAT ultra? I've told you. AFB culture remains the gold standard. Now, if RIF is sensitive, how are you going to guide Dr. Neera? What would you want? Clinician does not want further testing. Clinician says, I don't want to do anything. RIF is sensitive. I want to begin.
Okay, so if patient is naive and does not have any exposure previously to AKT, I think first line AKT should be fine. But again, I would normally recommend to go for the more detailed history. Isoniazid and monoresistant, this prevalence is still there. Around 8 to 10% of cases have isoniazid or monoresistant. So I would recommend to go for the isoniazid testing if clinician is agreeing. If no, better to start the AKT, keep the patient under monitoring, ask the patient to come back again after 1 month, do repeat the Zidane staining. If patient is responding, they don't need to go for do any further. If not, then again go for the AB culture and further testing. For that.
Very well said, Dr. Neera. So, if he does not want, where did I go back? History of the patient, as he rightly said, this is a molecular test. Viability is always questionable. RIF sensitive is not INH sensitive. You are a microbiologist and the clinician was sitting right next to your bench when you were in medical school. So remember, you are at par with the clinician. It is your responsibility to convince the clinician that this is the data, these are the publications, and INH resistance is going to be a big failure. And I think I have tons of papers here to show you, one of being our own publications of around 15,000 patients. That INH is a burning problem, lots of deaths due to that in smaller areas. So please insist to the clinician that you need to do INH. XDR, as I told you, you have to be cautious. Always remember low of the bacilli, mixed population, heteroresistance, and decision will remain on your primary results. AFB culture will be the gold standard. What you need to take back home and think is, CBNAT positive, what are the possibilities? CBNAT negative, what are the possibilities? If it is trace and indeterminate, what are the possibilities? We have at least 6 cases documented of trace and indeterminate, which were NTMs, right? In increasing the sensitivity, the specificity has taken a little brunt. So I think we have done this. So here,
just want to add.
Yes, please.
The trace positivity happens with the ultra and the MT plus kits. It is highly sensitive. But the thing is, when you process the pulmonary sample, then trace can be false positive. Extra pulmonary can be fine, very low bacterial bacillary load. But for pulmonary, to try to go for the older kits, either MTB or G4 kits of the gene expert. It is more for the pulmonary sample, especially bowel fluid and all that. So in that, again, if we want to report, discuss with the doctor, ask them to go for the AFB culture. If it is also showing the same, then you need to treat. If it is also showing the NTM, it will grow into this AFB culture. And again, all this, if patient is not very affording, then government is doing excellent program. NTEP is doing excellent job. You can send for LP, first line, second line. AP culture, they are going to do free of cost. And believe me, TET is excellent. Last month I got the LPA first line, second line almost just a month with the AP culture result.
Same
So
as
that is
private.
excellent. Same as private.
They are doing a brilliant job. And very rightly he said, when you're doing a CBNAT, even if your smear is positive, there is a difference between homogeneous sample and a non-homogeneous sample. If you're doing a tissue and you are mincing the tissue, the portion that you have for a smear could be smear positive and CBNAT negative. So we can't say, oh, this looks like an NTM, an indirect testing. Smear is positive and this is negative. So it's good to be a little patient and see what kind of a sample you're using. So maybe we could skip to Dr. Bhargav, that if the LPA second line and the XDR is positive, clear cut, we are giving a clear result to the clinician. Can we omit the AFP culture?
Good afternoon all. As ma'am already said, there is no alternative for the gold standard. Culture will remain the gold standard, so we cannot omit culture. Summarize the talk till now. If smear is positive, I would suggest directly go for the LPA. So you have both rifampicin and isoniazid. If smear is negative, then go for the gene expert. If you find gene expert, then you have the diagnosis. And with both, you have to go with the culture. Because after 1 month of treatment, if patient is not responding, and at that time you are going for the culture might get negative. So always go for the culture at the stretch. So to summarize this thing, so we never omit AFB culture, even if the any molecular test is suggesting positive or resistant.
Thank you so much, Dr. Bhargav. So same thing he said, history and communication with the clinician is the key. AFP culture remains the gold standard. The advantage is if an AFP culture is done and you have missed out on all molecular tests, once the AFP culture is positive, you could do everything that we described previously from the positive culture. So it's like a bank you have, you have the bugs with you, live bugs with you, you can do whatever you want with it. So it is good to always recommend an AFP culture. So now AFP culture is positive in the first week, Dr. Bhargav. Now what?
So again, as ma'am said, it's a history is must. Second thing, sometime if MTB infection is there and the load is very high, it can came positive in a week. And second possibility, and this is the most possibility, is a NTM infection. Usually NTM infection, if it is a rapid grower, it came positive within a week. So we have to keep in mind both the thing.
Thank you so much, Dr. Bhargav. Same, you have to differentiate MTB or NTM. You have the immunochromatography. Guide the clinician. Guide the clinician. There are specific guidelines of IDSA and ATS. I'll show you on the next slide, which recommend when you would call it significant, when you would not. Double checking results of other molecular tests if they are already done. If you have a gene expert positive medium and the culture comes positive for NTM, then what? You think? Do you always get a band of MTC in the immunochromatography card? How many of you are doing this card? Atlo uncho karjo hath, dekha hai wo. Very good. So how many times do you get a card negative? Your culture is B positive. The microscopy juo to tam saras serpentile cords you can see. And when you are doing the card, it is negative. So then what do? You say NTM? When you're seeing that, પછી આપણને confusion થઈ જાય કે આ શું કરીએ, ચલો આપણા ખર્ચે gene expert run કરી દઈએ, right? Because you don't want to be wrong in front of the clinician. So all those who are using midget, there is a printout that comes out every day which says growth units, GU. There's a print that comes out when it takes the reading. At times, midget gives a positive because the sample is not always homogenized. So it gives positive even at 250, 260 GU. So wait, don't remove your tube. Wait till the GU is 300. Only after 300 will it give you the right results. So in case you don't get a band and you think it is MTB, go back to the machine and check out on what your GU is so that you get an idea about what it is. So AFP culture is positive for MTB. Now what? Dr. Bhargav.
Yes, AFP culture is positive. So previously, if we have not done any molecular test, we have the bank and we can perform all the molecular tests if it's required. Second thing is conventional DST. We can suggest the clinician about the conventional sensitivity, and it gives us the result about the individual drug. While molecular test gives us the sensitivity and resistance about the group fluoroquinol on an aminoglycoside, while individual drug is can be possible with the conventional DST method. So we can do both if it was not done earlier, all molecular test and the conventional DST.
Thank you so much, Bhargav. I think this is all that he has said. The same things, you can do everything that is missed from that. Now AFP culture is positive for NTM and MOTT. Okay, NTM, MOTT. Now Dr. Anand, what could we do now with that sample?
First and foremost, if it is a pulmonary sample, directly calling with the clinician is very important because, right, you said that American Thoracic Society and IDSS published in 2007 and British Thoracic Society has modified in 2017. So any NTM from the sputum sample, or maybe say I'll go with the sputum first. So only single sample usually can be a colonizer. So subsequently, repeat sample expectorated, and if it again comes positive for the NTM same species, then only we can consider, along with the radiological as well as the patient history is always important. Either sputum sample is there, and if you and the clinician is gone for the BAL or any transbronchial or lung biopsy, or any histopathological resemblance of granulomatous inflammation on histopath, and the even BAL culture or transbronchial biopsy or lung biopsy is also positive for NTM, then definitely it is significant. Second thing is patient's HIV status. Particularly with the patient living with HIV, there is high probability of having Mycobacterium avium complex, and it can cause the severe pulmonary diseases. So these are significant things we need to keep in mind.
પતાવું 3 સ્લાઇડ છે લોકોને ચાલે એવું છોકરાઓ થાક્યા છો
So always go with the identification. If it is pulmonary specimen or extra pulmonary, definitely we have the history, surgical site infection, any prosthetic joint or any foreign bodies there, mesh, appendix, even laparoscopes, because these are the notorious bugs which survives even in the disinfectants. Glutaraldehyde, it doesn't kill this. So even here the history is very important. Here the clinician communication is very important, particularly when you are growing NTM or MOTT.
કરેક્ટ થેન્ક યુ ભાર્ગવ આઈ ગોટ આનંદ આ બેલ વાગ્યો ને એમાં હું ડિસ્ટ્રેક્ટ થઈ ગઈ સો when he is talking about NTM, also remember blood cultures positive for NTM. Don't miss out on that. Blood culture positive આવ્યું, તમે જોયું અને ગ્રામ પોઝિટિવ બેસિલાઈ દેખાયા તો તરત લાઇટ થવી જોઈએ કે આ કીમોપોટમાંથી સેમ્પલ આવ્યું છે or a compromised patients, because NTM frequently we find even in blood cultures. So be that, keep that in mind, not responding for a long time. Communicate, he said, relevance, he said, NTM are normal colonizers. These are the ATS guidelines, very, very clearly defining. You need to know this and have this, then and then you can talk with your clinician. So the clinician says that NTM MOTT is a pathogen. How will you guide him, Dr. Anand?
First and foremost, identification. So we have, either we can go with NTM PCR, now it is available, but again it's a commercially available kits and there are chances that it may come false negative, but LPA is always susceptible in resource limited setups. So LPA usually what you shown that 16, and if that common species are not, then we have the option of additional 17. So majority of the NTMs, most common is Mycobacterium abscessus, Chelonia and fortuitum. So that are detected with the LPA. Post identification, definitely you need to go for the sensitivity, because without sensitivity you cannot treat NTM or MOTT, because RGM has different treatment options while the slow grower has different treatment options based on their identification. And now with Malditoff is available, we can have that luxury that whichever the NTM is there, we can definitely identify. But yes, the identification and sensitivity is very important.
Very important. Thank you so much. Brilliantly said, Dr. Anand. When I said chemoport, remember post-angioplasty. We've had tons of epidemics across the state. Post-angioplasty, blood cultures growing NTMs. Remember that this is a problem of sterilization, because things that are used have not been sterile. So keep an eye on your blood cultures. They are colonizers, significant rise, post-laparoscopy, cesarean sections, etc., all because of compromised sterilization. It is recommended. 31 evidence-based recommendations about the treatment of NTMs are there. NTM represents over 190 species, of which MALDI is giving you 176. So which is, you can't ask better. This what I'm showing you, just the red ones you can see, just for small two things. There are, it's a big Gita, Bhagavad Gita, but just to understand what Anand rightly said, that ID is very, very important. Susceptibility testing is very, very important, because if you see Kansas, they will have to treat it like the first line. They will need rifampicin. So if you just say NTM, they will start treating with macrolides, right? So you need to identify the bug. And even when you do clarithromycin for abscesses, we just discussed it in one of our meetings, you have to incubate it for 14 days to rule out inducible resistance. Or we have started now doing the ERM41 gene, so that we know if that is present and how it will reflect with that. So just read this. Now you have to go and check this out. Previous report, RIF sensitive, RIF resistant. You could have released a CB NAT sensitive. Patient not responding. CB NAT was positive, but NTM has grown in culture. Reported LPA sensitive first line and patient is not responding. This is the publication which includes everything that we discussed today. Isoniazid resistance is a huge thing linked with tuberculosis deaths, Europe. Again, the publication, good news for us, they are beginning clinical trials of TB vaccine in India. This is just a quick load to positivity. What test detects what? હવે ઉપર મારું પેલું superimpose નહોતું થયું એટલે 10 raised to 4 છે. Don't read it as 104. 10 raised to 4, 10 raised to 5. I could not push it forward. So that is it. And this is just a small chart I have tried with difficulty to give you an idea of how will you proceed with whatever test there. This is all the practical aspect of how you are going to proceed with a clinical sample. So what would we say? We would say stay current. If you don't know your subject, you will never be able to talk to your clinician, or if you get an interesting result, you will omit it ke bhai aa badi magajmari thase. So be current and interact with your clinician. It's okay to open up your book then also and read once it gives you the history. Samples and TRFs are our patients. Patient is never going to come to us. So the sample and the TRF that comes to you is your patients and relatives, and the spouse is the clinician, of course. So talk to him all the time. A clinician wants answers. You know, their requirement is, they are not microbiologists. So they want answers from you. Sahib, aue lage che na, aue lage che. So they are not interested. They want either it is A or it is B. So be clear before you talk. What are you going to tell them? Never forget INH monoresistance. Please don't forget that. Eradication of TB has many, many team players. We are one of them as microbiologists. Let's do our role thoroughly. અને મેં પહેલી સ્લાઇડ બતાવી હતી, હવે સ્ટ્રોઝ આવી ગઈ છે, એટલે કાંકરા નાખતા નહીં. You use your straw and drink it well. Thank you so much for your attention.
Thank you so much, ma'am, and thank you so much, our panelists. I would request Dr. Bhavani, ma'am, to felicitate our knowledgeable panelists. I request Dr. Gauri Shankar sir to felicitate Dr. Bhavani ma'am. Thank you so much, sir. Before proceeding for lunch, we have an announcement. Poster presentation is scheduled at Seminar Hall 1 after lunch. We request all the participants and judges to be there as per schedule. I would like to request all of you to proceed for lunch at Multipurpose Hall, ground floor. Thank you. I request everyone to be back in the hall by 2 p.m. We'll move forward for further lectures and inauguration ceremony. Thank you.
Please do not miss the beginning.
Asif bhai, welcome Asif bhai.
Yes, Asif bhai, come on. Come on the stage. આ ખોવાઈ જાય તો એની અહીંયા
તમારા ભરોસે મૂકી ગયા.
બેગ અને કોટ પણ મૂકીને ગયા છે, જે સૂટનો ઉપરનો કોટ હોય એ બધા અલગ અલગ લોકોએ મૂક્યા છે. પ્લીઝ
food certificates, and halal. We have created products and systems to fulfill the complete needs of microbiologists and other researchers in the field of life sciences, with a focus on microbiology. Our portfolio includes biological media bases, dehydrated culture media, media supplements, ready-to-use culture media, among others. In fermentation industries, biological media bases play a significant role as they contribute to a plentiful supply of carbon and nitrogen sources, resulting in high production yields of microorganisms. In India, we are one of the largest manufacturers of the ingredients of culture media, with a production capacity of over 2,000 metric ton per year. We plan to expand this capacity even further in the near future. As a sustainable alternative, we also offer a range of plant-based biological media bases. We manufacture a wide variety of dehydrated and chromogenic culture media. Our portfolio includes over 2,000 varieties, available in homogeneous mesh size and as a free-flowing powder, which is stored in airtight sterile HDPE box equipment. There are separate laboratories dedicated to microbial and chemical testing. The Quality Assurance Department works towards quality assurance and documentation by making sure these laboratories operate under strict GMP, GDP, and GLP protocols. Thanks to the well-equipped storage facility, the movement of materials, in-process items, and finished products, as well as transfers between and within work centers, can be tracked on a real-time basis. This is one of the reasons why our team is well known for always ensuring timely dispatches in spite of our huge and diverse inventory. Another very important reason for our success is our people. They have embraced our vision and made it their own, working collectively and consistently to deliver superior quality biotechnology products. It is through the combination of a visionary outlook, never-ending research, innovative technology, and great teamwork that TM Media has made its mark globally and become the preferred choice of microbiologists in over 77 countries. Our commitment is to continue to evolve and innovate so we can keep fulfilling microbial product needs for our clients across the globe, helping them grow and nurture their products, services, and industries. The production of ready-to-use plates is another milestone that we have achieved. We have the capacity to produce 40,000 plates per day. Apart from the fact that these are ready to use, the culture media plates are also easy to use, free of contamination, and accurate in composition and consistency. The traceability content of each plate is printed on the edge rather than on the bottom, which gives an easy and accurate reading on the colony counter. These plates are available in 90 mm and 55 mm sizes, with a wide variety of culture media to support your laboratory needs. The plates have a shelf life of 60 to 150 days, and these are also available in gamma irradiated triple packaging. The production
हेलो हेलो बाहर जी में हेलो 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 સંભળાય છે ઇકો થાય છે હા ઇકો નથી થતું અને તું પેલા માઇકમાંથી બોલે છે ને એટલે મને તો ક્લિયર સંભળાય છે રૂમમાં હા અને ઇકો નથી થતો ને મારો અવાજ ત્યાંના સ્પીકરમાં આવે છે ને હા બસ તો પછી બરાબર
Welcome to the world of quality. Well,
I have joined. I have joined. Yes, 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 yes. शेयर स्क्रीन करूं मैं अपना? ऐसे करूं? नहीं समझ में आ रहा है मुझे। नहीं, आपका वॉइस थोड़ा लो है। थोड़ा और जोर से बोलेंगे? नहीं सुनाई दे रहा इतना क्लियरली। पहले क्लियर था। अभी ठीक है? क्लियर नहीं है, आप लोगों का स्पीच क्लियर नहीं है। बोलिए बोलिए. नहीं मुझे ना बराबर से नहीं सुनाई दे रहा आपका. क्यों ऐसे हो रहा है? पहले एकदम क्लियर था. आप फोन पे करते हैं, फोन पे बात करते हैं. चलो मैं फोन पे बात करती हूँ. मैं फोन कर रही हूँ आपको. हेलो हेलो. हाँ. ओके ओके. हाँ. Yes. हाँ. Yes. अभी कैसा है कैमरा? Come out like this. बट मैं ऐसे बात करती हूँ, मैं ऐसे बात करती हूँ. ठीक ना? ओके. डन. ओके ओके. हाँ हाँ. आई विल. ओके. डन. श्योर श्योर. ओके डन. श्योर श्योर. ओके डन. Good afternoon, I'm Dr. Anjali Shetty, and today I will be telling you about a mycological test that one can use to diagnose a fungal infection. There are various modes by which one can diagnose a fungal infection: microscopy, culture, use of biomarkers, susceptibility testing, and therapeutic drug monitoring. Let me go on to my first case. This is a case of an 18-year-old gentleman who presented with a swelling in his shoulder. This swelling in the shoulder, yeah, can you hear me? Yes, 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 I can hear you clearly. Yes, yes. हाँ, हाँ, okay, okay, fine. So, हेलो, बोलिए, हेलो. Yes. No, now should I disconnect? Okay, then I'll stop share. Is it now? Stop share करूँ? एक काम कीजिए ना, आप जब भी मेरा टॉक है ना, उसके 5 मिनट पहले मुझे फोन कर दीजिए.
चलेगा ना, क्योंकि थोड़ा मुझे टाइम लगेगा टू अरेंज इट. हाँ, चलेगा ना? ओके, डन डन. मुझे फोन पे कॉल करना मुझे. हाँ, थैंक यू. बाय बाय.
The candidates who have submitted their posters, there is in seminar room 1. The poster presentation has been started in next 5 minutes in seminar room 1. Please convey message who is participating in the posters presentations. Go to the seminar room 1, just nearer to the opposite side, nearer to that particular our multi-purpose hall. Okay, so there is some work going on. Just ask them on the ground floor, seminar room 1. And any faculty is also interested, any of participants also interested to join, there is enough space to review this or the posters. The judges are already available there. Thank you.
એને ફોન કર્યો હેતલ મેડમ પછી હું આવું માઇકનું અરેન્જમેન્ટ કરી લેવાનું છે હું આ લઈને આવીશ તું ત્યાં જતી રહે
Hello, hello. We request everyone to join for our next session. Sagar. We request you to ask your colleagues to join so we can start the session ASAP. So if you are interested, please call everyone.
Good afternoon, everyone. We are starting the session very soon. Please settle down. I request you all to settle down. Please take your seats. We have our GMC observer among us. So please settle down and show him some decorum being maintained. Please settle down and please call your colleagues to the hall. One more reminder, the poster presentation is continuously going on in SF1. So all the participants and judges, we are starting the session, the post-lunch session. It's good to see you all back well in time.
चलो चलो अंसर भाभी, देर मत करो।
अरे आ रही हूँ, वो सिफरा तो गिर गई थी, मैं तो नहीं गिरूंगी। हेलो हावर, खाना खा के जाना। ये मगर खाना खा लिया है ना इन लोगों ने, तो ठीक है, तो फिर हम शुरू करते हैं।
अरे वो नहीं, जाने दो हंसा भाभी, मैं नेक्स्ट चेयरपर्सन को बुलाती हूँ। I would like to invite on stage our next chairperson for the session, Dr. Hetal Vasani, Associate Professor, BJ Medical College, Dr. Madhulika Mistry, Associate Professor, PDPU Medical College, Rajkot, Dr. Mitesh Patel, Associate Professor, MJ Institute of Ophthalmology.
Let's have a round of applause, please.
We welcome Dr. Anjali Shetty, Madam, to join us.
There is one announcement regarding the same. It's an online lecture, so we'll ask everyone to be present here and attend the same.
I request Dr. Hetal Vasani, Madam, to introduce our esteemed speaker.
Very good afternoon. Dr. Anjali Shetty is a consultant microbiologist at PD Hinduja Hospital, and she is also in charge of Advanced Regional Mycology Lab for the Western India. She has been awarded with the MRCP and FRCP. Welcome, Madam.
Yes, I can hear you. Yes. Yes, share screen. You can see? Start now? Okay. Good afternoon, everyone. I'm Dr. Anjali Shetty from PD Hinduja Hospital, Mumbai. I would like to thank the organizers, especially Dr. Kamlesh, for inviting me for this conference of yours. So I'll be speaking to you about mycology tests. There are various tests that one can use to diagnose a fungal infection, and let's see what they are. First of all, I'll start with this case. 16-year-old gentleman who presented with a shoulder swelling, and this swelling was full of pus. It was an abscess on the shoulder. He also had an ankle swelling which was full of pus. So the doctor, thinking it could be TB, sent the sample for TB culture, and we did a ZN stain. When we did the ZN stain, we saw these round structures, and these were encapsulated as well. Now, what could this be? It's a fungal talk, so it has to be a fungus, but which one? Is it Histoplasma capsulatum, Candida, Blastomyces, or Cryptococcus? Now, histoplasma is very small in size, and actually this capsule is not a real capsule. It appears. Candida doesn't have a capsule either, much smaller in size. Blastomyces has a thick cell wall, and appears to have a double cell wall, but the size is quite big. And Cryptococcus is the one which this patient was not immunosuppressed. He did not have HIV. So why did he have this infection? So we went and inquired from him and found that he lived in Kabutar Khana in Dadar, which is just next to where all the pigeons come and they are fed over there. And we also checked his blood for CD4 lymphocytes and found that he had CD4 lymphocytopenia. He had a count of less than 300, and that predisposed him to this cryptococcal infection. Now, it's important to know if you're dealing with Gattii or neoformans, and this medium, cannavanine, glycine, bromothymol blue agar, helps you differentiate between the two. Gattii assimilates glycine and produces this blue color, whereas neoformans does not. Now, why is it important? Gattii has more predilection when you have CNS cryptococcus. It has a predilection for the parenchyma. There is more neurosurgical intervention required. It's more difficult to treat, and more immunocompetent patients have this infection. What are the other tests that you can do to diagnose this infection? A cryptococcal antigen test, or CRAG. It's best test. It can be done on CSF and serum. It has a great sensitivity specificity, more than 95%. You can also get a quantitative result with this. Now, India ink, which is quite often sent on the CSF, does not have very good sensitivity, particularly in non-HIV patients, that is in your renal transplant population. And a PCR test, like a biofire test, the meningitis encephalitis panel, it has a lot of false negatives. So even when your CRAG is positive in the CSF, you will find that the CSF biofire may be negative. In case of pulmonary cryptococcosis, always look for dissemination. Do a serum CRAG, do a blood culture, do a CSF, do a TAP, do a CSF culture, and look for the CSF CRAG as well. So these are the new guidelines that have come out in 2024 for cryptococcosis, and they clearly say that for all patients with suspected or confirmed cryptococcosis, you must do the following. And what is it? Look for dissemination. And how would you do that? Do a lumbar puncture, do a CRAG, cryptococcal antigen on the CSF. Quantify the blood cryptococcal antigen. Send cultures of blood, cultures of sputum, and do imaging of the chest and the brain. Now, can a cryptococcal antigen be performed on respiratory samples? It is not performed quite often, but it can be performed. Does the titer of CRAG matter? So if you're doing a latex test, if you have a titer which is greater than 512, then that would mean that the disease is disseminated, that the patient has a bad prognosis, and that the fungal load is very high. If you are doing a lateral flow assay, then it's 10 times higher titer that you need to prove that it is disseminated infection. How often is serum CRAG positive in pulmonary cryptococcosis? So if you have an HIV positive patient and you have isolated pulmonary cryptococcosis, almost always the serum CRAG is positive. Whereas in an immunocompetent patient, the serum CRAG is almost always negative in isolated pulmonary cryptococcosis. But in between, any other type of immunosuppression will give you a sensitivity of 50% for serum CRAG. So take-home messages, I think, beyond TB, perform serum CRAG, perform CSF CRAG, do a blood culture, do a CSF culture, do a sputum culture, and do imaging, and India Inc. has poor sensitivity. My second case is a 58-year-old male, a known hypertensive, who had a renal transplant long ago. He was on MMF, tacrolimus, prednisolone, and he developed a brain abscess. This is the imaging, and here is the abscess. Now, the most common cause of brain abscess in renal transplant patients is due to a fungus, nocardia, toxoplasma, or TB. The answer is fungus. And which fungus is it? Is it crypto? Is it aspergillus, dematiaceus, that is a black fungus, or pseudolisteria boydii? So it is dematiaceus. It's a black fungus. And the one that we found in this patient is the most common one, which is Cladophylloflora bantiana. Now, here we looked at the calcofluor of that brain pus and we saw septate fungal filaments. Now, septate fungal filaments can mean anything: aspergillus, fusarium, scerosporium. So immediately we looked at this slide under a light microscope and we saw these pigmented melanized fungi, which means it's a black fungus. Why is this important? Because for aspergillus, you need a single antifungal. Whereas for this infection, you need triple antifungals, amphotericin B, voriconazole, and 5-FC. The culture takes at least 3 weeks to grow, so it's very important to diagnose it on microscopy. And here it is, after it's culture positive, this is the wet mount. So microscopy is rapid, it has an increased yield of up to 20% compared to culture. And calcofluor is particularly sensitive as compared to a plain KOH. What information do you get from microscopy? You know if it is septate or aseptate. Aseptate means mucormycosis, and septate can mean a whole lot of fungi, as we already discussed. Mucorales are usually culture negative, so microscopy is very important to start treatment. PCP as well can be diagnosed on microscopy, either on calcofluor or GMS. Immunofluorescence is much better, and BAL is the preferred sample for non-HIV patients, especially for PCP. Here is my third patient. Again, a 20-year-old gentleman who suffered from ALL, and he finished his first cycle of chemotherapy. He was not neutropenic, he was not febrile, he was sitting up in bed, and he complained of a slight pain in the neck and a swelling in the neck. So a scan was done of the thyroid gland, and there were hypoechoic regions seen on the ultrasound scan. So now a biopsy was done. And what investigations would you send? You'd look for fungus, you'd look for TB, you'd look for bacteria, all of the above. Now you would look for all of the above, but the interesting thing is that the most common microorganism to cause an infection in the thyroid is a fungus. And which fungus is it? Is it Aspergillus, Mucorales, Candida, or PCP? So Aspergillus is the most common fungus to cause thyroiditis. What did we find on calcofluor stain? We did not find Aspergillus. We found these broad aseptate fungal filaments, which would indicate mucormycosis. Now that was quite scary. In a well patient sitting there finding mucor in the thyroid, you would expect a mucor patient. At least chest X-ray showed some lesions there. And here was the big nodule on the CT scan of the chest. And here his spleen was also involved. So this patient, because of the positive calcofluor, went on to have a splenectomy, thyroidectomy, and lobectomy, all within 48 hours of our calcofluor result. And the patient did very well on amphotericin B. Culture didn't grow at all in this patient. So, the calcofluor stain can be life-saving. Now, case 4. What fungal infection is seen most often in road traffic accident cases? Is it mucor, Candida, Aspergillus, or Fusarium? It is mucor. So, of the mucor, it is usually Succinia or Apophysomyces, which do not sporulate on solid media like this. On Sabrose agar, it will not sporulate. You will only see hyphae. So, how do you diagnose which one it is? You have to put it in a water agar, and then it starts sporulating, the Succinia and the Apophysomyces. And when you know that it is Succinia, this flask-shaped collection of spores. Moving on to this question, blood cultures are negative for which of the following fungi? Histoplasma, Aspergillus, Crypto, or Trichospora? The answer is Aspergillus. Even if you have Aspergillus endocarditis, you will not get a positive blood culture. So Aspergillus in a blood culture is almost always a contaminant. All other fungi can grow. Or histoplasma can grow, crypto can grow, trichosporon can grow. Mucor as well doesn't grow well in blood cultures, mucormycosis. Even for Candida, the sensitivity of blood cultures is quite low, 50%. And you need to send a lot of blood, up to 60 ml, to get a positive culture. Glabrata quite often grows in the anaerobic bottle, and it grows quite early in the anaerobic. Are fine. The next case is an ALL patient who has a central line, is febrile, he is neutropenic, and has had prior fluconazole prophylaxis. And his blood culture flags positive. So you do a gram stain. And here you see these budding yeasts. Now, what are you thinking of? Is it Candida, Trichosporon, Cryptococcus, or Histoplasma? I would say Candida. Most likely, it's going to be Candida, right? And what would you use to treat this patient? Being a neutropenic patient, he's had fluconazole prophylaxis, you would want to use an echinocandin on this patient. So that is your drug of choice, okay? Now, what you start seeing is dry, wrinkled colonies as it grows on the agar plate. You do a urease test, the urease test is positive. Now, what are we thinking of here? And when you do a wet mount, you start seeing these arthroconidia and these round blastoconidia. So, what are we dealing with? It's absolutely clear that we are dealing with trichosporon, most likely Asahi. How will this result change your management? Remember, you were on caspofungin. Will you continue or will you change to something else? So the drug of choice is voriconazole for trichosporon. So you change to voriconazole. So beware that anything that looks like candida on a plate, be sure to do a germ tube, a urease, and an LCB mount. This is absolutely important. Candida in the respiratory tract, don't worry about it. It's a colonizer. So this was a 2-year prospective study done in Belgium in 1,587 patients admitted to the ICU, of which 301 died, 200 odd autopsies were done. 60% of them had pneumonia of the people who had autopsy. 60% had BAL positive for candida when the patient was alive. And in the other half, there was no candida isolated when the patient was living. But none of these patients had candida pneumonia. So candida pneumonia is something that is a very, very rare entity, doesn't even happen in neutropenics unless you have really disseminated candidosis and you have necrotizing candida pneumonia, which is something that none of us have seen and nor is it reported much in the literature. So even in an immunocompromised person, if you find candida in the respiratory tract, ideally we should not be treating it. But beware that you don't lose out on your cryptococcus. If you see a yeast-like colony, make sure you do a make sure you do a wet mount, make sure you do a urease, and you will pick up cryptococcus. What about aspergillus in the respiratory tract? The sensitivity of microscopy and culture is not that great. 50% for BAL, 8 to 30% for sputum. So really not great. If it's sending sputum, send 3 sputa. And even if you do culture it, are you dealing with infection or allergic conditions or colonization or lab contamination? We don't know. It is quite often a lab contaminant as well. What about candida in the urine? And the patient is asymptomatic. Should you treat? Quite often, these are just colonizers, especially if the patient is catheterized. So you don't need to treat. But you do need to treat in neutropenics, low birth weight neonates, and if there is instrumentation of the urinary tract. By instrumentation, I don't mean catheterization. We're talking about cystoscopy, that sort of thing. What antifungal is the best to treat cystitis? Which one is the best? Of these, the best is fluconazole, okay? That's the best antifungal. Voriconazole doesn't get into the urine. Echinocandins are not great unless you're pushed against the wall. Liposomal, no. Deoxycholate is better. Okay. My next case is a 65-year-old man with COPD on long-term steroids who presents with cough, fever, shortness of breath, and the sputum reveals fungal hyphae on microscopy. Now, is this significant? You've got microscopy, but for URTC MSG, you need host factors, you need radiology, and you need microbiology. So you only got the microscopy. What do you do with this? What are the traditional host factors? All of these, that is stem cell transplant, neutropenia, solid organ transplant, prolonged neutropenia, steroids, CGD. But now there are new risk factors like ICU, COPD, which our patient has, cirrhotics, influenza, COVID, all of these are new risk factors for invasive pulmonary aspergillosis. The chest X-ray is normal, what would you do? So the radiology is not fitting now, so what would you do? Then you have to do a HRCT, and though the chest X-ray appears normal, you may end up seeing a halo sign on the CT scan of the chest. Now, do you know that it is definitely aspergillus? No, you don't, because all of these organisms can also give rise to that halo sign on the CT scan of the chest. And besides, it's not always that you will see a halo sign. Halo signs are seen in neutropenic patients. In the other patients, you're likely to see, you could see just a nodule or consolidation or peribronchial infiltrates, pretty much anything. So now the patient has got a host factor, he's got the radiology, and he's got microbiology, which is the microscopy being positive. So the patient is a probable case of invasive pulmonary aspergillosis. What would you do to prove this? You would need to do a biopsy from the sterile site, that is from the lung. So You need to do histopath and culture from that sterile site. So on biopsy, if you see these septate fungal filaments with acute angle branching, and if you grow it on culture, then yes, this is aspergillus. Because just seeing it on microscopy doesn't assure you that it is aspergillus. It could be fusarium, scedosporium, you don't know. How will you treat this patient? Depends on what you culture. Here is a nice fumigator, voriconazole, wonderful, it will help. But this, which looks just like fumigator, is actually lentulus. It has a small head and it doesn't grow at 48 degrees Celsius. Fumigatus does grow. This one is resistant to almost all antifungals. Here is Stereus, which is cinnamon brown, and this is resistant to amphotericin B. And here we are dealing with nidulans. The Hulle cells of nidulans, again, resistant to amphotericin B. So the culture will tell you what antifungal to use. This is my next case, a 60-year-old gentleman who went to Arizona in the United States of America to meet his son and spend a month with him over there. He came back and in 15 days, he developed a fever, he developed a supraclavicular swelling, he developed a cough, and this was the CT scan, there's a cavitatory lesion there. He was thought to have TB and he was started on TB treatment, but he was not improving on that treatment. So then a biopsy of the supraclavicular lymph node was done, and here we see these giant cells and we see these spherules with endospores in them, spherules with endospores. So what is this going to be? This is Coccidioides immitis from Arizona, USA. The patient was started on fluconazole therapy immediately. Here you can see it growing on culture. It takes up to 3 weeks to grow. It's this cottony white growth. And this is what you see on the LCB mount. These blank cells and these barrel-shaped cells, alternating blank cells is what you see. Okay? Now, this is a dimorphic fungus. It is in the yeast form in the body and mold form at room temperature on the culture plate. Which of the following is not a dimorphic fungus? Penicillium marneffii, Histoplasma capsulatum, Sporotrichschenkia, and Malassezia furfur. So the answer is Malassezia, which is a yeast. It's not dimorphic. It's not a mold. Now this patient, the doctor refused to stop the TB treatment. He added the fluconazole in, but the riff in the TB treatment was actually causing the induction of enzymes and breaking down the fluconazole. So fluconazole was not working. It's an enzyme inducer, rifampicin. And that was leading to breakdown of the fluconazole. And this patient developed lesions in his wrist as well and was really getting worse. So the TB treatment had to be stopped, and then the patient started getting better on fluconazole. Now my next case is a 51-year-old lady with a parietal lobe abscesses. In 2017, she had these multiple abscesses and anaerobes were grown from this, and she was treated with metronidazole and did really well radiologically and clinically. The following year, the patient decided to stopped the anti-epileptic treatment. And then she started having seizures and she presented to the casualty with seizure and fever. She recovered within a few hours, and as part of routine blood cultures were sent. Cultures grew oris, Candida oris, can be ignored. It certainly not, right? But the patient was well, afebrile, discharged, no symptoms of endocarditis, nothing to suggest candidemia there. There were no risk factors. There was no central line put in the patient. Blood investigations were fine. What do you do with this? We then found out that the same blood, the other set of the blood culture, the other bottle, which means that the blood culture was not collected as well as it should have been done. So there is some element of contamination. So could the Candida auris also be a contaminant? It's really very risky to call a Candida a contaminant. So you have to be absolutely sure. And what was done was a serum BDG and repeat blood cultures were sent, okay, to rule out Candida. And the serum BDG came back as 58. So it came back negative. And the repeat blood cultures were also negative. And hence the patient was not followed up. We did not call the patient back again. BDG is a major component of the cell wall of most fungi with the exception of Cryptococcus. mucorales, and blastomycosis. So in these three, it is negative, but in the others, it is almost always positive. But there can be a lot of false positives. Hemodialysis is no longer a problem because we do not use cellulose filters for dialysis. Intravenous immunoglobulin, IV, intravenous albumin, other blood products, all of these can cause false positives. Certain antibiotics, augmentin, piptazo, surgery in the last 3-4 days can give a false positive. So you need to wait for 4 days, perform the test on the 5th day. Bacteremias as well, Pseudomonas, streptococcal bacteremia have also been suggested as giving false positives. Also, Candida colonization in the respiratory tract can give rise to a false positive BDG. False negatives can occur if the patient is on treatment. If your bilirubin is high, also you can get a false negative. So you can use it to diagnose IFI, to exclude an invasive fungal infection. Can you use it to assess treatment response? Not really, because it does not go down as fast as it should. It remains positive for much longer. It's used to diagnose PCP, aspergillus, and yeast most often. So the EORTC MSG have come up with these criteria for PCP pneumonia. Proven is when you have clinical factors, radiological factors, and you have microscopy positive, that is immunofluorescence stain positive. Okay, conventional or immunofluorescence staining. Probable is when you have the host factors and the clinical factors, plus you have a PCR positive for PCP or BDG is positive. So now BDG can be used. It's as good as a PCR according to the EORTC MSG criteria. Case 9. 85-year-old male had COVID, received steroids, remdesivir, not improving, not able to come off oxygen, steroids, worsening cough, repeat chest x-rays, back counts are going up. What is going on? Is it bacterial? Is it fungal? A CT is done, a lesion is seen there, which doesn't look typically fungal, but you never know. BDG done, 14 negative, serum galactomannan 0.59. What do you do with this? Bear in mind, he's a non-neutropenic patient. So the serum galactomannan doesn't perform as well in non-neutropenics. But it is slightly positive. Do you treat? Do you not treat? What should you do? Now, what does EORTC MSG criteria state? You need to have a level of greater than 1. Okay, and we are on 0.59. So BDG is negative. It ideally should have been positive. Okay, so good negative predictive value with that as it's negative. Serum galactomannan very marginally raised, but patient has been on piptazo, which can give a false positive galactomannan. CT chest doesn't look clear as a fungal pneumonia, but who knows? You never know. Then repeat values are done, and here they're completely negative, the serum galactomannan and the BDG. And this patient was discharged home, not on antifungals. So serum galactomannan to diagnose invasive pulmonary aspergillosis, the cutoff is 0.5 according to the kit, and with this, the sensitivity is about 80% in neutropenics. In non-neutropenics, it's about 30%. Again, it has to be performed with utmost care in the laminar hood. Piptase can give rise to a false positive, especially generics. Other fungi like Penicillium, Histoplasma, false positives. Children under 3, heavy pasta meal, plasma light, and if the patient is on treatment, you can get a false negative. So it can be used to monitor treatment. Some people suggest two consecutive tests. It's important to use it to monitor clinical response. If your galactomannan is going up, you need to be worried. In patients with iris, so in a neutropenic patient who's got a chest infection, if the counts are improving and the chest x-ray is getting worse, but your galactomannan is coming down, you can be reassured. It has a good negative predictive value. What should be the cutoff in BAL? BAL is good, so it works well for your non-neutropenics who don't do so well with the serum. It's good for that. At the cutoff, we are not really sure what it should be because ultimately BAL is not a steroid. 2-year-old lady who presented with a 2-week history of fever, joint pains, shortness of breath, and she had these consolidation and ground glassing on CT scan. She was thought to have BOOP, myositis. She was put on pulsed methylprednisolone for 3 days, and a BAL was done latent. And the value of the galactomannan done on the BAL was back at 6. Positive, right? But on steroids, the patient's CT scan improved. So why do we have a level of 6? Now, we thoroughly investigated this case and we found that this was because the container in which the ball was sent, it was a container in which we send all our cultures to microbiology, all our sterile cultures to microbiology, or the sterile container in which the microbiology cultures come. That was the dabba. And that was what was contaminated with galactomannan. So from then on, we have not been transferring balls into that container. The ball comes directly in the trap, the Romson's trap, the green one, and we are fine. We are not getting false positives. And we actually published this in Lung India. Galactomannan is a very tedious test, and there are these lateral flow assays that can be used instead for detecting Aspergillus infection. So there's one by OLM, the lateral flow device, and this detects only one antigen, detects the antigen that binds to monoclonal antibody J5, can be done on serum and ball, and it's a qualitative test, it's a rapid test. There's a better test, that is the Inisona LFA, lateral flow assay, which detects two antigens, that is the antigen which binds with any A5 monoclonal antibody against the galactomannan epitope, it's exactly like galactomannan, but it has another undisclosed antigen that it detects. Again, can be done on serum and ball, and it's a quantitative result, and you have this reader that you can use. That gives you a value for the LFA. So which one is better? These point of care diagnostics. On blood, the LFA Inisona one is far better than the OLM one. And in ball as well, it does much better. So here it looks like it has better specificity, but overall, the LFA is far better. And if you compare it with galactomannan, you will find that the LFA has a sensitivity of 0.41, which is even better than galactomannan. Why? Because this has two antigens, right? The galactomannan antigen and the undisclosed antigen that it detects. But overall, the positive predictive value is best with galactomannan. Much lower with the lateral flow device, that's the Inisona one. We do have PCRs now for Aspergillus, and we're doing one on ball in our setup. We took 29 samples to validate it. 19 of them true positive, 10 were true negatives, and we found that we didn't have any false positives, but we missed 4 cases, 4 false negatives. So we had a sensitivity of 78% and a specificity of 100%. So this is the kit that we are using, Aspergillus, which detects the Fumigatus tereus and all other species. And there is an additional kit that you can buy to look for voriconazole resistance. So I've spoken about a whole lot of tests for diagnosis of Aspergillus, and what I would like to say is that the tests on the blood, the PCR on the blood, the galactomannan on the blood are far better than doing these tests on the ball sample, the galactomannan on the ball or the galactomannan, the PCR on the ball. And then direct examination, microscopy has much greater weight than culture. So some tests are better and have more weightage than others. Mucogenius is another test, Muco PCR that we have started. The kit is Mucogenius. There's our evaluation suggests that it had a sensitivity of 74% and a specificity of 100%. These are 2 papers which have evaluated this particular PCR test, and they have found a good sensitivity and specificity. This is on respiratory samples. Please note the number of cases are very small. We have evaluated 17 positives and 10 negatives. And here there were 16 proven cases, and the sensitivity was about 75%. Why is it important to identify a fungus? Because it tells you about resistance. For example, amphotericin B, poor activity against Lusitania, Oris, Nidulans, Tereus, and Flavus. Fluconazole doesn't act on molds. For glabrata, it is always susceptible, dose-dependent, resistant for Cruzii, and also Oris most often resistant. Vori does not work against mucorales. Isavuconazole has high MICs for mucus species, Syncephalastrum, Cunninghamella. Echinocandins don't work at all for Cryptococcus, Trichosporon. For Paraxylosis and Gillamondia, the MICs are high. Again, for mucorales, it doesn't work well. There are various ways to do susceptibility testing, like disc diffusion, e-test, sensititer broth microdilution, or Vitek2. Now, yes, Vitek2 is the easiest way to do it, but the recommended method is broth microdilution, which would mean sensititer. It's a ready-made kit that you get. You don't have to make the plates. And you can test Candida and you can test Cryptococcus on this. trichosporon and other yeasts and other molds, you need to do your in-house broth microdilution plates, your 96 well plates, and you need to test your drugs. So CLSI has criteria and UCAST has criteria for susceptibility testing. The methodology you've used to do the testing is CLSI, then you cannot use the UCAST breakpoints because the methodologies for these two are quite different. Voriconazole, posaconazole, itraconazole, all of them have therapeutic drug monitoring, which should be done. Thank you. These are my last two slides. Thank you. Hello? Yes, very clearly, yes. Yes.
I request Dr. Mitesh sir and Madhulika ma'am to give closing remarks.
I'm not able to hear very clearly.
She will be able to respond.
Hello?
Hello.
Hello, is this Kamlesh?
Hello, madam. Are you audible?
Hello?
As it is not possible, so we would add the closing remarks. As the madam had mentioned,
Thank you.
many of the rare fungi, which includes the yeast-like mold and the dimorphic.
Thank you, Kamlesh.
And
Sure. Sure.
yeah, so it is little bit challenging to diagnose the fungus
Hello.
as considering the conventional methods, which are the still gold standard for the mold, the slide culture methods. Okay, and as I am working into the ophthalmology institutes, so we encounter the so many fungus, which are the mold, mainly the fusarium and the aspergillus. Okay, and for the diagnosis of the fusarium, still there is a slide culture is the only way to diagnose it.
So nice to hear from you, dear. So nice.
Yeah.
Thank you.
Okay.
Thank you, God.
So,
Thanks a lot.
madam, it is now not reachable at right now because of the instability into the interconnect connectivity. So, if anyone have a question, it is we can interact actually because madam it is not now available. Yeah. Purohit madam, it is the pioneer into the fungus. Actually, whenever I was the resident, the madam told me the fusarium. Which one is the fusarium? Okay.
I request Dr. Bimal Chauhan sir to felicitate our chairpersons.
खाली काढून
આગળ મૂકવાની બધા જાય છે ત્યાં સુધી ગોઠવાની ત્યાં સુધી સ્ટાર્ટ ના કરતા આપણા ઘરે વધારે જાય પછી કરાવવાનું
चलो
એસીના બ્લોથી બંધ તો નહીં થતી ને કેન્ડલ ઉભી રહે એક મિનિટ ચાર છે ચાલે છે કે એસીના બ્લોથી બંધ થાય છે કે ચાલે ગેસ્ટ આવે ને એમ લાઇટિંગ આવે ને ફટાફટ કેન્ડલ્સ હટાવાઈ જાય
Very good afternoon. It's time for our inauguration ceremony. I request Dr. We are starting our inauguration ceremony. I request Dr. Bhavin Kapadia sir, Organizing Chairman, GAMM CON 2024, to accompany our respectable chief guest, Dr. Bharti Madam, ex-HOD, Department of Microbiology, BJ Medical College. It's a very proud moment for us as ma'am has joined us. Dr. Bharti ma'am, we are deeply honored by your gracious presence at this gathering. Your distinguished accomplishment, expertise, and experience have earned you respect and admiration far and wide. Your willingness to share your time and wisdom with us today is a testament to your generosity and commitment to fostering meaningful connection and collaboration. We are immensely grateful for your presence here, and we eagerly anticipate the wisdom and inspiration that you will impart upon us. Thank you, ma'am. Now I request Dr. Kamlesh Patel, sir, Organizing Secretary, GAMM Con 2024, to accompany our respectable guest of honor, Dr. Pranay, sir, and Dr. M.M. Vegar, sir. A very warm welcome to both of you, sir. So your presence here today is a testament to your unwavering commitment and dedication to the values and the principle that we hold. Your exemplary leadership, vision, and contribution have left an indelible mark on our country and inspiring us to reach greater heights and strive for excellence in all that we do. We are truly honored to have you with us, and we eagerly look forward to your insights and guidance. Thank you so much, sir. Now I request Dr. Naitik Patel, sir, who is our GMC observer, to join us. Thank you so much, sir, for joining us.
I request Dr. Bhavin Kapadia, sir, to felicitate Dr. Bharti, ma'am. Dr. Bharti, ma'am, an humble teacher and an incredible human being, is a veteran microbiologist. She did her medical graduation in 1967 and her MD in 1971, when most of us sitting here were either yet to be born or were in cradle. Her real journey of fulfilling and progressive career started when she joined BJMC in 1987 as an associate professor, and later she went to be the professor and head of the Department of Microbiology. For all the microbiologists, especially BJMC alumni, it's a matter of immense pride that PG course in the field of medical microbiology was first recognized by MCI under her able leadership in BJMC. Her contribution towards the department is unfathomable. She upgraded the virology section and developed polio lab, which became the jewel of the crown for microbiology department. She also became the pioneer of active contribution of microbiology fraternity in combat against epidemics by ensuring and witnessing successful fight against anthrax back in 2000. We must give a huge round of applause to the most favorite teacher of most of the person sitting here. Now I would like to request Dr. Kamlesh Patel sir to felicitate Dr. Pranay Shah sir, ex-Dean BJM Medical College. Does this name require any introduction? Dr. Pranay Shah sir has served as the Dean of one of the most reputed medical college of India, BJMC, for more than 3 years, which includes the most challenging period of COVID crisis. Sir has mentored many PG aspirants in the field of microbiology as a professor in various medical colleges like BJMC, Government Medical College Bhavnagar, Government Medical College Surat for more than 16 years. Sir has contributed significantly for many years as a member secretary, admission committee for professional medical and paramedical courses. Sir has been an active force behind training of more than 500 medical professionals across state to investigate epidemics. He has received many prestigious awards like National Veteran Academic Excellence Award by Indian Medical Association. Now I would like to request Dr. Bhavan sir to felicitate Dr. M.M. Vegar sir, Professor and Additional Dean, Dr. M.K. Shah Medical College. Dr. Vegar sir, Additional Dean and Professor in Department of Microbiology at M.K. Shah Medical College, Ahmedabad, had served good part of his career as a professor and head of Microbiology Department, BJMC, and earned reputation of visionary, disciplinary and hardworking leader. During his tenure, he has mentored so many of us sitting here and changed innumerable lives for all good through his constant guidance and support. Sir has also served on reputed at the same time accountable positions like in charge Deputy Director Medical Education, Gujarat and Dean GMERS Sola. Sir has contributed to Indian medical education by assessing many medical colleges. Thank you, sir, for being here. I would request Dr. Bhavin Kapadia, sir, to felicitate Dr. Naitik Patel, who is a GMC observer. Dr. Naitik Patel, a renowned anesthetist of Ahmedabad for more than 20 years, is an active member of Ahmedabad Medical Association and is ex-secretary and treasurer of Manipur Medical Association. Thank you, all of you. I would like to request Dr. Bhavin Kapadia, sir, to deliver welcome address.
Yeah, good afternoon. So we are running late by a few minutes, so I will curtail my speech so that everything will go on. So respected Chief Guest, Dr. Bharti Madam, Guest of Honor, Vegar Sir. Yeah. GMC Observer, Dr. Naitik Patel, respected teachers, seniors and colleagues. It is honor to welcome all of you in the conference of Indian Association of Medical Microbiologists, Gujarat chapter. The overwhelming response that we have received and enthusiasm that we all have to make this conference a grand success make me clear and confident to say that now we are going to make it tradition to meet annually. It is a microbiologist event in true sense because our chief guest, guest of honor, delegates, speakers, all are microbiologists. I find immense joy and proud to announce that today we have around 300 delegates, 70 researchers, 11 speakers sitting under this roof to take microbiology of Gujarat chapter to an unimagined height. We must congratulate ourselves for that. Our fraternity has demonstrated exceptional resilience and dedication during COVID-19 pandemic. and we have truly emerged as a frontline warrior, and that to victorious warriors. The remarkable work accomplished showcase our capability beyond what anyone can ever imagine. A small brief about the association and this conference. As laws were changed, association required a legal identity to functioning, and good number of MD microbiologists are coming out. So our seniors and colleagues thought that association of MD microbiologists with minimum qualification of MBBS should be made, and we have made this association. Within span of 6 months, with the great efforts by all the members of working committee and dedication and enthusiasm of all of us, we receive unprecedented response. No wonder today we have around just a half an hour before, we were 341 members. In this association, we want to work under a guiding principle of our Honorable Prime Minister, Shri Narendra Modi, Sabka Saath, Sabka Vikas, Sabka Prayas. This conference is a first step of association to check our capability to organize a national level conference, and I am confident that we will do in very near future. We in association are also eyeing to reach as much as possible in entire Gujarat. For that, we are proposing to have additional 4 zonal team apart from the state level central team. These additional 4 zonal teams will include North Gujarat, South Gujarat, Saurashtra and Madhya Gujarat. And zonal team under a banner of IMM Gujarat are also expected to work with local bodies like IMA bodies, Physician Association, Pediatric Association, IDSG and other association hand in hand, and spread our works like different work like AMR awareness, infection control and other national program. We are also planning to make our website, which is going to be interactive. Today, as we gather to share knowledge, exchange ideas, forge collaboration, let us renew our commitment to advancing the field of medical microbiology for betterment of healthcare of India and beyond. Let us continue to harness this strength as we navigate future and strive for excellence in our field. Thank you. Jai Hind.
One of our esteemed guests, Dr. Yogeshanand Goswami sir, who is the CEO of GMERS, is not with us here due to some official work that he had to attend immediately, but he has sent us his best wishes and blessings. So we must receive it with a huge round of applause.
Subham karoti kalyanam, arogyam dhanasampadam, Shatrubuddhi Vinashaya, Deepajyoti, Namostuti. As we gather here, let us take a moment to reflect on the profound symbolism embodied within simple yet powerful ritual. The lamp represent the triumph of light over darkness, knowledge over ignorance, and hope over despair. I request all the respected dignitaries on the dais to join for the lamp lighting.
Lamp lighting prayer.
We have to respect our chief guest as well as guest of honor. I request our chief guest, Party Madam, to share her insights.
હલો મિત્રો, આજે હું બહુ જ ખુશ છું કે આટલા રિટાયર્ડના આટલા બધા વર્ષ પછી પણ તમે મને યાદ કરીને બોલાવી અને તમને બધાને મળીને મને બહુ જ આનંદ. હું એ જમાનાની સ્ટુડન્ટ છું કે જ્યારે સ્ટુડન્ટ અને ટીચર કે જ્યારે માઇક્રોબાયોલોજી શું તે ઘણા બધાને ખબર નહોતી. અંડર ગ્રેજ્યુએટમાં એની કોઈ વેલ્યુ નહોતી. જનરલ પબ્લિક, નોન મેડિકલ એ લોકો તો કે એ શું છે, માઇક્રોબાયોલોજી શું છે. જનરલ પબ્લિકને આપણે સમજાવવું પડે કે વન ઓફ ધ પાર્ટ ઓફ પેથોલોજી, ત્યારે કંઈક સમજ પડે. અત્યારે મને એ જોઈને બહુ જ ખુશી થાય છે કે એની આટલી બધી પ્રગતિ થઈ છે અને અમે ઇમેજિન કરી શકું છું કે એ એટલું સરસ ડેવલપ થયું છે કે હું એવું ઈચ્છું પણ છું કે આખા ઇન્ડિયામાં, ઇવન પરદેશમાં આપણી કોલેજ, અહીંયાનું જે સબ્જેક્ટ છે તે રેકગ્નાઇઝ થાય, એને રેફરન્સ સેન્ટર્સ મળે અને બધા આપણી કોલેજને ઓળખે કે આ માઇક્રોબાયોલોજી આટલું ડેવલપ થયું, શૂન્યમાંથી ઉપર ટોપ પર પહોંચ્યું. થેન્ક યુ. તમારા સૌનો બહુ બહુ આભાર.
I'll also like to request Dr. Pranay Shah sir. Actually, sir, it was a goof up from our side. Actually, so I personally request you to share your emotions and few words.
Respected Madam, my dear friend Vegar, GMC Observer Dr. Naitik Bhai, Organizing Chairman Dr. Bhavin B. Kapadia, Organizing Secretary Dr. Kamlesh Patel, faculty members sitting in front 3-4 rows, and my dear friends. First of all, I want to congratulate Dr. Bhavin Kapadia, Organizing Secretary, for organizing this type of conference with large number of registration. So big applause for Dr. Bhavin Bhai. Same as Dr. Kamlesh Patel as Organizing Secretary, and all team members who are behind. So since last many days they are working hard for this conference. Bhavin Bhai, thank you very much for giving us platform like this to exchange our thoughts with clinical persons, academicians, and laboratory people. So thanks a lot. And we wish a grand success to this CME for remaining one day, half day today and half tomorrow. And all the best for your future plans for our association. For a lighter note, I think ઉર્વેશ બહાર જતા મેડમને એવું કીધું કે મેડમ આ બધું બદલાઈ ગયેલું લાગે છે નહીં, માઇક્રોબાયોલોજી. એટલે મને યાદ આવ્યું કે when we started MD, at that time it was not bifurcated, MD pathology and bacteriology was there. So it is 40 years almost, 4 decades. For Vegard, 1983, and I joined in 1985 as a resident, MD pathology and bacteriology. At that time we were doing minimum work with minimum resources. So let me admit that. And now today what I saw since last 40 years, I observe that we are growing very fast and nicely. And today Bhavini also told that ખભે ખભા મિલાવીને ક્લિનિશિયન સાથે વાત કરી શકીએ એવા આપણે થઈ ગયા છે. So congratulations for that and all the best. Thank you.
I'd like to request Dr. Vegat sir also.
એક મિનિટ.
Yes, ma'am.
સોરી, હું ભૂલી ગઈ હતી કે આપણો જે માઇક્રોબાયોલોજી સબ્જેક્ટ છે તેને રેકગ્નાઇઝ કરવામાં, પેથોલોજીની બગલ બચ્ચું છોડીને આપણે ઇન્ડિવિજ્યુઅલ આપણું એક્ઝિસ્ટન્સ બનાવવામાં ઘણા લોકોએ ફાળો આપ્યો છે. તેમાં ડૉક્ટર કેતન દેસાઈ, મેડિકલ MCIના ડાયરેક્ટર, પછી આપણા CA દેસાઈ, ડીન સાહેબ હતા તે, અને થર્ડ પર્સન ડૉક્ટર સીકે પીજી ડાયરેક્ટર હતા તે, અને એમાં હું એક નાનકડો હિસ્સો હતી જ્યારે ફર્સ્ટ ટાઈમ પેથોલોજીથી માઇક્રોબાયોલોજી છૂટું થયું, અને મારા સૌથી પહેલાં 5 સ્ટુડન્ટ અહીંયા, એમાં 3 જણા તો બેઠા જ છે, અને આઈ એમ ફિલિંગ પ્રાઉડ કે અત્યારે તે સૌથી હાઈએસ્ટ પોસ્ટ પર છે. થેન્ક યુ. આપ બધા સૌનો બહુ જ ખૂબ ખૂબ આભાર.
Sir, I'd like to request Dr. Vegat sir to share a few words with us.
એક તો મારું ઓનર કરવા માટે ઓર્ગેનાઇઝર્સને થેન્ક યુ. આમ તો બધું પ્રણય બધું મોટાભાગનું કહી દીધું. આ ઓનર ફક્ત મારું નથી, હું બીજે મેડિકલનો હતો, એટલે આ ઓનર આઈ વિલ ડેડિકેટ ટુ ઓલ માય કલીગ્સ, ઓલ ધી કલીગ્સ, રેસિડેન્ટ્સ, technicians, class 4, and Dean Dr. Bharat Shah, Dean Dr. Pranay Shah, and Superintendent Dr. Prabhakar sir also. Thank you.
I request all the guests on the dais to remain seated and present on the dais itself, because we have a special announcement here. The association wants to acknowledge the contribution of Dr. Bharti ma'am towards the entire microbiology fraternity by giving her a Lifetime Achievement Award. There should be a huge round of applause, everyone. It's a great moment for her, for us, everyone over here. Dr. Bharti ma'am, would you like to reflect? How do you feel on getting this award? Few words. Madam is, in plain words, I can say that Madam is overwhelmed by all the love that has been showered upon her. And ma'am, we assure you that we'll keep showering this love on you. Thank you, ma'am, for being there always. Okay, now it is also a matter of immense pride that to motivate extraordinary microbiology students, Gujarat University has started a gold medal as Dr. Bhartiben Purohit Gold Medal. For all the PG students, for the PG students securing first position in MD exam. And I'd like to invite on stage donor of the gold medal, Dr. Kanubhai Patel. Sir is my PG guide and I'm his first PG student, and I'm feeling quite proud right now. Thank you so much. Thank you so much for being on the stage and gracing the stage. I'd like to ask Dr. Kamlesh Patel to stay back for a while and share vote of thanks.
So, good afternoon, friends. Our chief guest, Dr. Bharti Madam, guest of honor, Dr. Vegat sir, Dr. Pranay sir, our GMC observer, Dr. Naitik Patel, my seniors, teachers, and dear friends. Hardik has actually given me a tough task to say thank you to all of you. But to whom say to thank you? This is a microbiology fraternity, right? No other people are invited today. her chief guest, to all speakers, to all delegates, everyone is microbiology. So in our own family, no thank you, right? હા ને કાં પછી એકને થેન્ક યુ કોણ બીજાને ખોટું લાગે બરાબર પણ thank you very much. Since day one, when me, Bhavin, Mitesh, Urvesh, Mansi, Kiran, Bimal, Sanjay, Atit, we actually, you guys know that we all are from the same batch. Me, Bhavin, Urvesh, Mitesh, Kiran, Mansi, Sanjay, Bimal, Atit, we all are from the same batch. So we met together one day and just shared thoughts, and actually to revive association, the thought is of Urvesh and Bhavin both. So our previous association was free, so worked hard, the whole team worked hard. Some new trust has been formed and all legal formalities has been completed, and our new association has started, and you people have actually supported a lot. Our guest of honor, Dr. Vegat sir and Pranay sir, I was sharing my thoughts with them initially that we are planning something like this. Both were so helpful, and actually they have encouraged, you guys have to do something for all microbiology fraternity, and ultimately we are today here together spending since morning, and we'll spend. You guys have supported a lot. Thank you all. Same in conference, registration started like anything, and we have actually more than 300 registrations till yesterday evening, and the PG students who have submitted their abstracts, the total 69 researchers. So thank you all of them, all the speakers, they all are microbiologists, panelists, our chairpersons, everyone is from our own family. So thank you everyone, and in the last but not in the least, our sponsors. They have supported us since day one. We have some limited sponsorship, but we'll do our program as a rocking program, and bear with us for 1.5 days. Thank you. Thank you very much.
Next in the queue, we have a very small promotional video by our sponsor, Titan Biotech Limited. So be patient and just have a look at it.
Welcome to the world of quality, reliability, and sustainability. Welcome to Titan Biotech Limited, established in 1992 at Bhiwadi. Welcome to the world of quality, reliability, and sustainability. Welcome to Titan Biotech Limited, established in 1992 at Bhiwadi. Titan Biotech is a BSc listed company that has been pushing the boundaries of research and development to deliver great quality biological products. Titan Biotech's microbiology division, TM Media, has been at the forefront of the microbial industry for over 3 decades now. We have made our mark by continuously improving our products for culturing microbes for different purposes, such as diagnosis, research, fermentation, high-quality testing, and environmental monitoring. We cater to several industries, including food, pharmaceutical, clinical, molecular research, and more. Over the years, we have scaled our business to keep up with the growing demand for our products. while maintaining strict quality standards that we are well known for. We believe the biggest challenge in manufacturing microbiology products is maintaining an aseptic facility. However, at DM Media, we have met this challenge head on. Various classified areas of the manufacturing facility are maintained using HVAC systems, EHUs, and calibrated hygrometers. Our objective is to continue to evolve so that we can keep pace with the industry's growing needs in the field of microbiology. We are proud of our world-class manufacturing facility, certified with international standards, including GMP, ISO, CE, food certificates, and halal. We have created products and systems to fulfill the complete needs of microbiologists and other researchers in the field of life sciences, with a focus on microbiology. Our food, ready-to-use culture media, antibiotic sensitivity discs, plant tissue culture media, among others. In fermentation industries, biological media bases play a significant role as they contribute to a plentiful supply of carbon and nitrogen sources, resulting in high production yields of microorganisms. In India, we are one of the largest manufacturers of the ingredients of culture media, with a production capacity of over 2,000 metric ton per year. We plan to expand this capacity even further in the near future. As a sustainable alternative, we also offer a range of plant-based biological media bases. We manufacture a wide variety of dehydrated and chromogenic culture media. Our portfolio includes over 2,000 varieties, available in homogeneous mesh size and as a free-flowing powder, which is stored in airtight sterile HDPE bottles to ensure quality and sterility. What sets us apart from most of the competition is that our raw materials are produced in-house. This helps us standardize the quality of our culture media and its ingredients. It also allows us to develop and customize new products as per the emerging needs of microbiologists across the globe. Additionally, we also offer a wide range of plant-based culture media, and our daily production capacity for dehydrated culture media stands at 10,000 bottles. The production of ready-to-use plates is another milestone that we have achieved. We have the capacity to produce 40,000 plates per day. The traceability content of each plate is printed on the edge rather than on the bottom, which gives an easy and accurate reading on the colony counter. These plates are available in 90 mm and 55 mm sizes, with a wide variety of culture media to support your laboratory needs. DM Media offers a complete range of prepared plates under its sub-brand Absolute EM, which was developed specially for environmental monitoring in the pharma industry. Ready-to-use culture media are also available in bottles and tubes in a variety of volumes in keeping with various use cases like food testing, sterility testing, etc. We have a daily production capacity of 20,000 tubes and 10,000 bottles. We also manufacture broth medium for volumetric use, which is sold in ready-to-use sterile bags. These ready-to-use bags are available for common varieties, usually preferred by microbiologists. We also manufacture and supply transport medium with swabs that are used in the collection of environmental, surface, clinical, food, forensic, and genetic samples. Again, the process is fully automated from filling to packing in sterile tubes, which comes with a variety of swabs. Plus, our portfolio includes over 70 antibiotic sensitivity discs with concentrations of antibiotics as per CLSI standards. It wouldn't be wrong to say that DM Media is your one-stop destination for all types of microbial products. Our dedicated research and development team comprises highly qualified scientists and microbiologists. Their constant endeavor is to develop distinguished industry-oriented products beneficial for microbiologists. Next up is the Quality Control Department, which works tirelessly to ensure the quality of our products through extensive and intricate testing, performed using advanced instruments and equipment. There are separate laboratories dedicated to microbial and chemical testing. The Quality Assurance Department works towards quality assurance and documentation by making sure these laboratories operate under strict GMP, GDP, and GLP protocols. Thanks to the well-equipped storage facility, the movement of materials, in-process items, and finished products, as well as transfers between and within work centers, can be tracked on a real-time basis. This is one of the reasons why our team is well known for always ensuring timely dispatches in spite of our huge and diverse inventory. Another very important reason for our success is our people. They have embraced our vision and made it their own, working collectively and consistently to deliver superior quality biotechnology products. It is through the combination of a visionary outlook, never-ending research, innovative technology, and great teamwork that TM Media has made its mark globally and become the preferred choice of microbiologists in over 77 countries. Our commitment is to continue to evolve and innovate so we can keep fulfilling microbial product needs for our clients across the globe, helping them grow and nurture their products, services, and
All right, we are getting back to our business. I hope everyone's with me. Now we'll move on to our next session and let's have a look at what again these girls are up to. Girls.
Bonjour, a very good afternoon. I'm Maya Sarabhai. I am overwhelmed to meet you all.
नमस्ते, मैं मोनिशा साराभाई.
Our next session is on automation.
जी, ऑटोमेशन की क्या जरूरत है? कितने पैसे खर्च होते हैं?
अभी मोनिशा क्या जाने ऑटोमेशन का मतलब. वो तो आज भी कपड़े हाथ से धोती है, नेटफ्लिक्स की जगह के कुमकुम भाग्य देखती है और कन्वीनियंस फीस बचाने के लिए क्यू में खड़ी रहती है ऑनलाइन टिकट बुक करवाने की जगह पे. डोंट माइंड मोनिशा बेटा.
मम्मी जी, अब यहाँ भी शुरू हो गए.
ठीक है, मोनिशा मुर्दाबाद प्रकरण खत्म हो गया है तो हम आगे बढ़ते हैं. सो इंडीड मोनिशा के पास तो टाइम ही टाइम है, हमारे पास नहीं है. सो विल मूव टू आवर नेक्स्ट सेशन विच इज रिगार्डिंग ऑन ऑटोमेशन. Without wasting everyone's precious time, let's proceed. I welcome our chairpersons for the same are Dr. Seema Bhatt ma'am, Professor BJ Medical College. Dr. G.U. Kavathia sir, Associate Professor, PDPU Medical College. Dr. Parul Patel ma'am, Associate Professor, GMERS Gandhinagar. It's our pleasure to invite Dr. Vikas Ranjan sir to join us. I request Dr. Parul Patel madam to introduce our esteemed speaker.
Good afternoon, everyone. Dr. Vikas Ranjan sir, having 8 years of experience in core clinical microbiology and acquiring rich and versatile experience in the field of working at topmost institute like KM Mumbai, ICMR, NIMR Delhi, PIJMER New Delhi. He is presently working at Biomerio in the capacity of Manager Medical Affairs South Asia. He is an active member of Indian Society of Medical Mycology and many more. He has published paper in national and international journal as well as chapter on advanced fungal diagnostics in CNS infection. Welcome, sir.
First of all, madam, you are very senior to me. Please don't call me sir. We are still learning and will continue to learn. Okay. So with this, good afternoon all, and I thanks for giving us the time to speak to you about automation. There's a lot of things that is involved in my topic. I will cover upon blood cultures, best practices in blood cultures. Then we have the Vitek, then we have the MIC. In the Vitek, I will be talking mostly about the importance of the ID, and most of the speakers have already talked about the importance of ID in respect to fungal ID and the Mycobacterium tuberculosis. So, starting, it's not moving. It's not moving. Excuse me. Hello. You don't have the pointer, Will. Not even.
We don't have.
Okay, fine. So, starting with the antimicrobial resistance, what is AMR? AMR is a phenomenon where the bacteria, I will specifically talking about mostly on the bacterial. So, it's a non-susceptibility of the microbes, and the microbes will develop resistance whether you are putting an patient on an antibiotic or not. They will continue to evolve and they will develop resistance. What is the global burden of AMR? As we all know, 1.27 million deaths is attributable to AMR directly, and 1.495 million deaths is associated with AMR. Mostly because of the fluoroquinolone and the beta-lactam antibiotic that is overused, misused, whatever you can say. Non-compliant with the guidelines. And we all have gone through this COVID-19 pandemic. And what we have learned is that most of the organisms, specifically speaking, the crab organism, the antifungal resistant Candida auris is on the rise. And it's very difficult to even diagnose Candida auris in a normal setup. Now we have the Vitek, we can have the auris getting detected, but it's not everyone that is able to detect. We do not have the automation, because manually it is very difficult to detect Candida auris. Why sepsis? Now sepsis and antimicrobial resistance go in hand to hand. We all know the patient lying in a critically ill condition. That is the patient in which we use the most antibiotics. And there is the problem that we have a very low amount of choice left with us. Means if you are not sticking to the guidelines, it's very difficult to how to and what treatment we should give. So AMR and sepsis, as I said, it goes in hand to hand. What does the statistics say about the sepsis? Sepsis, 550 million cases per year, 11 million deaths per year, and 40% of the kids who are dying of sepsis are less than 5 years old. So this is the problem with the AMR and the sepsis. Coming to the what is sepsis? Now, as per the sepsis 3 guideline consensus, sepsis is a life-threatening organ dysfunction caused by dysregulated host immune response system. And you can have sepsis because of any kind of infection, bacterial, fungal, viral, whatever. Any system can be involved, and finally you will have an infection and you will land up with a sepsis if you're not treated at the earliest time possible. It's not only the treatment, it's the diagnostic part also which is involved. What is there? There comes the importance of the diagnostic and the antimicrobial stewardship. So what is diagnostic stewardship? Is the right test at the right time for the right patient. And what is antimicrobial stewardship? The right antimicrobial at the right time, okay, at the right dose. These are the 6 important pillars of any microbial detection and for treatment also. So we all know any test you do, you take pathology, biochemistry, microbiology, any diagnostic test you do, you have 3 steps: pre-analytical, analytical, and the post-analytical. And in the country where we are living right now, we have the most of the problems lying in the pre-analytical steps. Collection of the sample. We're not collecting the sample optimally. Now, one of my colleagues was talking about biofire. It's a very good, it's a very practical approach. Now, we had a meeting with Dr. Subhas Todi, and Subhas Todi just questioned one simple question to us. What was the question? The question was, if the patient is paying, will you not allow a biofire test to be done? If the patient is paying, then nobody has the answer. Non-paying patient, we can understand. But for the paying patient, he is the sepsis, will you run a biofire BCID panel if you have or not? This was the simple question. So, and for every panel, we need to have certain criteria to be fulfilled. And that criteria is the pre-analytical steps. What kind of a sample you are collecting? how you are collecting the sample, how much is the volume of the sample. So these all pre-analytical steps are very critical for any diagnostic test to reach at the right results. So as I already said, you have the two pillars, 6 principle, two pillars, the diagnostic stewardship and the antimicrobial stewardship. Surviving sepsis, one bundle I've already said, which will define the sepsis. Now we have this more important point, obtain blood cultures at the right time before administration of antibiotics. Now I ask you a question, how many of the patients in India are getting admitted to the hospital or an emergency or any critical care without antibiotics? Most of the patients are on the antibiotics. What we do? Are we getting the sample correctly? Are we getting the blood cultures the right way it should be collected? Are we getting the right bugs? No, we are not getting. Most of the times we are missing the bugs. So what is the role of blood culture in management of sepsis? So what it is doing? It is doing for causative. We identify the causative pathogen, we identify it, and we accordingly treat the infection. So identification. So when should the blood culture be drawn? We all know the blood culture should be drawn before starting any antibiotic. If the patient is on antibiotic, then what we do? Then before the next dose of the antibiotic, we have to collect the blood cultures. That is the recommendation. Okay. When should the blood culture be drawn? This is the first chart I am showing you for blood cultures prescribed in an Indian hospital. This is a study taken from the Indian study. Per 1000 bed, India, we are at the last per hospital bed. Again, so we are not utilizing the possibility and the advancement of the blood culture systems that we have. Now gone are the days when we used to have that glass bottles, and from them we always come to the microbiology lab every morning, take out the bottle, see the see the turbidity, and then do the subcultures. So that thing has been taken care of, but still we are lacking somewhere. Okay, why? Because the guidelines say, what the guidelines say? The guidelines said 2 to 3 sets of blood culture. I can understand that 3 sets of blood culture is very difficult, but what can two sets of blood culture? Even there are many institutes who are using one single aerobic blood culture bottle. Is it enough? Are you able to justify it for the patient, or just only for the cost that a hospital cannot bear? What about the patient? Okay, there are a lot many things to be answered. What is the optimal strategy? Now the optimal strategy is the right volume of the blood to be collected. And the guidelines strictly said how much should be the volume of the blood in the adult and the pediatric. Order of draw. Order of draw, always we all know that as per the order of draw, the first sample to be collected if a patient is in sepsis, so the first sample to be collected is the blood culture sample. How many phlebotomists they know? But we are getting trained them. Number of sets, 2 to 3 sets. I will show you all the possible slides, all the possible information that I am talking about. It's nothing that I have written from my side or taken from any book. It's all from the guidelines. Distribution between aerobic and the anaerobic. Okay. Transport. How many of the time that we transport the blood cultures bottles directly to the microbiology lab in the best way possible, in the best possible time? Many of the times happen the blood culture bottle still lies in the emergency lab and it's transported to the next day. Importance of the blood volume. As you increase the blood volume, your chances of detection, your increasing in the yield of the bacteria increases. So as you go to the third set of the bottle, you almost have 98.3% identification capability or the detection capability. But at least we should try to get to the second part, that is the 2 sets of blood culture. You will have 89.7% identification capability. This is not what I am saying. It is from the cumulative sensitivity of blood culture sets taken from a study, international study. CLSI states the same thing. M47A guideline, again the same thing. Order of draw, blood culture tube, first bottle should be taken. Again the same. What is guideline is to collect 2 to 3 sets per episode. This is CLSI M47A, volume 27, 2 to 3 sets of blood culture. Now, what about aerobic and anaerobic? How many of us are using anaerobic bottle? Is there any use of anaerobic bottle? Why should I am already using aerobic bottle. Why should I spend adding one more anaerobic bottle to it? There is a justification to it. Okay. So still where we are, the pink is the anaerobic bottle and the green is the aerobic bottle. We lie at the very bottom most. We are still not utilizing the full potential of the anaerobic bottle. This is the cumulative guideline taken from many of the guidelines USA, CLSI, ASM, Cumitech, ECMID, Australia, what they say, this is a cumulative accumulation. Number of blood culture sets, 2 to 3 sets aerobic is equal to anaerobic. Cumitech also says the same thing. ECMID also says the same thing. Australian guidelines also the same thing. So where are we? Where are we lacking? Okay. Again, volume. We all know what should be the adult volume, what should be the pediatric volume. Pediatric volume is dependent upon the weight and the age of the patient. Time to incubation as soon as possible. Length of incubation 5 days, and you can increase it if you are suspecting of something special like brucella. You can go up to 14 days. Okay. What is the benefit of using an anaerobic bottle? Now the benefit of anaerobic bottle, when you have one aerobic and one anaerobic bottle versus two aerobic bottle, two aerobic bottle versus one aerobic and one anaerobic bottle. This is the study. Significantly more total organism, gram-positive Staphylococcus aureus, Enterobacteriaceae other than E. coli. I'm sorry, Enterobacteriaceae is not there. It's Enterobacterials other than E. coli and anaerobes. I can understand that most of the labs do not have the anaerobic setup, but at least think about these two organisms, Staphylococcus aureus and Enterobacterials other than the E. coli. Is Streptococcus pneumoniae growing much better in the anaerobic bottle? How many of the isolates we are missing? This is the first study that I'm saying. Now second study, the same person did the another study comparing one aerobic, one anaerobic versus two anaerobic bottle. One aerobic, one anaerobic versus two aerobic bottle. Total 1186 pathogens were detected. But when he had only two aerobic bottle, only 190 pathogens were added over the 1186. But when he compared adding one aerobic and one anaerobic bottle, just see the figure, plus 374 pathogens. So what happened to these 180 pathogens that you missed out? Because these were the organisms that were growing much better in the anaerobic bottle, specifically more important in the anaerobic bottle that were missed on the aerobic bottle. This is something already published, many publications are there comparing, but there are still a certain uncertain question mark lies why we should use. I can just only give you the guidelines. I cannot pressurize you to please start utilizing, but there is certainly a point that we should add one anaerobic bottle to our workflow. If you are using two aerobic bottle, fine, it's okay, it's up to you. But you just add one anaerobic bottle, you just see the comparative study. You can do a comparative study and you find it out yourself. Routine use. This is the most recent guideline, most recent publication by Eric M. Ransom in 2022, published in the American Society of Microbiology. Why we should have an anaerobic bottle? You can see Staphylococcus aureus from anaerobic bottles demonstrated statistically significant increased recovery. Finally, if only an aerobic bottle had been collected, 2027 fewer positive cultures would have been detected and 7452 fewer isolates would have been reported. Now think about this. And how many samples they collected? 28,000 samples across 3 centers in the US. This is not a simple study. 28,000 blood culture samples should be processed and then you have the data. What about the inactivation of antimicrobial agent that the patient has been already given? In the presence of antibiotics, 231 out of 430 bottles were declared positive and the detection rate of Bacti alert system was significantly higher than the achieved for the Bactec system. In the Bacti alert, you have the 150 out of 215 isolates getting detected if the patient was on antimicrobial. It's not only antimicrobial, imipenem, meropenem, piptaz. These were the antibiotics that were neutralized much better in the anaerobic bottle. So this is one more advantage of the anaerobic bottle, that the neutralization of antibiotics are much better in the anaerobic bottle. Advantage. So finally coming to the advantage of anaerobic bottle, recovery of anaerobes, as simple as that. We all are microbiologists, we all know, it's very easy to say. Improved detection of facultative anaerobes, Streptococci, Enterobacterials, faster detection in anaerobic condition. Detection only in anaerobic bottles, 16% Streptococci and 70% Enterobacterials are getting much more easily detected in your anaerobic bottle. Piptaz, ertapenem, imipenem, meropenem are getting much better neutralized in anaerobic bottle. Now comes the most important part, Candida glabrata. That is much better, 100% detection rate in your anaerobic bottle. Now, we all know Candida glabrata, multi-drug resistant fungi in the blood. If you are having a glabrata in a blood, then you will miss out most of these isolate if you are using only 2 aerobic bottle. Forget about 1 aerobic bottle. Please. If you are using 1 aerobic bottle, please shift to at least 2 aerobic bottle or at least 1 aerobic, 1 anaerobic. This is a control study comparing the bacterial at virtue and the bacteric effects. Now, what is bacterial at virtue? We all know about bacterial at 3D. Bacterial at virtue is where you do not have to do anything. Just keep the bottles there, move away. Now, you know, there is a one study that has been done, how much of the time a technician spends on the bacterial alert muscle. 3 minutes of their time. From scanning to writing to loading to removing, 3 minutes of the time is spent in bacterial alert. You can just check. In the bacterial alert virtue, you do not need to do anything. Just go and keep the bottle, just move, do your own work, whatever you want to do. The machine will automatically take the bottle inside, process it. Once if it is negative, thrown out automatically. You do not have to do anything. You can do your rest of the work. There is a lot many work for a microbiologist. Antibiogram analysis. That is the forward thing. Antibiogram analysis. Without that, you cannot have your antibiotic policy. Reporting, you already have the VITEC, so you have the automated ID. You have the automated AST. In the absence of antifungals, 100% of the bottle were declared positive. In the absence of antifungals. And the fastest time to detection. Mean time to detection for Candida glabrata was 77 hours faster in the bacterial alert. 77 hours. In the presence of antifungal, if the patient was an antifungal, 98% of the bacterial alert FA plus bottle were positive. Bacterial alert FA plus bottles were the only to grow Candida glabrata in the presence of caspofungin, if the patient was on caspofungin, and overall had a mean time to detection of 8.9 hour. In 8.9 hour, you would have detected, and 21.1 hour faster than your bacteric effects. I'm not comparing. You can do your study. You can just find it out. It may be proven somewhere wrong, but this is what the study, and this study was done, and it was published in the ECMID, and the ASM also, ASM 2019. Efficient recovery of Candida auris. This is one of the more publication in the ASM. You see the data. Now, in the first bar, you see this is the when the patient is at 100% peak serum limit. In the second, in the third, when in the 90 and the 50% peak serum limit, and everywhere you are having the bacterial alert FA plus bottle detecting Candida much better. In the first right hand side, you see Candida auris 100% detection, glabrata, cruzi, and parapsilosis, and also tropicalis, getting much better detected in your anaerobic bottle. Similar, another study. So almost all of this study do say, yeah, please. Yeah. Okay, So many of this study do say that the addition of anaerobic bottle will help. But how much will it help? It's up to you. I can only show you what I have said. I can only show the publication. Okay? It's up to you. You can do your own work and you can just find it out how adding a simple anaerobic bottle to your workflow can increase your detection rate and can save patient lives. Okay? So essential elements of blood culture, we all know we have the pre-analytical, analytical, and the post-analytical. What is the pre-analytical principle for the blood cultures? Number of bottles, how many bottles you are collecting, volume of the blood that you are collecting, transport to the laboratory, how easily you are transporting. Analytical, post-analytical, timely gram stain performance, rapid diagnostic, timely AST. Intervention, what intervention you need to do? Appropriate blood culture collection, phlebotomy team training, your nursing training, these are all important aspects for a proper blood culture sample collection to the processing. Coming one, we have done with the blood cultures. Now we have a positive culture. Okay. Now we will shift to ID. Why we do a ID? What is the importance of ID? Why we should do an ID? Should we do a manual method or automated method? Even the manual may be, aaj ke date mein, you have moved out from multiple biochemicals to chrome. Why shouldn't chrome? तो बहुत सस्ता है. Why I should buy a Vitek? There is a lot of problem. It's not a problem that I am saying. A book written by Apurva Shankar Sastry. Most of the PG students who are sitting here use that book. Please go and see his own written page where he says कि chrome agar is only to be used as an initial test to detect. It's not a final. You have to finally detect it by doing a certain test. Okay, it's all tables given in his own book. Okay, so now we have an idea. So when the patient arrives in a hospital in a sepsis condition, you have initial antibiotic therapy which is based on your antibiogram. Targeted therapy when you have an ID and an AST. Personalized therapy where you do a MIC or MBC or TDM. Finally, you have the monitoring of therapy where you do a ProCal. Okay, so this is the general workflow for any patient. What is the importance of ID? The importance of ID is that key definition of host-parasite disease relationship. How is the host and the parasite is interacting with each other? Epidemiological investigation, and finally therapeutic regimen. Which treatment I should give? Why accurate organism ID gives you a reliable AST. Finally, if you have an intrinsic resistance and your breakpoints. Now, what is this intrinsic resistance? How many times we have been using a manual disc diffusion method and we encounter AMPC? How many times? Hardly 1 or 2 times we detect AMPC, because detecting AMPC on disc diffusion is very difficult. Paper written by Dr. Sumit Rai. What he says, you have to put this disc at this place, this disc at this place. How many times you place the disc? We place the disc. Even I have not done. Why I say for you? I have not done. Your technician generally puts the test. How many times while reporting you find it out that it is a spice organism or ESCP organism? How many times? We forget about intrinsic resistance because a lot of work is there. We forget about intrinsic resistance. That is where the importance of ID comes into play. One paper, this is one of the slide where I combined CLSI, UCAST and the CLSI plus UCAST guideline. Here you say Escherichia coli and Escherichia harmani. Now Escherichia coli doesn't have an intrinsic resistance to beta-lactam, but the moment you have harmani, you have intrinsic resistance to ampicillin, amoxicillin and ticarcicillin. So that is where the importance of ID comes. You will not have more than IMVIC. If you have IMVIC, you will probably go till PPA if you have a Proteus. How many times we put any biochemical above IMVIC? Not many times. Now coming to one question, Salmonella is intrinsically resistant to all. How many of you will go with A? Any answer with A? A, one answer. Any answer with B? Jaldi. B. Okay. C? No, very good. D? Yes, very good. Let's see the answer. What was the question? Salmonella is intrinsically resistant to all. Is it intrinsically resistant? No. The question is not right. है ना? ऐसा सोच रहे होगे आप लोग. Salmonella के बारे में CLSI क्या बोलता है? What did the CLSI tells you? You can have a sensitive, but you should not report it. My question was intrinsic resistance. Now you see, I am asked you a very simple question to Salmonella Shigella, most frequently isolated from the blood. Okay? Do you have the Salmonella Shigella? Table 1A2 as per CLSI 2024. These are the antibiotics which has to be reported. The first tier 1 drug. For Salmonella Shigella, aminoglycosides, first generation cephalosporin, second generation cephalosporin, cefamycin may appear active in vitro, but it are not clinically effective in vivo. So it should not be reported susceptible. I have not asked. Okay. Now coming to the next question. Stenotrophomonas maltophilia is intrinsically resistant to all except piptaz, phosphomycin, meropenem, cotrimoxazole. जल्दी. वेरी डिफिकल्ट टू रिमाइंड ना, रिमेंबर, याद करना बहुत मुश्किल होता है ना, बहुत मुश्किल होता है. किसी के लिए भी पॉसिबिलिटी. ह्यूमन माइक्रोबायोलॉजी इज अ वेरी वर्सेटाइल सब्जेक्ट एंड वेरी वोलाटाइल सब्जेक्ट. It's very difficult to remember all the things. Most of the people, even I, मुझसे अगर कोई सवाल पूछता तो मैं भी शायद जवाब नहीं दे पाता. Cotrimoxazole. So that is the importance of whether you will report Stenotromonas multifilium or whether you will report cotrimoxazole or not. You have to go back to the books. You have to see the CLSI. Then you will report cotrimoxazole. How many times we go to the books? How many times we put CLSI M24 at the reporting table? Not many times. We have the paper stick in front of us and then we go through it. How many times we update our CLSI? Important. There is something written in the CLSI guideline, Stenotromonas multifilia tetracycline. Tetracycline के नीचे एक ऐसा मार्क लगाया हुआ है. CLSI में लिखा हुआ होगा B या A लिखा हुआ होगा, मोस्टली A लिखा हुआ है. तो उसका मतलब क्या है इसका? इसका मतलब यह है कि it is only sensitive to tetracycline but not susceptible to doxycycline, minocycline. Okay? Now CLSI 2024, what it says? It says now you have these organisms non-enterobacterial you can only report by MIC. You will ask me why I am telling you all this. This is important only why you should have an automation. You cannot do certain things manually. I accept manual was the method, manual is the method. You can reconfirm your Vitek result, but you should move from the manual to the automation. This is my part. So what CLSI said, you have to report non-enterobacterials only by MIC based method, not by disk diffusion diameters. What are the unmet needs with the traditional identification methods? So this is how we have been doing. Firstly, we have the microscopy, then we have the traditional method, biochemicals. We moved forward, we have the commercial method, you have the Vitek IDST, now you have the MALDI-TOF, PCR, and finally you have the sequencing. These are the biochemicals that we used to do. How many times we do the quality control of the biochemicals? What are the problems with the using of the biochemicals? How many times we follow these many charts for speciation of Staphylococcus? How many times we specify cons? How many times we give Ciferi, hominins? How many times? We do not do. We move from MRSA. The moment you have the MRSA, rest all cons. What cons? Is cons important or not? How many times we do these many tests for identifying a gram negative? What are the challenges in terms of traditional methods? Time consuming, technically complex, quality control checks, QC for each test, multiple tests per organism, so many problems. This is one of the paper. If you have a Pseudomonas which is non-pigmented, how will you identify? Pseudomonas का कलर तो देखिए आज तुम बता देते हैं, लेकिन मैनुअल में how will you say कि आपका it's a Pseudomonas which are non-pigmented? How will you identify? Coming to chrome agar, very beautiful plate, very easy to interpret. Color देखा और बता दिया identification. So is it so easy? Many organisms presenting with the same colors. You can see in the chart, Enterococcus, Proteus, it's okay. You see the swarming, okay. Klebsiella, Enterobacter, Serratia, same kind of a color. Citrobacter. So what they say is that you have to reconfirm it. What reconfirm? If you have a red color isolate, you do an indole test and then you see what is the final identification. You cannot just see by color and say this is, it's good, it's okay, you are using it, it's fine, but please reconfirm it. Either by a biochemical test or if you have the Vitek, please reconfirm it. This is what I was saying. This is a paper directly taken from this book. I'm not saying what I'm represent bioMérieux, so I talk only about bioMérieux. This is only the book. All the PG students sitting here who are interested in AMSP, diagnostic stewardship, antimicrobial stewardship, doing into conference, seeing this publication, that publication, the book is in front of you. What he says? Simple thing, automation is mandatory. Coming to Candida, I'm sorry, I'm taking a little bit of time, 5 to 10 minutes, that's it. If it is possible, is it okay? Candida speciation already, and Dr. Anjali Shetty madam has said, Candida species is a double-edged sword. You cannot have one treatment for all Candida species. Okay? So once you have a Candida albicans, please see whether the patient is critically ill, whether it's invasive candidiasis. Whether treatment differs from each of the Candida speciation. This is one of the sham paper taken. What you can see, bacterial virtuo. I'm talking bacterial virtuo, which is detecting the Candida species much better in a much early way, rather than even the bacterial alert. What are the consequences of organism misidentification? Now, see, you have a ESCPM organism, spice organism. How many times you see ceftriaxone? How many times you see cefoxitin? So what is the problem? AMC. What is the treatment of AMC? How will you treat the patient? Patient is already on ceftriaxone, ceftazidime, and now you have a spice organism. How many times you repeat the test? Whether you see for ceftriaxone, whether it's getting resistant. Because the moment you have the AMC organism, spice organism, what are the spice organism? Enterobacter cloacis, Rhizia marcescens, Citrobacter, Providentia stuarti, Morganella morganelli. If you have these organisms, the moment you start third generation cephalosporin, it will appear active in vivo also, but certainly in the next culture it will become resistant. Why? Because it's AMC inducers. So you have to change the treatment. So that is the importance of identification. Paper by Sumit Rai, he himself says, apart from what the susceptibility report says, if the right antimicrobial is not chosen, such infection will lead to a lot of mortality. If you have these 6 organisms in your lab, and if you are having a ceftriaxone resistant and treating, and a doctor is treating with these drugs. So lessons learned, accurate identification is important. Clinical perspective, the fact that the third generation are good inducers. The third generation cephalosporin are good inducers of the AMC. So please see to it, if you have this organism, please see to it, if the patient is getting this third generation cephalosporin or not. Vitek, identification, you know the importance of Vitek. People are using it, you have the lot many cards. MIC, now coming to the MIC. Why we have a MIC? Why we need to have a MIC? Because MIC tailors the therapy. This is the closest that we can reach up to. We cannot have a PKPD. We cannot calculate the PKPD. But this is what the nearest that we can get. Now the MIC is way behind. What now we have? We have the BMQ. What is BMQ? MIC to breakpoint quotient. Now when you have the Vitek, you have the breakpoint tables with you. Now what Vitek gives you is a raw MIC. And what you have to calculate is the BMQ. And on the basis of BMQ, everything changes. I just show you one slide. I'm just going little fast. These are some of the antibiotics which can only be reported by way of MIC. You cannot report these drugs by the way of DD. Little bit. Correct interpretation of incorrect reporting. When you have these Vitek reports, how many times we see the second and the third page of the Vitek report? There are a lot many things which the Vitek gives you. It's very easy to interpret because it tells you it is a ESBL CTXM type. Why? Because the cefotaxime is getting resistant. So what is interpretive reading is that if you have a Klebsiella which is resistant to ceftazidime but sensitive to ceftriaxone, what the normal microbiologist will do? He will report everything as resistant. He will report everything as intermediate. But the Vitek will change the report. It will change the report. It will tell you, because it is cefotaxime resistant, to please, it is a ESBL CTXM type, please check for ESBL. So this is what MIC, the breakpoint question. Now this is the last question, last slide for you. Which is the best drug? If a patient is on pneumonia, he's come to you, you have started this drug. Firstly, you started on cefepime, it was sensitive. Now this is the antibiotic report. Which drug you will choose? Which is the best drug? If you go by MIC, you see which is the best drug? Which is the best drug? Ciprofloxacin. MIC. Which is based on MIC. Lower the MIC, better is the. This is what you will choose, no? The best drug is the ciprofloxacin based on the BMQ quotient. Okay? So this is what I'm telling you. Please start using your Vitek instrument as closely. What you see is a lot of information. There is an interpretive reading. There is something called as AES, Advanced Expert System. It tells you a lot of things about that organism. With this, I just end up my lecture. I hope you understand the importance of blood cultures, the MIC, and the breakpoint. Thank you all.
I request Dr. G.U. Kavatia, sir, to give closing remarks.
Automation is a need of today, and it is definitely a extreme need of the coming year. એટલે all microbiologists have to update the knowledge of automation and upgrade the laboratory for the automation. Dr. Vikas have said so many things in the interpretation of the automation. Automation definitely gave the report, but with our knowledge, we have to interpret the result. Then and then it is clinically important. Thank you, Dr. Vikas, for your informative lecture. Thank you.
Thank you so much, sir. Now I request Dr. Seema ma'am to felicitate Dr. Vikas, sir. Thank you, ma'am. I request Dr. Kiran Patel, sir, to felicitate our chairpersons. Thank you so much. What a splendid session. We'll make a move.
डुगडुगी बाबा की जय.
Stop, Manisha. Stop embarrassing. Now, before proceeding to our another session, there is one important announcement for all of you. You all are invited to join the most awaited entertaining event at the last ceremony banquet held tonight. And tomorrow's, please make a note regarding that. The tomorrow's scientific program session is at HT Parekh Hall, that is on the first floor, not on this hall. And another thing, the QR code is, which is present in the scientific program, which is kept in your orange bag, and that has the venue code. You can reach the venue for the dinner from scanning that QR code. And let's proceed for the tea break. We will be expecting you within 15 minutes. Yes, sir, 1 minute.
વન્ડરફુલ બેન્ક્વેટ છે, બહુ જ સરસ એન્ટરટેનિંગ ઇવેન્ટ છે અને એના માટે પણ આપણી અમુક ફેકલ્ટીસે બહુ સરસ પ્રિપરેશન કરી છે. સો બધા બેન્ક્વેટમાં આવજો અને જેટલા પણ બહાર ઊભા છે તમારા ફ્રેન્ડ્સ એ બધાને પણ કહેજો કે બેન્ક્વેટમાં આવે. એમણે કીધું એ પ્રમાણે QR કોડ તમને એસેસ આ એડ્રેસનું એસેસ આપશે. સો એવરીવન ઇઝ ઇન્વાઇટેડ ટુ જોઈન દેટ. ટાઈમ 7 o'clock ઓનવર્ડ. અરે હજુ બધા પ્રોગ્રામ બાકી છે, અત્યારથી નથી જતા રહેવાનું. મિલનભાઈ બેસો બેસો, અત્યાર નથી જવાનું, 7 વાગ્યાનું છે. બેસો બેસો.
We are proceeding with the tea break, but we all gather within 15 minutes. It's okay for everyone as we have. Yes, because we have a very interesting panel discussion regarding the career prospects in the microbiology. Please make sure you will reach here within 15 minutes. So let's make a move. I request everyone to please join. In a while, we are going to start our next panel session, Career Prospects in Microbiology.
Many microbiology residents sitting here, they have a dilemma regarding their future career prospects.
Don't worry, our next session will answer all their queries.
Moving to our next panel discussion on career prospects in microbiology, I request Dr. Sanjay Rathod, moderator of the session, to join us. Dr. Sanjay Rathod sir is an associate professor at Department of Microbiology, Narendra Modi Medical College, Maninagar, Ahmedabad. He is dedicated to quality work and has been a lead assessor for NABL as well as an assessor for NABH. I invite our panelists, Dr. Mehul Panchal, Director Medical Services, Kiran Multispeciality Hospital, Surat. Dr. Neeraj Singh, Scientist, GBMR Institute. Dr. Sumita Soni, Associate Professor, BJ Medical College. Dr. Frenil Muneen, Consultant Microbiologist, Venus Hospital, Perfect Diagnostic, Soros Laboratory, Surat.
We request sir to start our panel session.
Good afternoon all. આ સેશન ઉર્વિશની ઈચ્છા હતી કે we'll put this particular session regarding the career prospects in microbiology. When we pass out as a batch, કમલેશે કીધું હતું ને, we are all from the same batch, almost 10 કે 11 જણા હતા માઇક્રોબાયોલોજીમાં. We at the time of, you can say 2002, 2003, we applied, suppose હું મારી વાત કરું તો I applied for almost 13-14 places. એક નાની જોબ હતી મારી જોડે ટાઈમે. We applied for 13-14 places. અને almost I was rejected from all the way, દરેક જગ્યાએ. કારણ કે શું એ માઇક્રોબાયોલોજીનું કામ એક તો હતું થોડું, we have very small work and that also work will taken care by the pathologist. કારણ કે હજી બહુ છે ને ક્લિયર કટ સેપરેશન થયું નહોતું from microbiology to the pathology. Over a period of time there are the few labs, private sectors માં બી કામ થઈ શકે. મારા જ અમુક કલીગે they decided કે ઓકે આવું બી થઈ શકે. તો after a long durations, જ્યારે એ ટાઈમે આપણને લોકોને કોઈ પૂછતું હતું ને કે આ તમે માઇક્રોબાયોલોજી કેમ લીધું, એ ટાઈમે એવું થાય આપણને, અરે યાર લીધું કેમ આપણે, જોબ તો છે નહીં આપણી જોડે અને કામ શું કરવાનું એમ. અને સી વેન વી ગો ઇન ટુ ધ પ્રાઇવેટ ને, પ્રાઇવેટમાં બી શું થાય ખબર કે કોઈને શું લાગે ખબર માઇક્રોબાયોલોજીની બ્રાન્ચની ઇમ્પ્રેશન શું હતી, તો ધીસ ન્યૂ રેસિડન્ટ્સ ડોન્ટ નો આ તો કે બીએસસી કરેલું છે કોઈ કોલેજમાંથી કે એમ. સી બીએસસી માઇક્રોબાયોલોજી, એમડી માઇક્રોબાયોલોજીનો ડિફરન્સ નહોતો ખબર, નોટ ફ્રોમ ધેર પર્સપેક્ટિવ. એટ ધ સેમ ટાઈમ એમડી માઇક્રોબાયોલોજી બી એટલું બધું ફૂલ્લી ઇવોલ્યુશનમાં નહોતું, બિકોઝ આર નોલેજ ઇઝ ઓલ્સો નોટ ધેટ મચ. અમે લોકો બી ઘણી વાર એવું થતું હતું કે વી આર નોટ એબલ ટુ કમ્પીટ. અમને બી એવું લાગતું હતું કે યાર કદાચ અમે લોકો આ લોકોને કમ્પીટ કરીશું કે નહીં. આઈ થિંક વેરી વેલ નો કે ધેર આર ધ ફ્યુ લેબ્સ ઇન અમદાવાદ કે જેની સાથે પ્રાઇવેટમાં કોમ્પિટિશન કરવું એટલું ઇઝી નહોતું. સો પ્રેક્ટિકલી સ્પીકિંગ ઇનિશિયલી તો આપણે ડૉક્ટર્સ જ નહોતા, વી આર એમએસસી. ગ્રેજ્યુઅલી people consider કે okay microbiology છે, there are the one particular branch in second MBBS, we require some teachers, so only one scope, whenever you pass out from the MD microbiology, we have to just think of only one thing કે ક્યાં કોઈ મેડિકલ કોલેજમાં આપણને જોબ મળી જાય, ક્યાંક we will settle down somewhere. This is the only option. Gradually over a period of next few years, we definitely evolve a lot of things, lot of new branches. During this particular career perspective discussions, we definitely discuss કે કઈ વસ્તુ નવી થઈ રહી છે. But one thing is very much sure, બહુ સ્લોલી ધીમે ધીમે ડેવલપ થતા હતા. વી આર જસ્ટ લાઈક નહીં આપણે પેલું હાઉસી રમીએ ને, હાઈલી અનલકી પીપલ કે 14-15 વાર નંબર સુધી આવે ને આપણો નંબર જ ના આવે, એના આગળ 15 આપણો નંબર પિકઅપ થાય. કે કોઈ કહે ને કે હાઈલી અનલકી પીપલ, તો એમાં બી આપણે ના થઈએ સિલેક્ટ. વી આર નોટ સિલેક્ટિંગ ધેટ વે. અને સડનલી એવું થયું કે આપણી જોડે ફૂલ હાઉસી લાગી ગઈ. દેટ ઇઝ ફર્સ્ટ કોવિડ આલ્ફા. સેકન્ડ હાઉસી બી આપણી જાય બીટામાં, એન્ડ થર્ડ હાઉસી ઓલ્સો દેટ ઇઝ ડેલ્ટા. સો ડાયરેક્ટલી microbiology jump. એટલે now everyone understand there are actually Urvesh અથવા તો ઘણા બધા માઇક્રોબાયોલોજીસ્ટ એવા હતા કે they have very good brand ambassador of this. I'm not કોઈ એક પર્ટિક્યુલર માણસ માટે હું પિનપોઇન્ટ નથી કરતો, but medical colleges also contribute a lot in microbiology. Now this particular talk is only focusing on the career perspective for the post MD microbiology. We not think of MSc, we not think in its full potential now. So for this particular career perspective, we have with me, there are the allied panelist people already. Hardik introduced to you people. Dr. Mehul, he is from the, see, we have a panelist. હું તમને એ રીતે સમજાવું કે panelists are from the different areas. Suppose Dr. Mehul is a microbiologist, but he is from the admin background, from the hospitals. Dr. Franil Munim, he is a purely hardcore microbiology. He is practicing the microbiology in Surat. Dr. Sumita Soni, she is working in the medical college, but at the same time, lot of other areas she is working on. Specifically, you can say antimicrobials or AMSP or all that particular HIC work. Dr. Neeraj Singh, he is from GBRC and the research analyst. Somehow, Dr. Sanjay Mehta was also there, but he is not able to join us. But આપણે compensate કરીશું આ ચાર લોકો જોડેથી સવાલો પૂછીને. So, start with the panel discussions. Question first. આપણે આ લોકોનો વાયવા જ લેવાનો હોય પ્યોરલી. ક્યારેક જ મને બી આવો મોકો મળે, સિનિયર લોકોનો હું વાયવા લઉં, તમને લોકોને બી મજા આવશે કે તમારા ટીચર્સનો વાયવા આજે થશે. ઓકે, સો માય ફર્સ્ટ ક્વેશ્ચન ઇઝ વિથ Pranil Muni, please. What are can you read this question? Okay, what are some of the emerging trends and advancements in the field of microbiology that will shape the career opportunities for professionals in futures? એટલે બેઝિકલી ક્વેશ્ચનનો મતલબ એ છે કે which are the further advancements that might help in your shape of the career, please?
I personally feel કે ક્લિનિકલ માઇક્રોબાયોલોજી ભણવું વધારે ઇમ્પોર્ટન્ટ છે. ગુજરાતી
અરે પ્લીઝ,
સો
આપણે શું ફરક પડે, તમે ટેન્શન ના લો.
ના એટલે ગુજરાતમાં જ છે તો થોડું ઘર જેવું લાગે. આપણે મારા હિસાબે ક્લિનિકલ માઇક્રોબાયોલોજીસ્ટ બની જાવ તો જ બહુ છે. બિકોઝ આપણે જે 3 વર્ષનો કોર્સમાં જે શીખીએ છીએ એના પછીની જે બહારની દુનિયા છે, મને મારા સાહેબે કીધેલું કે જો ભાઈ તું બહાર નીકળે ને, આઈ વોઝ વેરી મચ ક્લિયર કે મારે કોલેજમાં નથી જવું. અને મને કીધું કે તું બહાર જશે તો કોઈ તારી પાસે એમ કે થાળીમાં સજાવેલા લાખ રૂપિયા લઈને ઊભું નહીં હશે કે તને નોકરી મળી જાય. કીધું કે સર ફાઇન, નો પ્રોબ્લેમ. પણ ખરેખર હું જ્યારે બહાર ગયો અને પહેલી જોબ ઓફર થઈ, સો આઈ વોઝ ઓફર્ડ 50 રૂપીઝ પર સેમ્પલ એન્ડ આઈ ટુક દેટ જોબ. કે ભાઈ તમને 50 રૂપિયા પર સેમ્પલ મળે. અને એમાં બહુ સીધું, આઈ રિયલી રિસ્પેક્ટ દેટ પેથોલોજીસ્ટ. એ ટાઈમ પર કલ્ચરનો ભાવ હતો 600 રૂપિયા. અને હી વોઝ પ્રેક્ટિસિંગ, એટલે એ તો કોઈ પ્રેક્ટિસ નહીં કરતા હતા, ટેકનિશિયન કરી આપે ને એ રિપોર્ટ સાઇન કરતા હતા. એમણે મને કીધું જો મને કંઈ આવડતું નથી, તારે જે કરવું હોય તો તું કર. એટલે મેં કીધું કે સારું હું કરીશ. પણ કે હું તને 50 રૂપિયા આપીશ. એમ કે વસ્તુ સમજ, 40% તો મારે કટ આપવાનો અને બાકીનો બધો તને લાગે ખર્ચો, આ ટેકનિશિયન, આ ઇન્ક્યુબેટર બગડી ગયેલું, હમણાં જ થર્મોસ્ટેટ નખાયું એટલે ખર્ચો છે એમ કે તને 50 રૂપિયા આપીશ, થશે? મેં કીધું સારું સર પ્લીઝ કરવા દો. અને દેન આઈ સ્ટાર્ટેડ. સો માય જર્ની બિગેન. અને મેં એ રીતે જે લેબમાં કામ હતું ત્યાં કરવાનું ચાલુ કર્યું. એટલા માટે યુ કેન સી માય મલ્ટિપલ એસોસિએશન્સ. Now, after practicing for this 11 years, what I have realized કે there is a lot of scope. There is a lot of scope. પણ સ્ટાર્ટિંગનો રસ્તો બહુ અઘરો છે. I was not being paid that much. જે ફર્સ્ટ આસિસ્ટન્ટ પ્રોફેસરને પે કરવામાં આવે. સૌથી પહેલો સવાલ તો એ જ આવે ને કે ભાઈ બેઝિક પૈસો તો ઘરે આવે, કારણ કે નો બડી કન્સિડર્સ અસ એઝ અ ડૉક્ટર. પહેલાં તો કોલેજ સિવાય બહાર જાઓ તો. અને મેજર પ્રોબ્લેમ પેથોલોજિસ્ટ વિલ નેવર ગીવ યુ ધ સ્પેસ વોટ દે આર ઇન. તમને એ રીતનો પે સ્કેલ કોઈ પહેલી વારમાં ઓફર નહીં કરશે. પોસ્ટ કોવિડ ડેફિનેટલી સિનારીઓ હેઝ ચેન્જડ, બટ હજી બી થોટ બ્લોક તો ખરો. સો વોટ આઈ હેવ રિયલાઇઝડ કે અત્યારનો જે ટ્રેન્ડ છે, કમિંગ ટુ બેક ટુ ધ બેઝિક જે ક્વેશ્ચન છે એના માટે, I am seeing one very big opportunity in two fields. One is AMSP, એન્ટીમાઇક્રોબિયલ સ્ટુઅર્ડશિપનો તમે કોઈક કોર્સ કરીને આગળ વધો તો, અને બીજું એક છે HEOR, હેલ્થ ઇકોનોમિક્સ એન્ડ આઉટકમ રિસર્ચ. This is the field which I feel that post microbiology will definitely give an upper edge to a clinical microbiologist. તમે પછી એમાં એડમિનમાં રહીને પણ કામ કરી શકો અને લેબમાં રહીને પણ. So this is something which I feel that this can help the microbiologists who are budding microbiologists in near future.
Yeah, I'll just continue with Dr. Frenil કે સ્ટ્રગલની જે વાત કરે ને 50 રૂપિયા ને 25 રૂપિયા 100 રૂપિયા, એ એકચ્યુઅલી સ્ટ્રગલનો પીરિયડ વી સિનિયર બેચે ફેસ કરેલો છે. પણ રાઇટ નાઉ મને એવું લાગે કે એટલી બધી હાર્ડકોર સ્ટ્રગલ નથી, એટલે એટલું ટેન્શન ના કરતા. ખરેખર નથી. અને સી તમને રિયલિસ્ટિક ફિગર મળી રહી છે. ધીસ ઇઝ ધ બ્યુટી ઓફ ધીસ પર્ટિક્યુલર કોન્ફરન્સ કે ઓલ આર માઇક્રોબાયોલોજિસ્ટ. સો તમને ફિગર મળે કે આટલા રૂપિયા જ મળતા હતા આપણને. સો અત્યારે આ જો છે આપણે સો ભાવિનની વાત સાચી છે, પણ વીલ ડિસ્કસ દેટ પર્ટિક્યુલર પોઈન્ટ ઇન ધ નેક્સ્ટ ક્વેશ્ચન્સ. કે સપોઝ અહીંયા અમારી જોડે સપોઝ 50 સ્ટુડન્ટ્સ છે, તો 50 સ્ટુડન્ટને ઓફર થશે? ઇઝ નોટ પોસિબલ, એટ ઓલ નોટ પોસિબલ. તો યુ હેવ ટુ ડેવલપ સમથિંગ. તો તમારે શું ડેવલપ કરવું જોઈએ, શું કામ કરવું જોઈએ, વિલ ડિસ્કસ ઇન ધ નેક્સ્ટ ફ્યુ ક્વેશ્ચન્સ. સો સેકન્ડ ક્વેશ્ચન્સ I'll ask to Sumita. Can you give your inputs on the importance of interdisciplinary collaborations in microbiology careers, particularly in addressing the infectious disease outbreaks? આ એક બહુ કોમન છે. બે વસ્તુમાં છે ને માઇક્રોબાયોલોજીના લોકો લીધ લે. એક છે હેન્ડ હાઇજીન અને બીજું છે BMW, કે એ બી કચરાની વાત આવે ને એટલે કે માઇક્રોબાયોલોજી છે. નહીં સી હું NABH એસેસરમાં જાઉં ને તો એ લોકો બી મને કે સર તમે BMW જોઈ લેશો? મને એકલા ના આવડે, તમે લોકો કામ નહીં કરતા? યુ આર ઓલ્સો BMW હેન્ડલર છે. સી 2016ની ગાઈડલાઇનમાં શું લખ્યું છે? એની હેલ્થકેર વર્કર હુ ટેક કેર ઓફ બાયોમેડિકલ વેસ્ટ હી ઇઝ કન્સિડર એઝ અ બાયોમેડિકલ હેન્ડલર્સ. ને તો દરેક જણે ટેટનસની વેક્સિનેશન લેવી પડે, તો આપણને એકલા ના આપી રહ્યા. સો સેકન્ડ થિંગ ઇઝ ઇન્ફેક્શિયસ ડિસીઝ આઉટબ્રેક્સ. ધીસ ઇઝ અ વેરી કોમન. હવે થયું છે એવું ને કે માઇક્રોબાયોલોજીને વી બ્લેસિંગ ઇન ડિસગાઇઝ સોર્ટ ઓફ લાસ્ટ 10 years વી જસ્ટ તમે આમ રિકેપ કરો ને તો એટલા નંબર ઓફ વાયરસીસના આઉટબ્રેક્સ આવ્યા છે. અને એવરી ટાઈમ સમથિંગ ઇન્વોલ્વ ફ્રોમ ધ માઇક્રોબાયોલોજી, ચાંદીપુરા હોય કે એનીથિંગ, કંઈ બી હોય ને તો માઇક્રોબાયોલોજીનું સમથિંગ ઇઝ દેર. સો ધીસ ઇઝ રિગાર્ડિંગ ટુ સુમિતા કે ઇન્ફેક્શિયસ ડિસીઝ આઉટબ્રેક આવે અથવા તો ઇન્ટરડિસિપ્લિનરી કોલેબોરેશન્સ વિધિન ધ કોલેજીસ ઓર વિધિન ધ ઇન્સ્ટિટ્યૂટ, હાઉ માઇક્રોબાયોલોજી પ્લે ધેર રોલ, પ્લીઝ.
Good evening. All alert, had a very good tea. So, with the outbreaks, when we talk about, the branch which comes in the mind is PSM. So, what a microbiologist is supposed to do in an outbreak, because whenever we have been taught about outbreak, જ્યારે પણ આપણા કરિક્યુલમમાં જ્યારે પણ પાર્ક્સ ભણ્યા હતા ત્યારે આઉટબ્રેક ઇન્વેસ્ટિગેશન અને એનાલિસિસ બધું આપણને PSMની ચોપડીમાંથી થોડું થોડું ગોખીને અને એક્ઝામ આપી આવ્યા હતા. ત્યાં સુધી આ સીમિત હતું. Now comes the infectious diseases outbreak. So there is a big difference between the outbreak and the infectious diseases outbreak. હવે જ્યારે એક માઇક્રોબાયોલોજિસ્ટ બીજા બધા ઇન્ટરડિસિપ્લિનરી લોકો જોડે વાતચીત કરતું હોય ત્યારે એ લોકોએ ખાસ ધ્યાન એ રાખવાનું, કારણ કે જ્યારે વેપ ઓફ અ one single CRE which was discussed in the morning, બરાબર, એની ડિસ્કશન થાય. ક્લિનિશિયનને એના પેશન્ટોની ચિંતા હોય અને બીજું પણ એમને એ ટેન્શન હોય કે આ હવે કંઈ પણ થશે તો આને હવે બીજાના માથે ઢોળવું કઈ રીતે, બરાબર. તો એ ઢોળ વિદ્યામાં એ શું કરે કે જસ્ટ ટુ શ્રગ ધેર રિસ્પોન્સિબિલિટી દે વિલ ટ્રાય ટુ ફાઇન્ડ આઉટ સમથિંગ અને એકદમ બ્લા બ્લા કરીને અને મોટું લાઈક ઇન અ મેડિકલ કોલેજ હોસ્પિટલ કંઈક પણ આવું નાની મોટી પેલી થાય, આમ ઇન્ફેક્શન કંટ્રોલ કમિટીની મીટિંગ રોજ કહીએ કે ભાઈ બોલાવી લો મહિને, પણ ના બોલાવે ને અચાનક આઉટબ્રેક આવે, 2 PM MS ઓફિસ મીટિંગ ઇઝ ધેર. ઓકે, સો દેટ ઇઝ હાઉ we are being placed. Main purpose of this outbreak investigation is the diagnostic stewardship, wherein we have to first isolate what are the type of the organism till the phenotypic and the genotypic level. બરાબર જ્યાં સુધી આપણે એ કામ નહીં કરીએ ત્યાં સુધી પહેલા તો શું કહેવાય આઈડેન્ટિફિકેશન ઓફ ધ ઓર્ગેનિઝમ નહીં થાય. ઓર્ગેનિઝમ આઇસોલેટ આઈડેન્ટિફાઈ અને એન્ટીમાઇક્રોબિયલ સસેપ્ટેબિલિટી ટેસ્ટિંગ. સેકન્ડ સ્ટેપ ના આવે, એ લોકો એમના પેશન્ટને ગમે તેટલું ટ્રાય કરે, they won't be able to treat them appropriately. The second aspect of the outbreak investigation is the participation of the infection control team. Okay, so infection prevention and control practices will also become a part of the outbreak investigation. અને આપણે ગમે તેટલું આ ઝંડો લઈને ફરીએ, બરાબર, બાયોમેડિકલ વેસ્ટ સિવાય કે ભાઈ લાલ લીલા પીળા ડબલામાં શું નાખ્યું ને શું કર્યું, એટલે આ સિવાય એ લોકોને શું કહેવાય કે એમને એમ જ થાય કે આ લોકો કાં બાયોમેડિકલમાંથી કંઈક કાઢશે અને નહીંતર પછી એન્વાયરમેન્ટલ સેમ્પલ, બરાબર, CDC, WHO ગમે તેટલા રોદના રડશે, બટ દે વિલ ટેલ कि नहीं नहीं भाई हमको तो लग रहा है कि ये सारे जो भी आपके स्टराइल आइटम्स हैं उसके अंदर हमें तो कुछ क्वेरी लग रही है. डू द एनवायरमेंटल सैंपल, डू वॉट एवर यू वॉन्ट, वी वॉन्ट टू सेव आवर पेशेंट. हियर comes the role of the microbiologist to tell them that the standard case definition, that the linkages of the case, that the good infection control practices are mandatorily important to deal with an outbreak. It is an interdisciplinary approach. It is not at all the sole responsibility of a microbiologist. First and foremost responsibility comes of the the healthcare professional who are giving direct care to the patient. That is the thing we need to. In the morning only, I love the sentence of Dr. Bhavini, communicate, communicate and communicate. So we need to put in our voice to say that microbiologist will only aid in the diagnosis. You have to treat your patient. You have to cure your patient. You have to break the chain of transmission. And then only you will be able to deal with the outbreak. And that we have shown dealing with not only the outbreak, the pandemic itself, that is the COVID-19 pandemic. Yeah. I think I have given the answer.
Yeah. She continue with Dr. Sumida. She said that it's a interdisciplinary it's a team approach whenever there is an outbreak or whenever there is a team of the HIC meeting. But I just convey one specific message. Slide तो बराबर है कि ये लोग अपने यहाँ समझे कि आपने हाथ धोवा मटा आए जे. But actually you have to develop the authority. You have to develop the authority कि clinicians तुम्हारी बात सांभळे, एमने हम कोई नहीं सांभळे. मतलब I'm not saying कि they are not interested in you, but they are just focus on the patient and if you can help them in that situations. તમે અગર કંઈ વેલ્યુ ઇનપુટ્સ આપશો રિગાર્ડિંગ ધ ટ્રીટમેન્ટ પ્રોટોકોલ્સ, ઇફ યુ ગીવ સમ વેલ્યુ ઇનપુટ્સ રિગાર્ડિંગ વેન યુ ટેક અ રાઉન્ડ ઇન HICs, see lot of engineering controls are available. Lot of engineering. Being an NABH assessor, ધીમે ધીમે ખબર પડી અચ્છા HVAC સિસ્ટમ હોય, this is high ventilations વાળી, these are the different AHUs has to be there from different ICUs. The pressure rooms હોય, that is in the operation theatres, there are the negative pressure rooms from transplant units હોય. These are lot of engineering controls are available. જ્યારે બી HSC ની મીટિંગમાં જઈએ ને, મારો એવો એક્સપિરિયન્સ છે તો 80% કેસીસમાં તમે લોકો ઇન્ફ્રાસ્ટ્રક્ચરની ચર્ચા કરીએ. વી ડિસ્કસ ઓન ઓનલી ઇન્ફ્રાસ્ટ્રક્ચર્સ કે અહીંયા એરિયામાં ધીસ ફ્લો ઇઝ નોટ ઓકે, હિયર દેટ પર્ટિક્યુલર કન્ડમ મટીરિયલ ઇઝ નોટ અવેલેબલ, ઓર હિયર સી આપણે ઓલ ધીસ ડિસ્કશન્સ ઓલ કોર હાર્ડકોર માઇક્રોબાયોલોજી નથી આવતું, બટ દેટ ડઝન્ટ મીન કે એ માઇક્રોબાયોલોજીનો પાર્ટ નથી. Don't take it in that way. You have to develop the skills to learn all about all these things. Then and then you become a value added member in your HSC team or your outbreak team. Otherwise તો આપણે એ ડેવલપ જ નહીં કરી શકીએ. Neeraj sir, this question for you. How do you see the future of microbiology careers evolving in response to molecular testing innovations such as CRISPR, Cas9 gene? मैं આ ક્યાંક વર્ડ સાંભળી લીધો ને પછી લખી કાઢ્યો है.
Thank you very much.
But he is from GBRC and exclusively work on the genetic editing. એટલે
Thank you. So first of all, I congratulate all the participants, coming from the microbiology background. So I think, the microbiologist or the person sitting in front of us is the only person who can understand the human physiology as well as the microbiology, right? So certainly a big round of applause for them. So if we talk about the, microbes, we all know that less than 1% microorganisms we know and characterize till now. So 99% is not characterized at all, right? And the researchers working on the human physiology or, the human gut, so they are having data and they are saying more than the number of cells we are having, number of microbes are there in our body, and those microbes will actually decide the physiology, right? So this is very surprising for us. And if you go through the recent literatures, so you will find many more proofs of that. So really, less of the human physiology, but more of the microbiology, or more of the microorganisms which is there inside us is really deciding the physiology of the human being or the animals. And if we talk about the research and the research scopes for the, the young researchers sitting in front of us, it's a very huge, very, very, big opportunities for the MD microbiologists are there in the research. Unfortunately, very, very less number of doctors, medical doctors, I can say, are coming in the research. And that is, very pathetic situation for us actually. Because the basic scientists, they are not able to understand the human physiology, right? That is the very big hurdle. So you are the people, you should come into the research and you can do wonders, really, I'm telling you.
Just sir, for in one or two sentences, can you describe what actually you are doing so that they can have a very good idea? Actually,
Yeah, certainly.
What's your
See, if I'm talking about the recent research, like CRISPR-Cas9, sir, is written here. So, by these technologies, you can, tailor-made the organisms. You can tailor-made the, the diagnostic kits. And that would be very, very rapid, very, very cost-effective. And, many a times, by use of this CRISPR-Cas9 and the other molecular techniques, you can multiplex the things. Means in a single reaction, you can detect more than, dozens of the pathogen in a single PCR reaction, right? Recently, the technologies come into that extent that by just putting the microbes into the machine or the facility, you will come to know the microorganisms which are, AMR or which are not AMR, or, what are the different characteristics or like that. We can, here as a researcher, we have a great opportunity and we have a great, facility now in India that we can set up many more things. COVID pandemic is one thing, but you can now go beyond the COVID pandemic actually. So whatever emerging diseases are there, so microbiologists are the person who can actually design, study and research to predict the upcoming pandemic situation. Like GBRC, Gujarat Biotechnology Research Center, we developed during the pandemic, early warning system for the COVID. At least 14 days early, we can very well predict when the COVID peak will come just by, researching onto the waste waters actually. So for young researchers, very, very good opportunity to come into the molecular field, molecular biology. And, certainly you will enjoy this field, and very, very huge opportunity of employment is there. Not only in the government sector or not only the private sectors, you can, start your ventures as well. Very, very big opportunities.
Yeah. I just continue with the sir. Suppose a long back I visited NICED, that is National Institute of Cholera and Antic Disease, Kolkata. So we'll discuss with the interaction with the scientists. No, there are a good number of scientists are also available. They say, कि, sir, आप क्या करते हैं cholera में? Because we have some cholera samples we'll send to the NICED. No? So हमने तो sir we isolate, culture कर लेते हैं. That's it. ज़्यादा से ज़्यादा हमारे पास एंटीसीरा होता है, फिर एंटीसीरा से कंफर्म करते हैं होगा वही ना वॉट एवर, बस दैट्स ओके, हाँ इतना ही करते हैं, ओके सर दिस इज नॉट इनफ ना, वी हैव टू गो फॉर द फास्ट टैपिंग. वहाँ पे उस टाइम पे बासुन मुखर्जी का फास्ट टैपिंग था, नाउ दे हैव डेवलप अनदर फास्ट टैपिंग टेक्निक्स, बट एट दैट टाइम सर देन वी गो फॉर द राइबो टैपिंग में. क्यों ये सब क्यों कर रहे हैं, मतलब क्यों कर रहे हो यार ये सब, तो क्या सर एग्जैक्ट ज्योग्राफी और एग्जैक्ट स्ट्रेंज फ्रॉम वेयर इट एक्चुअली ओरिजिनेटेड उसका ट्रैकिंग नहीं मिलेगा तो कैसे करेंगे. सो उस टाइम पे आई जस्ट फ्लैश दैट आइडिया कि सपोज समवन इज इंटरेस्टेड कि यार यू आर नॉट सेटिस्फाइड विथ जस्ट आइसोलेशन, इफ यू आर इंटरेस्टेड कि नहीं यार मुझे इसका पूरा बायोडाटा चेक करना है यार, मतलब इज नॉट अ कार्बापेनम रेजिस्टेंट हमें आइडेंटिफाई नहीं करना है, ये जीन्स का पूरा कच्चा चिट्टा ढूंढना है कि कहाँ से आया है, फ्रॉम वेयर इट हैज बीन ट्रांसफर्ड, सी ऑल दिस एपिडेमियोलॉजी, then this is a very good field. So
Just I'm giving one
definitely.
example here. So as madam said, madam is working on the AMR and we are having very good, collaboration. So, many antibiotic resistant organisms, they are giving very good, AMR positive, but they are not having the genes actually. And many organisms, those are having the genes, but they are, antibiotic sensitive. So these are the things where, great, scope and opportunities for the researchers are there.
Yeah.
To add on, this is, I think, in the country, it is of one of its own kind of, the collaboration going on, which is called as human health, the One Health approach for this AMR. So herein it is not only because we are, limited to our fields, we think of only the bacteria or the viruses or whatever it is inside the human body. It is talking about, it is collaboration of the animal sector, the environmental sector and the human. It's a tripartite collaboration and it is the only, in the country, it is the only MR program wherein, we are having a sequencing node, wherein the whole genome sequencing with the help of the GBRC is being done. Whatever the number of the isolate you submit it to them, if they are, XDR, PanDR, or they are of the medium priority, they will put all those isolate for the sequencing, and it's one of the greatest collaboration. Only thing is that we need to sit together the way we were talking about the outbreak investigation. Herein the genotyping and linkages of outbreak investigation is quite possible when we are doing these type of activities. So this is the AMR surveillance network and it is country's own kind. So I thank Government of Gujarat and Department of Science and Technology for giving us this opportunity.
We'll back to topic. ટેન્શન ના કરો, આપણે આટલું નથી કરવાનું. જસ્ટ ફોકસ આપણે આઇસોલેટ કરીને છોડી દઈશું, ઓકે? કારણ કે બીકોઝ માઇક્રો ઓર્ગેનિઝમ્સ આપણા માટે શું વિચારે? કેન સે વી આર પાપારાઝી, આપણે એને ફોલો કરે રાખીએ. વી જસ્ટ ટ્રેક ધીસ ઓર્ગેનિઝમ્સ. Okay, next question with Mehul bhai. What are some of the key important points to be considered if an individual wants to change role from an academic positions to a role in private hospitals or vice versa? मतलब बोर थी जे थाकी जे કે માઇક્રોલોજી કામ નહીં કરવું. મારા મગજમાં એવી ઇમ્પ્રેશન છે કે એડમિનમાં જઈએ એટલે કામ ના કરવું પડે. માઇક્રોબાયોલોજીમાં બહુ કામ છે આપણી જોડે. કોવિડમાં આ લોકો બહુ કરાવ્યું આપણી જોડે, એડમિનમાં ના આવે. બટ ઇન અ લાઇટર નોટ, બટ સપોઝ સમવન ફ્રોમ અ માઇક્રોબાયોલોજી વોન્ટ ટુ બી અ પાર્ટ ઓફ ધ એડમિનિસ્ટ્રેટિવ ઓર વાઇસ વર્સા, સમ એડમિનિસ્ટ્રેટિવ પાર્ટ માઇટ બી ધ હેડ ઓફ ધ યુનિટ ઓફ યોર ઇન કેસ સેન્ટ્રલ લેબ, એવું કંઈ થઈ શકે સર? મેહુલભાઈ પ્લીઝ તમારી ક્વિક સ્લાઇડ તમે મને આમાં તમારું કન્ટિન્યુ થાય પહેલાં એક કીધું જો આવું લોકો બોલે આપણા માટે. It's not administrative staff, it's administrative staff.
I'll say in a simple way કે પહેલાં એટલું આપણે સમજવાનું કે આપણે મેડિકલ સાયન્સમાં છે. મેડિકલ સાયન્સમાં એટલે કે આપણે બધાએ MBBS કરેલું છે. એનાટોમીથી લઈને ફાર્મેકોલોજીથી લઈને આપણને ફોરેન્સિક સાયન્સ પણ આપણને આવડે છે. દેટ ઇઝ ધ મોસ્ટ ઇમ્પોર્ટન્ટ થિંગ્સ. કારણ કે આપણો જ કલીગ આપણી જોડે જ બેઠો છે અને આપણને કોઈ ક્વેશ્ચન્સ પૂછે છે અને આપણને આન્સર ના ખબર હોય તો એ ચાલે નહીં. આપણે એના કોઈ પણ આન્સર્સમાં થોડી ઘણી વેલ્યુ એડિશન્સ કરવી પડે. આઈ જસ્ટ સે કે અત્યારે હું કદાચ માઇક્રોબાયોલોજીસ્ટમાં એડમિન બન્યો છું, તો દેર આર 2 પર્સન્સ. એક જે કદાચ પિક્ચર નથી દેખાતું, દેટ ઇઝ અ રોબોટ કોક. he is a ID physician turn into a microbiologist. Why? Because he wants to search. મેડમે કીધું કે આઉટબ્રેક ઇન્વેસ્ટિગેશન્સ કરવાનું છે, એને પણ વિચાર આવ્યો કે મારે પણ આઉટબ્રેક ઇન્વેસ્ટિગેશન્સ કરવાનું છે, કે આ ટીબી આવ્યો ક્યાંથી, કેવી રીતે ફેલાય છે. રોબર્ટ કોકે સ્પુટમ કલેક્ટ કરી એન્ડ સ્ટાર્ટેડ ટુ ડુ અ એએફબી સ્ટ્રેન. અને કદાચ તમને હિસ્ટ્રીમાં ખ્યાલ જ હશે કે ગ્રામ સ્ટ્રેનની પહેલાં એએફબી સ્ટ્રેન આવી ગયો હતો. દેટ ઇઝ અ રિક્વાયરમેન્ટ ઓફ અ માઇક્રોબાયોલોજિસ્ટ. કારણ કે એ પહેલાં આઈડી ફિઝિશિયનમાંથી માઇક્રોબાયોલોજિસ્ટ કન્વર્ટ થયો અને પછીથી થયું. એન્ડ સેકન્ડ વન ઇઝ બ્રિગેડિયર ચોપરા સર. આઈ વિલ ગીવ અ વન ક્લુ. મીન્સ અત્યારે તો એ લેફ્ટનન્ટ જનરલ થઈ અને રિટાયર્ડ થઈ ચૂક્યા છે. બિફોર આઈ એન્ટર ઇન ટુ ધ એએફએમસી, જ્યારે અમારું કાઉન્સેલિંગ થતું હતું તે વખતે આઈ વોઝ સિટિંગ ઇન લાસ્ટ બેન્ચ અને કાઉન્સેલિંગમાં 1 by 1 કોલ આવતા હતા. દેર આર અરાઉન્ડ 5 seats વિચ આર ઓપન એટ દેટ ટાઈમ. અને મને પણ એક અંદરથી કીડો હતો કે આપણે ગુજરાતમાં શું ભણવું, ગુજરાતની બહાર જઈને જઈએ, આર્મીમાં જઈએ. તો મેં સરને પૂછ્યું કે સર હવે કઈ બ્રાન્ચ લેવાય, ઓફથેલ લેવાય, ગાયનેક લેવાય, પેથોલો લેવાય કે ટ્રાન્સફ્યુઝન લેવાય. કારણ કે ઇન ધ આર્મી બેકગ્રાઉન્ડ ઇટ્સ અ વેરી ઇમ્પોર્ટન્ટ થિંગ્સ ટુ નો કે ત્યાં ઇન્ટ્રાયુટ્રાઇન ટ્રાન્સફ્યુઝન પણ થતું હતું, તો ટ્રાન્સફ્યુઝન મેડિસિન ઇઝ ઓલ્સો ગુડ વન. ઓફથેલ પણ થતું હતું, તો દેટ ઇઝ ઓલ્સો ગુડ વન. તેમણે મને કીધું કે એક કામ કર, તું માઇક્રોબાયોલોજી લે. કીધું કેમ માઇક્રોબાયોલોજી? એની અંદર ખાસો બધો સ્કોપ છે. કીધું ઓકે સર. માઇક્રોબાયોલોજી લઈને આવ્યો. પછી મને ખબર પડી કે એ અમારી જ કોલેજના માઇક્રોબાયોલોજીના ડાયરેક્ટર હતા. તો આઈ થોટ કે સરે તો હવે ડબ્બામાં મને પૂરી દીધો, પણ શું કરીએ. બટ સરે કીધું તું ચિંતા ના કર, તું બધું કરી લઈશ. અને પછી ધેન આઈ થોટ કે ઓકે ફાઇન, હવે શું કરીએ. દેર ઇઝ અ સેકન્ડ પર્સન હુ સેડ કે એક કામ કર, તું હવે છે ને આનંદ નારાયણ છોડ, એ તો તું મહિનામાં પતાવી દઈશ. તું એક કામ કર, હેરિસન ચાલુ કર અને બેન્ડલ ડગલાસ ચાલુ કર. વાય ધીસ આર મોર ઇમ્પોર્ટન્ટ થિંગ્સ. રિમેમ્બર વન થિંગ્સ. મેં તમને કીધું ને કે તમારા જ કલીગ તમને કશુંક પૂછે છે અને જ્યારે તમે કોઈ જાત નાનું આપણે વેલ્યુ એડિશન્સ નથી આપી શકતા ત્યારે એ તમને ડિટોરિએટ કરે છે અથવા તો ડિગ્રેડ કરે છે. જ્યારે તમે એમના એક ક્વેશ્ચન્સની આગળ તમે બીજા 2 ક્વેશ્ચન્સ પૂછશો તો ધેન દે વિલ વેલ્યુ યોર સેલ્ફ. આઈ એમ જસ્ટ ગિવિંગ વન એક્ઝામ્પલ. MRSA આવેલું છે, શું કરવાનું? એન્ટીબાયોટિક આપી દેવાની? ઓકે ફાઇન, વેન્કોમાઇસિન આપી દીધી, પણ એ તો લેબ રિપોર્ટમાં પણ લખેલું છે. વોટ એક્સ્ટ્રા યુ આર ગિવિંગ? યુ શુડ સે એક કામ કર, અને કાલે સર્જરીમાં જતા પહેલા ક્લોરેક્સિડિનથી નવડાઈ લેજે, તારું SSI ક્યારેય નહીં આવે. દેટ ઇઝ ધ મોસ્ટ ઇમ્પોર્ટન્ટ થિંગ્સ. આર વી ટોકિંગ અબાઉટ ધીસ થિંગ્સ? વી નેવર ટોક અબાઉટ થિંગ્સ. ઓકે, મ્યુપ્રોસિન ઓઇન્ટમેન્ટ કદાચ MRSA આવેલું છે બ્લડ કલ્ચરમાં, હી માઇટ બી અ કેરિયર ફોર MRSA. મ્યુપ્રોસિન ઓઇન્ટમેન્ટ લગાડી દે. બટ ડુ વન થિંગ, એક કામ કર, તું પહેલાં 1000 રૂપિયાનું મારી ત્યાં ટેસ્ટ કરાવી લે. આઈ વિલ ચેક કે મ્યુપ્રોસિન રેઝિસ્ટન્સ છે કે નથી. 1000 રૂપિયા પણ આવી ગયા. જેવું ફેરીલે કીધું ને કે અમારે તો 50 રૂપિયા પણ લેવા અઘરા પડતા હતા. સમટાઇમ્સ યુ હેવ ટુ ટ્રિક યોર કલીગ્સ. વાય ઇટ ઇઝ મોર ઇમ્પોર્ટન્ટ? મ્યુપ્રોસિન રેઝિસ્ટન્સ હશે, અગેન યુ આર ગોઈંગ ટુ હેવ અ ફેટ. તો એના કરતાં બેટર છે તમને તમારા કલીગ કરતાં વધારે નોલેજ હોવું જોઈએ, સ્પેસિફિકલી ઇન ધ ઇન્ફેક્શિયસ ડિસીઝ. વાય ઇટ ઇઝ મોર ઇમ્પોર્ટન્ટ? બિકોઝ યુ આર ડે ઇન એન્ડ ડે આઉટ યુ આર પ્લેઇંગ વિથ ધ માઇક્રોબ્સ. એને ખવડાવો છો, એને ગ્રો કરાવો છો, એને થોડીક એન્ટીબાયોટિક જોડે લડવા મોકલો છો અને પછી છેલ્લે એને ઓટોક્લેવમાં કરીને મારી નાખો છો. બટ યુ આર પ્લેઇંગ વિથ દેટ પર્ટિક્યુલર થિંગ્સ. આપણે કહીએ ને કે નાના છોકરા ધૂળમાં રમે, એવી રીતે તમે બેક્ટેરિયા જોડે રમો છો, એન્ટીબાયોટિક્સ જોડે રમો છો, બટ યુ હેવ ટુ પ્લે. અને તમને ખબર હોવી જોઈએ કે ક્યાંકડી કઈ વસ્તુ ઇમ્પોર્ટન્ટ છે. હવે આ તો વાત થઈ આપણી ક્લિનિકલ માઇક્રોબાયોલોજિસ્ટની. પછી નક્કી થયું કે હવે એક કામ કરીએ, હવે મેડિકલ કોલેજમાં તો નથી જવું, કારણ કે ભણાવતા તો આવડતું છે નહીં આપણને. છોકરાઓને ભણાવીશું તો ભાગી જશે.
મેહુલભાઈ આપણે થોડોક ટાઈમ શોર્ટ છે. વી હેવ ઓનલી
I'll just give it 2 minutes, sir.
Yeah, thanks.
So then you have to have a thinking about H. મેડમે કીધું ને કે આઉટબ્રેક થાય તો કોણ યાદ કરશે? સૌથી પહેલા માઇક્રોબાયોલોજિસ્ટને જ યાદ કરશે. So you supposed to have a HIC knowledge. સરે કીધું he is going to see and assess the lab. So NABH અને NABL નું પણ તમને નોલેજ હોવું જોઈએ. કોઈ પણ નવી હોસ્પિટલ બને છે, હોસ્પિટલ કમિશનિંગનું પણ તમને નોલેજ હોવું જોઈએ. હોસ્પિટલની અંદર જેવી રીતે ફાઇનલે કીધું કે હેલ્થ ઇકોનોમિક્સ ઇઝ ધ મોસ્ટ ઇમ્પોર્ટન્ટ થિંગ્સ. અત્યારે આપણે વાત કરીએ કે વોટ ઇઝ ધ રેવન્યુ પર પેશન્ટ્સ, એડમિટેડ પેશન્ટ્સ. તમારા 10,000 રૂપીસ આવે છે કે 50,000 આવે છે? સો ઓકે સર, પ્લીઝ પ્રીવિયસ સ્લાઇડ. સોરી. સો આ બધી વસ્તુનો તમને ખ્યાલ હોવો જોઈએ. યુ કેન ઓલ્સો ગો ઇન ટુ ધ પેશન્ટ સેફ્ટી, માર્કેટિંગ, ફાઇનાન્સ એન્ડ એડમિનિસ્ટ્રેટર્સ. સો આઈલ સે કે કોલેજની અંદર એક નાનકડું ટ્રાયંગલ છે અને હેલ્થ ઇન્ડસ્ટ્રીઝની અંદર મોટું ટ્રાયંગલ છે. તો યુ કેન ગો ઇન ટુ દેટ પર્ટિક્યુલર થિંગ્સ. એન્ડ રિમેમ્બર વન થિંગ્સ, કદાચ એવું લાગે કે આપણે બધું જ નોલેજ કરીએ છીએ અને કરીને આપણે એકદમ બાહુબલીની જેમ મસ્ત બની જઈએ છીએ. બટ રિમેમ્બર વન થિંગ્સ, તમારેથી ઊંચકાય એટલું જ ઊંચકજો. ઓકે, On a one side, it is too much a strengthened persons, and in the side face, you can see it's a too much burden on that particular things. That should not supposed to compromise your health. Sir, next slide, please. So, microbiologist can be anyone. એ કોઈ પણ વસ્તુ બની શકે છે. And remember one thing, they are the power source in the hospitals. Thank you, sir.
Yeah, thank you, Mehul. Sorry for interruption, Mehul, because we have to cut it down by now next 11 minutes. So next few questions, each questions will only allot 2 minutes so that we can at least આ લોકો ભાગી જાય પહેલા આપણે પતાવી દેવું પડે ને. Question 5, I'll ask it, Sumita. Can you discuss the importance of microbiology as a part of an antimicrobial stewardship? ઘણી બધી વાતો થઈ રહી છે stewardship પ્રોગ્રામની, and addressing the complex global challenges such as antimicrobial resistance. So WHO start કર્યું છે this initiative and how we contribute in that, please.
Okay, we are the pioneer in that. Without microbiology, a AMSP program cannot start. Nothing can start without a microbiologist or a microbiology lab. Because the source, it's all, the entire AMSP program runs towards the diagnostic stewardship. જ્યારે આપણે diagnostic stewardship કરીએ ત્યારે આપણે, we are giving a very good, in the morning also the talk were going on about the antibiograms. Okay, so depending upon your antibiogram, you will be deciding your hospital antimicrobial policy, that is empiric antimicrobial policy, and depending upon that, how it is being adhered, you need to check. And there is the crux, because a single microbiologist or a team of microbiologists may not be able to do or run a AMSP program in solo. So we need to, it is entirely a team approach. Herein we need to, put all our consultants into confidence that whatever we are doing is in the best of the patient benefit. Okay, so as a team, mostly in an AMSP team, intensivist or the infectious disease specialist, definitely value addition is being done by the microbiologist and the infection control nurses. Not lesser than that, we also need to have a very good knowledge. Sir told that we need to have a very good knowledge of the Harrison. We also need to have a very good knowledge of the pharmacology. Because, without that, a microbiologist cannot survive. In vivo, in vitro disparities cannot be sorted out. The MIC levels of the drug cannot be clearly discussed with the consultants. So these all we need to do. Running an AMSP project wherein we are, this is a very focused thing, wherein, with the diagnostic stewardship, you are going to know how your hospital is adhering to the antimicrobial policy. Okay, and that there you will need the infection control nurses, clinical pharmacists also into the picture. The key factor over there is the antimicrobial usage audit, which is also the part and parcel of the AMR containment program, and also how you are monitoring your restricted antimicrobial uses policy. So these all things we need to monitor. બહુ મોટું લાગશે, પણ દરેક વસ્તુ દરેક સ્ટેપ બહુ ચેલેન્જિંગ હોય છે. બટ જ્યારે તમે લેવલ ટુ લેવલ નાના લેવલના વ્યક્તિઓ જોડે જ્યારે આ બધી વસ્તુ ડિસ્કસ કરો, when your team is empowered, you are going to do that. This is how a microbiologist make a change in the system, and that systemic change will speak by decreasing the AMR into
Actually,
this.
she said that this is a very beautiful branch if your microbiologist is interested, particularly the AMSP. But mind you, I told you, compared to the lab work, AMSP માં સખત મજૂરી છે. સખત. Lot of data you have to compile outside your comfort zone. તમારે ડીલ કરવું પડશે ક્લિનિશિયન્સ જોડે, even from the pharmaceuticals people, infectious disease specialist. સાદી ભાષામાં તમારે એન્ટીબાયોટિક્સ કંટ્રોલ કરવાની છે, પકડીને રાખવાની છે. And it's not easy. At the surgical side, or not easy. It's at the medicine side also, it's not easy. But if you can make a balance in that, so it's really a very, very beautiful branch. Newer spectrum has been opened for the microbiology people specifically. 6 questions. How can networking, mentorship, and professional development opportunities enhance the career advancement and success for microbiology. Specifically, I asked Dr. Frenil for this at different stages of their careers, especially the HSC knowledge. See, microbiology બહુ બધા નાના નાના divisions થઈ ગયા, just like the pathology. There are the one part is specifically for these particular questions, HSC. HSC knowledge તમને rest of life તમારી career develop કરી શકે? Please.
Definitely, sir. It can help you a lot. But in a matter, as we already discussed, we have to communicate. So if you will start talking with the clinicians, they'll also realize that there is one person who is ready to help me in the management of the patient. So they will develop a trust in us. Okay, let me go to this person. He'll help me in this case. So that way you can, you can make contacts, and then you can gradually win that trust. And definitely, if your management is good, and HIC is something like which is actually stressed upon microbiologists whenever there is NABH inspection. This is something which we have not learned in a textbook or something, which we learn gradually with our practices and do through some courses and all. So yes, you can grow in that area, and there now it's not only HIC, but HIC, AMSP, diagnostic stewardship, they all go in hand, and ultimately it all comes to healthcare economics and outcome research. So I personally feel that healthcare economics and outcome research is at the center. Above is the HIC, AMSP, and diagnostic stewardship. These all come together, and this triangle is very important.
અમે લોકો બિંગ એસોસિએશન અમે લોકો ટ્રાય કરીએ કે આ વર્ષમાં એકાદ એસએસસીનું કંઈક વર્કશોપ કે હેન્ડ્સ ઓન CME રાખીએ. જે લોકો પાસ આઉટ થઈ જશે રહી જશે, પણ એ સિવાયના જેટલા બી સ્ટુડન્ટ્સ વિલ ટ્રાય કે હવે એસોસિએશન બની ગયું છે તો વિલ ડુ સમથિંગ. પણ ફ્રેન્ડ સરે કીધું ને, દેટ ઇઝ વેરી ઇમ્પોર્ટન્ટ કે HIC ટીમમાં યુ હેવ ટુ મેક એ બેલેન્સ, કે તમારે ક્લિનિશિયન્સ જોડે બાકી દોસ્તી કરવી પડે તો જ એ આપણા માટે આવું બોલે. ઓકે યાર, દે આર વેલ કલ્ચર્ડ. નહીતર અગર આપણા માટે સારું બોલશે ને તો આપણી વાતો સાંભળશે, નહીં તો સાંભળશે જ નહીં. નીરજ સર, I will give you only 1 minute, sir, please. Sorry. Can you share your inputs regarding specifically the role of a microbiologist in government health programs or any of the NCDCs or the ICMRs or WHO or CDC? Anywhere work apart from the teaching institute. See, we are in a comfort zone right now. હવે બધા એટલે મતલબ including me. Outside of these comfort zones, કંઈક સારું વધારે બેટર થઈ શકે આમાં, please, sir.
Yeah, many scopes are there. See, as madam was saying, the AMR program is going on, right? So this AMR program is there on the state. Actually, Gujarat state is running this program. Apart from that, much more scope is there throughout the pan India. And apart from the academic post, you can certainly come into the research, right? So you will find many more scopes, and number of scopes are there, research scope, and you can develop many more things actually. So ultimately, I request all the microbiologists here to, explore much what you can do in the microbiology. So at least you can spare half a day to visit the GBRC. Right? At least you see the facility and how you can use those facility to do research, right? So certainly you will get a great exposure. So I request all of you
to
come
રિક્વેસ્ટ
to
કરું છું
the
તમને બધાને, જેમ નહીં હોતું ડૉક્ટરના છોકરા ડૉક્ટર ના બને, તો આઈ સજેસ્ટ કે ટીચરના છોકરા તમે બધા બી ટીચર ના બનતા.
Certainly, you should be
do something
researcher.
different. અમારા કરતા કંઈક અલગ કરજો.
Thank you.
Yeah. Last 2 questions quickly. Panel sir, last question for you. Share your opinion regarding specialist. मतलब suppose सिर्फ exclusively see medical college में हमारे माटे possible नहीं कि we only work on the mycology. But in the private sector or anywhere, if you work as only a mycologist or tuberculosis specialist or you can say molecular biologist, तो scope है. They can do something.
Individually, sir, it is a long way to go, but we have to do everything. As of now, you have to manage everything because I feel કે અત્યારે ટેકનિકલી જોવા જઈએ તો 100% સેમ્પલો આવવા જોઈએ, એની જગ્યાએ ખાલી 10% સેમ્પલ જ આવે. 90% હજી પણ લખવાનું ચાલુ નથી કર્યું. So we say that there is an improvement in sending the samples.
Suppose histopathology માં there are specifically there are the renal biopsy specialist available છે, કે head biopsy specialist are available છે. So microbiology is evolving, તો એવું બને over a period of time.
Over the period of time, definitely, sir, there will be. But હજી તો clinical microbiologist field માં બહુ ઓછા છે, sir. We need them.
Last question, Mehul sir, for you. What advice will you give to the students and early career professionals, all of our students aspiring to the pursue rewarding and impactful careers in microbiology?
Microbiology.
કઈ
Okay, fine.
ટેકો મેસેજ તમારે આપવો એ?
Simple thing. Set a goal, fulfill. Once again, set a goal and fulfill it. Microbiology એટલે ખાલી MD microbiology નથી. I'll just give a certain list of qualifications કે જે હજી પણ ઓપનલી અવેલેબલ છે. એવું નથી કે એનામાં પણ સેચ્યુરેટ થયેલું છે. ઇન્ફેક્શિયસ ડિસીઝ સર્ટિફિકેટ કોર્સ, SGPGI, PDCC, SGPGI, DMID available in the India, FRC batch, DABMM, FCCM, PhDs. There is also people who are doing a double PhDs. NABL માં પણ important role છે. Specifically when we are talking into the NABL hospitals and healthcare careers માં HIC, NABH, JCI have a knowledge, fulfill it and once again set it. જો આ બધા knowledge હશે, તમે સારા માઇક્રોબાયોલોજીસ્ટ પણ બની શકશો, સારા ઇન્ફેક્શન કંટ્રોલ પર્સન પણ બની શકશો. સરે કીધું કે માઇકોબેક્ટેરિયોલોજિસ્ટ, માઇકોલોજિસ્ટ, HIC સ્પેશિયાલિસ્ટ ડેફિનેટલી બની શકશો. અને જો બધાનું સારું મિશ્રણ થયું તો સારા એડમિન, સ્ટ્રેટેજિસ્ટ, ફાઇનાન્સ પણ બની શકશો. આઈ ગીવ વન એક્ઝામ્પલ. અત્યારે ગુજરાતમાં 4 મેડિકલ એડમિનિસ્ટ્રેટર છે કે જે માઇક્રોબાયોલોજિસ્ટ છે, અપાર્ટ ફ્રોમ અ ગવર્મેન્ટ સેક્ટર. વન ઇઝ ગરિમા સાવલિયા, KD હોસ્પિટલ. ડોક્ટર સાજન નાયર, ઝાયડસ હોસ્પિટલ. ડોક્ટર પાટણકર, સ્ટર્લિંગ ગ્રુપ્સ, બરોડા.
ડોક્ટર મેહુલ પંચાલ.
Mehul Panchal, Kiran Hospitals. And if you go about in India, there are many more are available. Specifically, if you see the Bridge Candy, if you see Just Look, if you see any good hospitals, there are microbiologists who are having a key hospital administrative jobs. Thank you.
This for me. Okay. We are happy. now તો સેટલ થઈ ગયા છે. Already over. Thank you. Anyone want to ask? Panelist છે આપણી જોડે. કોઈ કેરિયર માટે કોઈને કંઈ ક્વેશ્ચન્સ કરવો હોય? Anyone?
Okay.
Sir, I'll tell you one thing. એવું નથી કે માઇક્રોબાયોલોજીનો દસકો નથી આવતો. તમે એપિડેમિયોલોજી દેખશો ને તો દર 10 વર્ષે એક આઉટબ્રેક આવે છે અને માઇક્રોબાયોલોજીને બૂસ્ટ મળે છે.
Check. મારે ક્વેશ્ચન છે. And biggest outbreak which is awaiting is the AMR actually. This is called slow pandemic.
ઘણા બધા ડોક્ટરો શું કહેવાય કે પ્રોફેશનલ ઇન્ડેમનિટી કવર લેતા હોય છે ઇન્સ્યોરન્સ, પર્ટિક્યુલરલી સર્જન છે, એનેસ્થેટિસ્ટ છે, ઓપ્થેલ્મોલોજિસ્ટ છે. તો માઇક્રોબાયોલોજિસ્ટે આ કવરેજ લેવું જોઈએ, જેમ કે ઇન્ડિયન મેડિકલ એસોસિએશન PPS સ્કીમ ચલાવે છે, પ્રોફેશનલ પ્રોટેક્શન સ્કીમ. તો આપણા માટે જરૂરી છે અને લેવું જોઈએ કે ના લેવું જોઈએ? કોઈ કેસીસ થવાની શક્યતા છે ફ્યુચરમાં?
સર, ડેફિનેટલી લેવું જોઈએ. HIV देखिए કે એની એન્ટીબાયોટિક સ્ટીવર્ડશિપ્સ देखिए. કાલે ઉઠીને ફિઝિશિયન્સ કહેશે કે તમારો કલ્ચરના રિપોર્ટથી મેં મેડિસિન્સ આપી છે, કદાચ બેકગ્રાઉન્ડ વેરિફિકેશન્સ થાય, કલ્ચર તમે કેમ મોકલ્યું નહીં, કેમ રેફરલ સેન્ટર પર નથી મોકલ્યું, તમારા લાયસન્સ પર સવાલ છે. સિમ્પલ થિંગ્સ. એટલે તમારે ઇન્ડેમનિટી લેવું જરૂરી છે.
રિવર્સ લે. એકચ્યુઅલી ઓલ ઇન્ડસ્ટ્રી ઇઝ ડ્રીવન બાય ધ ઇન્સ્યોરન્સ કંપનીઝ. એટલે ગ્રેજ્યુઅલી એવું બને ને કે એન્ટીબાયોટિક્સનું સપોઝ જે બિલિંગ આવે ને, એ બિલિંગ ઇન્સ્યોરન્સવાળા અગર રિજેક્ટ કરી દે, અગર તમારું કોઈ જોડે કલ્ચર પોઝિટિવ રિપોર્ટ ન મળે. સી પ્રોફાઇલેક્ટિક એન્ટીબાયોટિક્સ અથવા તો નોન સ્પેસિફિક એન્ટીબાયોટિક્સનો કોર્સ તમે સ્ટાર્ટ કરશો અથવા તો કલ્ચર રિપોર્ટ નેગેટિવ આવે, બીજી કોઈ જગ્યાએ પોઝિટિવ આવે, તો ઇન દેટ સિચ્યુએશન ઓલ્સો વી લીગલી સમવેર વી બાઉન્ડ. ઇન દેટ સિચ્યુએશન્સ એવી આવશે. ઇન્સ્યોરન્સવાળા હવે સ્ટાર્ટ કર્યું છે ગ્રેજ્યુઅલી ધીમે ધીમે. they definitely will work on that કે એ લોકોને તો ગમે તે રીતે we have to target. now evidence based medicine જેમ ડેવલપ થતું જશે ને, એવિડન્સ આપવું જ પડશે.
એટલે it is advisable to take the PPS scheme or the indemnity cover.
Sir, definitely it's advisable.
એટલે કારણ કે હજુ આપણા માટે નવો જ એરિયા છે કે PPS પર્ટિક્યુલરલી માઇક્રોલોજિસ્ટ માટે કે મોટા ભાગના લોકોની જોડે નહીં જ હોય કદાચ.
Definitely we require it, sir.
Thank you very much.
Any more further questions? Okay. So I request Sanjay sir to felicitate our respectable panelist. I request Dr. Manish Patni sir to felicitate Sanjay sir. ज़्यादा भले दो.
Thank you very much, the moderator and the panelists. One more time, before concluding this, I'd like to make few announcements, rather repeat few announcements. Everybody is invited to join most awaited entertainment evening at the banquet hall tonight. Tomorrow's scientific program will be at H.T. Parekh Hall on the first floor. So please take a serious note of this thing. Here you will not find anything. Same premises, but not the same hall. Okay. And to conclude, on behalf of the organizing committee and the whole organization, I extend my sincere thanks to each and everyone for making this event a truly unforgettable experience so far. And your presence has graced this event in ways that we cannot even express in words. And for that, we are eternally grateful. Thank you all and see you all tomorrow. In 15 minutes, we are starting the general body meeting. 5 minutes. Okay, now it's because we are having constraint of time. In 5 minutes, we are starting. And the venue for that is Seminar Hall 1 on the ground floor. Seminar Hall 1 in the ground floor. Thank you.